Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія. Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія.
I Hello everybody. We welcome you in at this Saturday in our studio of Ukrainian Association of Reproductive Medicine in the International Symposium Theory and Practice of Human Reproduction. Please wake up, join us, be active. Today, a very interesting day is waiting for us. We look for your questions. I wish you all the best. Let us begin. It's my great pleasure to give the floor to the facilitator of the first section, Professor Svetlana Zhuk. Please, Svetlana. Thank you, Alexander Mikhailovich. I also want to welcome all of you who are already waken up, who drinks their coffee and hopefully listens to us. Dear colleagues, I am today with you. There was a proposal for the specialty of obstetrician gynecologist 140101 to rename it obstetrician gynecologist and reproductologist. I believe we have been together earlier, and now this new name will unite us more in the scientific sense. So let's start our work. It's my great pleasure to give the floor to our guest from Spain, medical director of Reproduction Center Bilbao, Mr. Gorka Barentsy. The topic of his presentation is ovarian stimulation in assisted reproduction, myths, legends, and reality. Please, Professor.
Yes.
Okay, good morning everybody again, and first of all I wish to thank your camp presentation, and I want to thank Ellen Richter for the opportunity to share with all of you this scientific session and to take part in this important meeting. This is my disclosure statement. This is the organization, both public and private, with which I have collaborated in the past. Well, we are going to talk about ovarian stimulation as a key step, an inherent part of a full IRT process. The availability of a number of mature oocytes suitable for IVF improves the likelihood of achieving fertilization, generating good quality embryos, and finally to have a successful pregnancy. And actually, we deal with three different types of patients. The classical patient couples with fertility problems after diagnostic workup represent actually most of our patients, but a lot of cycles are nowadays performed among young egg donors. The objective of these young patients is not to achieve a pregnancy and to deliver a child, so they are not willing to cope with difficult and stressing treatments. And finally, an increasing number of healthy women ask for oocyte preservation. All of them share part of the treatment: ovarian stimulation, ovulation induction, and egg retrieval procedures. And I come from Spain, as you said before, the first country in number of cycles in Europe, the third in the world. And every day, more than 200 ovarian stimulations are started in Spain. So we're talking about hundreds of thousands of cycles, many treatments, many ovarian stimulations. Well, all of our work is based or should be based on three pillars, three mainstays: scientific evidence, our clinical experience, and we always have to take into account our patients' preferences. And all of these elements have changed. The scientific evidence is not the same today as it was 20, 30 years ago. Our experience has increased, and our patients are in some way different from the ones 20 years ago. Then they had to overcome infertility anyhow, and nowadays they are seeking a normal pregnancy, a normal baby, as soon and as easy as possible. The first question we must ask ourselves is why we do what we do nowadays. And this is the first question of associated next questions will come later on. And let's try to to have a rethink of the process to change ovarian stimulation, making protocols more effective and taking into account how the interests of our patients. As it was said by one of the pioneers of our medical field, a pioneer that you know, or everybody knows. First of all, we should ask, which is actually the objective, the aim of a IR procedure. The objective is to accomplish a pregnancy as easy, as soon, as normal as possible. Easy. Women in the 21st century are not the same as those in the past century. They do not have time to waste. Soon. I don't mean soon just in chronological terms, but in terms of treatment attempts. They want one attempt, one success. A normal. We cannot assume nowadays that a multiple pregnancy, for example, is a normal pregnancy, or it is an unavoidable fate. Multiple pregnancy is a side effect that we have to avoid, if possible. Well, next question. Which is the objective of the ovarian stimulation itself? I think that everybody will agree with this answer. To achieve an adequate number of oocytes to accomplish a pregnancy. It's a very easy answer. The key question is to define adequate. How many oocytes are needed to achieve a full pregnancy? Well, it depends on many factors. But if we take data from the National Registry of Spanish Fertility Society as an example, we need, taking into account both fresh and frozen embryo transfer, we need some 14 oocytes to achieve a full-term pregnancy. In donor treatments, when egg donors are used, we need some 11 oocytes to achieve a pregnancy. So we have different types of patients that we can roughly divide them into low and normal high responders. And the term adequate among low responders, I think that's quite easy to answer. Adequate number of oocytes means as many as possible. Well, different strategies have been proposed and assessed for the management of poor ovarian response. However, without a clear beneficial effect. These interventions attempt either to increase FSH levels or to increase the sensitivity of the developing follicles to FSH. I think that one thing is clear. Regardless of the product we use, ovarian stimulation can only support the growth of the follicles available during each given ovarian cycle. It cannot generate follicles ex novo. I think this is very useful to remember it. And increases in the daily doses of the gonadotropies over a certain level, set more or less at 300 international units, do not increase the number of mature oocytes or pregnancy rates. So, in other terms, it is worthless increasing the dose of gonadotrophins beyond a maximum threshold, which, as I said before, has been set more or less at 300 international units. Okay, there are other strategies trying to increase the sensitivity of follicles to FSH, and one of the most popular may be LH addition to ovarian stimulation, LH addition to FSH treatment. Well, everybody knows that FSH and LH play complementary roles in stimulating follicle growth and ovulation in a normal cycle. But the actual importance of LH during ovarian hyperstimulation in assisted reproduction is a matter of debate. Many controversy exists about what amount, if any, is necessary to achieve a pregnancy. And there are thousands of publications, thousands of papers in favor and against the addition of LH or LH effect. The first reflection that comes to me is that if there is so much controversy about the need of LH addition, such action may not be effective, at least. And at this point, I would like to refer to a recent publication from a study performed here in Spain, the BIRTH study, in order to show you what is done in Spain in general in most of the centers. This is a post-approval non-interventional study of women who had undergone treatments by using Benfola, the first recombinant FSH biosimilar launched in Europe in 2014, between the 2016 and 18. We know that beyond the demonstration of efficacy in carefully controlled phase 3 trials on selected population, it's useful to assess the effectiveness of new treatments across the whole population undergoing routine clinical care in a real-world setting. This study included more than 1,000 women and was carried out in 26 Spanish assisted reproduction centers, both public and private. The primary endpoint was the total number of oocytes retrieved, with and among secondary endpoints, implantation rates and clinical pregnancy rates were included. While patients were divided into poor responders, optimal responders, normal responders, and also oocyte donors were included in the study. Actually, the study reflects the usual practice in our country. As an example, in this slide, you can see the number of cycles or the percentage of cycles in which LH, as a recombinant LH or LH effect, was added to ovarian stimulation protocols. As you can see, more than half of cycles among patients, in more than half of cycles, LH effect was included. Even among young egg donors, 1 out of 4 donors, LH effect was included. So this is the usual practice in our country, maybe in many countries all over Europe. Well, regarding the primary endpoint, the number of achieved oocytes was 9.9 among patients and almost 20 among egg donors. And the number of achieved oocytes was slightly higher than the national average in Spain, taking into account data from the Spanish registry. Well, it was not a randomized study, so we must be cautious when making comparison, but in any case, combination therapy, LH addition, was not associated to an increase in the number of achieved oocytes in the study. Regarding secondary endpoints, these were the pregnancy and ongoing pregnancy rates per transfer of a cycle were consistent with the figures in the Spanish Fertility Society. Again, combination treatment did not show any improvement regarding this secondary endpoint in the study. So, summing up, the study, the non-interventional study, remember it, reflects the usual practice in Spain. As an example, it occurs in other countries all over the world. The number of achieved oocytes was slightly higher than national average, with consistent pregnancy and implantation rates. No parameter improved with combination therapy. Well, the history of gonadotropin's development originated with early attempts to extract and purify preparation from animals, human cadavers, and human urine, eventually evolving to their production by recombinant DNA technology. So, to make a long story short, the improvements in the developing of gonadotropins have consisted in the removal of the non-gonadotropic proteins, thus allowing a more specific effect on the subcutaneous administration, by the way, the removal of the supposed deleterious effect of LH, and a more comfortable administration, not only due to a subcutaneous administration instead of the intramuscular one, but reducing the number of shots and designing more comfortable devices. Our experience, our own experience, with very few exceptions, hypo patients, for example, we think that the widespread use of LH is not justified. In cases in which we decide to administer LH serum concentration are not useful for identifying patients who might not need LH, as we published years ago. And finally, in this subset of patients or low responders patients, we can increase the number of stimulations. Oocyte vitrification has resulted in a breakthrough in RT technologies, probably the most important in our decade. By accumulating oocytes through vitrification over several stimulation cycles, we create a similar situation as normal responder patients. And according to the results presented by Anna Cohen in classical, already classical study, they showed that cumulative live birth rates could increase by accumulating oocytes, especially or mainly due to a reduction in drop-off rates. The reduction in drop-off rates of our patients is very important, both for patients, more pregnancies, and for the centers, more treatments are performed at our centers thanks to this new strategy. Well, and what about normal high responders? Is adequate does it mean as many as possible as it was in low responders? Let's maybe have some doubts. In an already classical study by Sankara, almost 500,000 cycles were assessed. The results showed a nonlinear relationship between the number of eggs and live birth rates following IVF treatment. The number of eggs to maximize the live birth rate was approximately 15. But we have to take into consideration that this study was performed in the years showed in the slide, and frozen embryo transfer were not regarded as are now. So we have to put in up this number. Let's have a look at some concerns in this subset of patients when ovarian hyperstimulation is regarded. First, the risk of ovarian hyperstimulation syndrome. Well, we do know nowadays that among patients prone to develop this complication, the key factor for triggering this complication are the exogenous administration of HCG and the endogenous production of HCG if implantation occurs. So if we know what causes the process, let's avoid it by triggering ovulation with agonists and by delaying embryo transfer. Summing up, the traditional ideal cohort size defined by Sankara is different if we consider the possibility of embryo freezing. Ovarian hyperstimulation syndrome is not an issue if we trigger ovulation with agonists. And finally, endometrial receptivity is not a problem if we segment the treatment by delaying embryo transfer. Because vitrification has been a game-changing technology that has enabled to increase our total reproductive potential. On the other hand, some argue that controlled ovarian stimulation may have a negative impact on embryonic development and increase the risk of chromosomal abnormalities. It is not true that the higher the number of oocytes, the higher the percentage of bad quality embryos. Actually, euploid quality of embryos, in fact, decreases with age, but not with growth size. This is the reality. So, another myth. Let's have a look at our own experiences, more than 25 years experience. Among women older than 38, we use fixed doses of 300 units in general. We only use antagonist protocols. We don't use agonist protocols. With anti-trigger, we perform trigger always with agonists. So hyperstimulation is not an issue. Changes in the initial doses do not change the final result. We carry out our demonetization, ultrasound monetization without estradiol determination, with few exceptions. If few oocytes are obtained, we advise oocyte accumulation. With very few exceptions, we do not use LH or LH effect, and no human-derived products are prescribed at our center. We published years ago an update about iatrogenic prion diseases in humans, and based on that review and the availability of recombinant products, we only use these ones. The absence of evidence of risk does not mean evidence of the absence of risk, as we said years ago. Among younger patients, the initial dose of recombinant FSH depends on the predictive response of the ovaries, according to a previous cycle, available, or the antral follicle count. And although in Spain it is legal to transfer up to 3 embryos, we only perform single embryo transfers. No transfer at cleavage stage is performed at our center. All the embryos have to reach the blastocyst stage, and we perform embryo biopsy by trophobectomy biopsy in almost all the developed blastocysts. The consequence of such strict single embryo transfer policy is that multiple pregnancy is diagnosed at our center, and the consequence of such a strict embryo selection, only euploid blastocysts are transferred, is that ongoing pregnancy rate per transfer is very high. The counterpart of such a policy is that sometimes we do not have embryos for transfer. So, as a consequence of the differences between poor and high responders, we may have to redefine the classical IRT treatment. The classical treatment of ovarian stimulation, ovulation induction, egg retrieval, IVF, embryo culture, and embryo transfer may be changed. In some cases, among low responders, for example, we may need more than one stimulation process to have the chance of an embryo transfer. In other hand, in other cases, high responders, one single controlled ovarian stimulation may be sufficient to have more than one transfer, the so-called one and done approach. But even being different subset of patients, they have some points in common. All of them, everybody wants to have comfortable and short treatments. Everybody wants to achieve as many oocytes as possible, and everybody, both patients and centers, want to reduce the number of failed transfers of embryos. I think that for finishing, it is worth asking ourselves the following questions. Why do we advise long ovarian stimulation protocols, agonist protocols, instead of short ones? Because does any patient, if she is correctly informed, want to be stimulated for more than 1 month instead of 12 or 14 days? Why do you prescribe human-derived products instead of recombinant ones once these are available? Do really patients know that some products they are prescribed are of human origin? Why do you change the FSH doses once stimulation has been started? Do patients know that those changes neither improve results nor avoid side effects once stimulation has started? And finally, why do you transfer more than one embryo once vitrification is available? Do patients really know the actual risks of multiple pregnancy? Are currently informed? Have previously said that the objective for the RT treatment is to achieve a pregnancy as easy as soon as normal as possible. In any case, patients want comfortable treatments. Patients want to succeed at first attempt, and patients want to achieve a normal pregnancy. This should be the reality. We have said previously that this should be the mainstays, the columns, the pillars of our daily practice. But in my opinion, too many times we base our practice on clinicians' preferences instead of patient preferences, or even worse, in old beliefs. If we have new tools, both in the lab, in the products to use in ovarian stimulation, vitrification, new culture system. We have new tools in our hands in both sides of our field. So we can't, or we shouldn't work in the same way as we did in the past century. The worst statement in any human activity is that we do what we do because we have always done in this way. Well, I wish to thank all of my workmates and all of you for your attention. Thank you very much.
Професору за
Thank you, dear professor, for very interesting presentation. I believe that there were many listeners who did new knowledge. Thank you very much. And now there are two questions for you. The first question is of general nature. Mainly the financial component of RT programs in Ukraine is beared by the parents themselves. So the question is about Spain. How this issue of financial contribution is solved in Spain? Do you have state support programs for when, for example, the RT programs would be supported or fully paid by the state? Thank you.
Patients, couples with infertility problems have the opportunity to carry out or to undergo 3 IVF cycles in the public setting in Spain. This is the limit. There are some limits regarding age, regarding prognostic factors and so on, but once a patient, let's say 36 years old woman without any additional risk factors and so on, this patient, this couple, has the opportunity of undergo 3 ovarian stimulation, 3 IVF cycles to be exact, in the public setting. Once these 3 cycles have been performed without success, patients have the opportunity to go to a private setting. More or less in Spain, 70% of treatments are performed in the private setting and 30% in the public setting. More or less, these are the figures in Spain.
Дякую, пане професоре. До вас ще поступило одне запитання.
Thank you, Mr. Professor. We have another question regarding your presentation. In which cases the pen syringe. Syringe pen is used one dose, disposable one, in the dose of 450 international units.
Бемфола, бемфола.
Can you repeat the question?
The question is for the use of Bemfola. When there used a syringe pen with disposable one dose 450 international units of Bemfola.
Use three devices: 300, 225, 150. We use 150 units, especially among young donor patients and patients younger than 32. But we use both age and anti-follicle counts to predict the response of the ovaries. For example, regarding the factors we use to predict the response, we do, and we have published a paper about this, that anti-follicle count is more reliable than the AMH measurement. So you usually use anti-follicle count to calculate the doses, the initial doses. Sometimes, if we see that in one given stimulation with, let's say, 150 units, we have obtained less oocytes than expected, in the next cycle, we increase the doses. But once you have started an ovarian stimulation with a given doses, let's say 150, 225, and if you see that a follicle growth is poor, it's slow, the increase on the doses do not change the final result. And for example, if you start with 300 units and you see that the response is very high and you are afraid of ovarian hyperstimulation syndrome, the reduction in the doses do not change the risk. The risk of ovarian hyperstimulation syndrome depends on the ovulation trigger, and usually we only use gene agonist for ovulation trigger. So the OHSS is not an issue for us.
Дякуємо, пане професор.
Thank you very much, Mr. Professor, for such an exhausting answer. There are no more questions now for you. If there will arrive more questions, we shall send them to you by email. Thank you very much for your presentation. All the best to you and the video colleagues are continuing our work. It's my great pleasure now to give the floor to our colleagues from Ternopil, the duo of Khmyl, and the man will be the first to take floor. It's a good sign. It's my great pleasure to introduce to you Stefan Khmyl, Professor, Director of ART Clinic, and the topic of today's presentation of Mr. Stefan is optimization of COS protocols in the patients with OHSS. Welcome, Mr. Khmyl. Good morning. I'm sorry, but I have other topic. You named the topic of my daughter, Maria Stefania. I'm sorry, Mr. Stefan. Then I will announce increasing the efficiency of diagnosis and treatment of fertility in women with genital endometriosis in ART programs. Please. Dear ladies and gentlemen, good morning. I receive our sincere greetings from our fine city of Chernobyl. Endometriosis remains one of the most topical problems in gynecology. Each 10th woman in the world has this problem. Nearly 200 million women are sick with endometriosis. In the recent years, it has been proved that those patients are referred to the group of risk of genital and extragenital cancer. So this issue is to be considered very attentively. There have been many scientific studies and which are ongoing currently, but the exact reason is not known. Among main theories that were published in Human Reproduction Journal remains the same. Great attention is paid to oxidative stress, immune disorders, which is proper. After Chernobyl accident, the percentage of such patients increased. And also there is a rule that in the northern regions of the globe, terrestrial globe, there are much less of such patients. The closer to the equator, the more patients with endometriosis. The American journal published papers where the authors describe the triggering factors of endometriosis. They divided them on exogenous and endogenous. As you can see, we use the old classification, a generally accepted one for endometriosis. I believe it is very useful very comfortable in use. According to the data of World Endometriosis Association, the clinical pattern is multifaceted, and the authors separate out the main triad of symptoms, and the patients with such a multiple clinical situation have great influence on the psychic and physical welfare of those women. That's why this issue deserves very great attention. But now, today, our topic is endometriosis and infertility. There is a clear correlation between the severity of endometriosis and the fertility of a woman. The Norwegian authors published an article where they underscore main infertility mechanisms with endometriosis. Great attention is paid, first of all, to disorders of folliculogenesis, fertilization disorders, reduced endometrial reproductive potential, structural DNA disorders. Great attention is paid to peritoneal fluid properties changes. All these results in adhesions and ovulatory dysfunction. Dear colleagues, depending upon the localization of endometrioid enterotopies, there is an influence of them on the functional capacity of the bodies, of the organs and surrounding tissues. Let us look at the peritoneal fluid. Concentration of such markers of inflammation is increasing. Macrophage, prostaglandins, IL-1, 2, 6, and others. Oxidative stress markers are increasing in peritoneal fluid. All this results in disorder and poor regulation of fallopian tubes, peristaltics, patency, and further functioning of embryos. Let's now look at the ovaries, which are changed due to endometriomas. And for the short disorders of endometrium and the relevant implantation failures, the functional condition of endometrium is changed. The management guideline was accepted for treatment of endometriosis. It was divided on 4 parts. First, conservative treatment, use of agonists, aromatase inhibitors, progestogens, EMS with the levonorgestrel, and there are different kinds of treatment, surgical one, combined, etc. There are many studies about that. But as you can see, there is nothing critically new in the treatment of this pathology. What are the main provisions of treatment? We have to remember, first of all, that prolonged hormonal therapy suppresses ovarial function, provokes subfertility, and makes deeper infertility problem. Hormone therapy with severe forms of endometriosis without further treatment is non-efficient, and the surgery has its own drawbacks because on top of excapsulation of endometrioma, it results in the decrease of ovulatory reserve. So as of today, the main method of treatment of infertility treatment associated with endometriosis is use of ARTs. And for each patient, there should be individual protocol of treatments, adjusted individual treatment scheme, examination scheme. As you can see here, according to the evidence of the data, use of extracorp in vitro fertilization as first-line treatment increases the rate of pregnancy up to 50–60%, compared with the reduced rate of pregnancy with IVF after surgery. Currently, it was proved the impact of endometriosis on the quality of eggs. Look, what are the main factors? Firstly, the endometrioma is mechanically influencing the machinery of ovaries. It obstacles vascularization of the tissues and folliculogenesis, and also the endometrial fluid is negatively impacting oocytes quality and embryos quality because it's a source of pro-inflammatory cytokines and growth factors. And to this purpose, the Italian authors proposed an interesting approach to use inositol for pre-gravidary preparation of the patients with endometriosis-associated infertility. The mechanism of inositol action is aiming to improve antioxidative protection system and to reduce the impact of oxidative stress. Boris Kopel published a paper where he says that inositol is a B8 vitamin is belonging to the follicular fluid, and this concentration directly correlates with the quality of oocytes. And we do know that oocytes quality directly impacts embryo quality and the outcome of in vitro fertilization. In our practice for many years, we do use inositol together with other vitamin, ST500 plus, inositol, glutathione, lutein, included zinc, vitamin C, vitamin E, vitamin, folic acid, and selenium. We have tried many different inositols, and we see the best efficiency in its use in combination, because as you can see is here, and the authors do underline that the use of combination of vitamins A, C reduces the concentration of peritoneal fluid inflammation markers. It is very remarkable with endometriosis and fresh pelvic pains in endometriotic women, and zinc and selenium do increase the activity of antioxidation protection enzymes and reduce the manifestation of oxidative stress. As of now, there is a broad use in reproductology of D vitamin and also with endometriosis, because infertility-associated endometriosis is connected with target gene disorders connected to implantation of embryo, and metabolites of vitamin D influence that process with gene transcription and immunomodulating effect. That is how vitamin D deficiency is resulting in poor placentation. You see in the next slide that a number of authors do underline the positive influence of D vitamin on the outcomes of in vitro fertilization, including during endometriosis. In our practice, we do use Italian drug Eutelia D3. It is very good, very suitable. 2,000 international units, those allowed to use it without a laboratory, without testing the deficit. It is sublingual formulation. Dear colleagues, recently many publications appeared regarding the efficiency of alpha-lipoic acid and its use in medicine, and specifically in reproductive medicine and with endometriosis. In gynecological endocrinology article, a paper was published where authors say that alpha-lipoic acid is a powerful antioxidant helping to restore the balance of intracellular antioxidants. It's the only antioxidant able to neutralize several types of free radicals in any part of a cell. It's capable to transform other antioxidants, including vitamins A, C, tocopherol. It increases intracellular synthesis of glutathione, which directly participates in oocytes maturation. And the level of glutathione in mature oocytes is higher than in unmature oocytes. So is capable to regenerate antioxidant molecules, which ease embryo implantation and stimulate production of local mediators, which in this case are favorable for implantation. A paper was published by Italian authors who also say about its remarkable anti-inflammatory effect and also the influence of alpha-lipoic acid, which is believed to be a coenzyme for many Krebs cycle enzymes. Its use increases ATP biosynthesis and also the energetic availability of the cells. In Ukraine, we have now a drug, maybe the only one, of alpha-lipoic acid, imipelvidol, which is used frequently to fight chronic pelvic pain. We know perfectly that 40 to 87% of women with chronic pelvic pain have endometriosis. That is why in the etiology of chronic pelvic pain, the oxidative stress has a leading role. It's used mainly with the purpose to reduce the pain syndrome and the intracellular inflammatory response as a symptomatic treatment in women with endometriosis. I believe it's a novelty in endometriosis treatment currently. It comes together with magnesium. See next article by Italian authors on the use of alpha-lipoic acid and myo-inositol. The authors underline that all this results in reduction of expression and activation of inflammatory process in women. Now a few words about treatment methods, surgical treatments. As you see, in human reproduction, there was a paper published where authors do clearly say that symptomless endometrioid ovarian cysts in women who plan pregnancy are contraindicated because the surgery substantially impacts the ovulatory reserve due to ovary damage. And the results of lab testing underlines that the previous removal of endometrioid cysts gives much lower outcomes. And high gonadotropins doses are necessary for ovulation trigger. You see next publications also say a number of embryos and oocytes is reducing and the clinical pregnancy rate is much lower after surgery. Dear colleagues, I would like to underline that in the first step of surgical treatment conduction, one should very carefully and thoroughly approach the ovulatory reserve. Most authors underline unreasonability of repeated surgeries. A timely use of ARTs should be there. You see this Cochrane review, which says generally that the surgery substantially reduces ovulatory reserve and gives much poorer outcomes. What do we propose here? We are in favor of using the sclerotherapy. You see, in fertility and sterility, there was a paper on and sclerotherapy is believed to be one of the optimal ways for treatment of endometrioid cysts before IVF procedure. And they underline that much better outcomes on efficiency are there compared with when there is a prior laparoscopy. Sclerotherapy method was developed and firstly published in 1988. This is the sclerotherapy method we use in our practice. And see, next publication where the authors recommend to perform sclerotherapy with a size of up to 10 centimeters, but without malignization signs. Next publications authors say about the efficiency and stable FSH, LH, AMH, level CS125 reduction, oncomarker reduction. Regarding the results of our studies, we conducted a study by dividing patients on 3 groups. First group, sclerotherapy and pregravidary preparation. Second group, without pregravidary preparation, sclerotherapy. And third, for women with previous surgeries. You can see on this slide the patients for whom sclerotherapy and pregravidary preparation were made had much better parameters of hormone background. You can see in the next slide, when analyzing hormones concentration, we established that AMH concentration was much lower in the patients with hysterectomy. And patients who has got pregravidary preparation had more stable ovary hormones background. You can see in the slides the patients who received pregravidary preparation, the percentage of recurrences was much lower. Finally, all this substantially influenced, the use of sclerotherapy plus pregravidary preparation, all this influenced embryos quality. This slide shows the patients with prior surgery. Much lower number of follicles, number of retrieved oocytes, number of mature oocytes is much lower, a number of fertilized eggs. And you can see how much lower was the blastulation and also the rate of pregnancy. Fertility and Sterility published another paper saying that after sclerotherapy the number of oocytes was substantially higher. Dear colleagues, a few words I would like to say also about comparing the use of oral contraceptives. And yes, the oral contraceptive drugs do ease endometriosis symptoms, but do deteriorate ovarian function and stimulation response. So there was a comparison of use of antagonists before programs, and according to Cochrane review, the percentage, the rate LBR in patients who took oral contraceptives is much lower than when using agonists and releasing hormones. As of today, there is no single opinion for selection of optimal stimulation protocol during controlled ovarial stimulation, long protocol or short protocol. There is no difference, no clearly confirmed parameters. Some authors underline that stimulation protocol choice doesn't influence ART outcomes in endometriotic patients. Others say there is antagonists are more efficient compared with agonists, and stimulation protocols are cheaper, shorter, less burden on the body. In our practice, from the drugs we use for stimulation and ovulation induction, we believe more suitable is Bemfola, the recombinant FSH. Just recently it came to Ukraine, and I like it to use it. This is a syringe pen. There was a study, and the most suitable and convenient system for administration. 62% of patients say the Bemfola pen is the most convenient one to deliver the drug. Bemfola provides for a required dose. Pregnancy rate with Bemfola use is correlated to expected outcome. A low rate of adverse events. It's easy to use for medical staff and patients, and the women prefer mostly Bemfola to other alternative pens to administer FSH. Dear colleagues, it was my pleasure to communicate with you today. Receive my sincerest greetings. Take care about Corona and have all the best, and receive my sincerest greetings from Ternopil. See you. Thank you very much. It was a pleasure to see you, to hear you. Such interesting facts, which I believe will be very useful to our listeners, both reproductologists and obstetric gynecologists. We have many obstetricians, gynecologists who attentively listen to you this morning. And the topic, your topic today obviously is interdisciplinary one, because endometriosis is the disease which has multifaceted manifestation. I was talking to my American colleagues, and they sent me an interesting case of brain endometriosis, which was malignized. There was a surgery, but it was our Ukrainian woman living in the US, but everything was good there. I also am following interesting cases of our colleagues. There is ocular endometriosis, not to talk about pelvis as a cause of infertility, about which you deliver it very in detail and very thoroughly. There are questions to you, but due to shortness of time, allow me to send them through chat to you, and I believe you will communicate. You will answer the doctors who put questions to you. And now, colleagues, we switch to next topic. And Maria Khmil, a reproductologist, she defended her thesis brilliantly just recently. She also is a head of ART clinic. She's medical director. I believe I now announce correctly her topic: optimization of COS protocols in patients with the syndrome of polycystic syndrome ovarian system. Hello, dear colleagues. I'm happy to stay with you. Today, we'll talk about PCOS today and optimization of COS for PCOS patients. Just a minute. Also, I greet you from Ternopil and Lviv because our medical centers are located in these two cities and our study is made in Lviv and Ternopil. PCOS really is one of the most frequent reasons of anovulatory fertility in reproductive age women both in Ukraine and abroad, and makes from 6 to 20% according to different authors. PCOS is established in almost 50% of women with disorder of menstrual and ovulatory function. ARTs are the main way to restore fertility in patients with PCOS. The key point in achieving result, meaning the outcomes, live birth of a healthy child, is a correct approach to establish diagnosis, to pre-gravidory treatment of these patients, planning the pregnancy, and approach of to selection treatment and the protocol used for infertility treatment. As of today, there are a great number of publications about COS protocol in PCOS patients. But, in our opinion, the evidence requires certain systematization, clarification, optimization of pregravidory preparation, choice of optimal stimulation protocol, where also trigger selection should be considered to provide a high quality folliculogenesis. And all reproductologists are very much afraid of OHCC. What studies have we conducted? On the first stage of the study, we analyzed the hormonal background. As a hormone profile of this patient and also US parameters in women with PCOS. Also we assessed IMT impact, BMI impact. So what concentrations of hormones were obtained? As we see in PCOS group, AMH level was much higher than in comparison group. FSH level was lower, but please pay attention. The ratio of FSH and LH was changed. Also, there was a difference in prolactin, estradiol, and other hormone and values, and obviously the progesterone. Also, what was our conclusion? In women with PCOS, the hormonal disbalance is present, and the increased concentration of FSH, LH, testosterone, estradiol, and also reduced concentration of FSH compared in women with peritoneal infertility, which were making the comparison group. Also, the level of reproductive system hormones depended upon body mass index in women with infertility and PCOS, like we see in this slide. With polycystosis, the dose of FSH was correlating to BMI and was lower with terminal obesity type women. We studied this issue depending upon type of obesity, and testosterone level in obesity directly correlated to progesterone and estradiol level. Obviously, the main ultrasonic criteria of ovarial reserve assessment in infertility women at the background of PCOS was AFC and volume of ovaries in these patients. We retrospectively studied the patients who had COS with agonists with long protocol. Another group has pituitary suppression with agonist and further ultrasonic control. And also supraovulation stimulation with relevant treatment was conducted. As ovulation trigger, earlier we used HCG, even to PCOS women. In 36 hours after ovulation trigger, oocyte retrieval was conducted, but the ovulation wasn't yet happening. So what were the results as a result of this superovulation induction? In PCOS group, we obtained higher number of follicles. Ovariolar reserve was much higher, and the average number of retrieved oocytes was higher than in comparison group, and the average number of mature oocytes. But unfortunately, we had very high level of unmature oocytes and also very unmature oocytes in PCOS patients. PCOS patients. Based upon this retro review of history of patients with infertility and PCOS, the patients with long protocol of COS, we studied risk factors and the rate of hyperstimulation syndrome. It was very high, unfortunately, rather high, unfortunately, like it was shown in the previous slides. We had high percentage of oocytes which were very unmature or just unmature. Unfortunately, rather high number of hyperstimulations syndromes was received. So we decided to optimize the protocol to prevent hyperstimulation syndrome and to obtain higher number of mature, better quality oocytes, and obviously to get good embryos. So what we proposed and what was improved? We proposed a comprehensive method of pre-gravidary treatment. We know that the pre-gravidary preparation is a very important stage for the patients with infertility and scleropolycystosis, and the good quality pre-gravidary treatment helps us to optimize the protocol itself to get better results, and also to help pregnancy to develop better and to have less reproductive losses. What do we use for comprehensive pre-gravidary treatment methods? We use vitamin complexes, folic acid, 400 micrograms, in inositol, 2000 micrograms, D3 vitamin, and also we studied pituitary and other hormones background in PCOS and infertility women who used this complex of pre-gravidary treatment. In the second step of treatment, we also improved it, and we introduced use for PCOS patients of a new comprehensive method of double administration of antagonist trigger, and we studied how it influences oocytes quality and OHSS rate. We had to avoid it as much as possible. Also, we studied delayed ET on PCOS treatment outcomes and its capacity to prevent OHCC and improve pregnancy rate. Let's talk about the drugs used for pre-gravidary treatment. Besides the obligatory use of folic acid, we use also the inositol, and basically it's stable isomer myoinositol. It's very common in nature, and There are many studies now proving to that its deficiency influences pathogenetic process development for PCOS. We know that its reserves are replenished with food, with nutrition, but general inositol sources are very often missing in women, or they have great deficiency. That is why insulin receptors are deteriorated, which is already present in PCOS women. Very often our patients are missing, are lacking this exogenous inositol intake. That is why inositol containing vitamin complexes is quite reasonable. We know many papers that prove to the favor of using of D3 vitamin in women planning pregnancy, especially those with PCOS. Vitamin D deficiency enhances polycystosis in those women. In the modern literature, there's many information about correlation of vitamin D deficiency and the relevant metabolic disorders, which are proper for PCOS patients. So I want to underline once more that D vitamin plays a critical role in pathogenesis of PCOS and influences the efficiency of IVF outcomes in women with this pathology. And also, we not only want to get pregnancy, but also we want a favorable, good course of pregnancy and to have a healthy newborn from that woman. And with relevant vitamin D levels significantly contribute to that. Obviously, there's discussion of the mechanisms, how it is made, optimal dosage in PCOS patients and also during pregnancy. So our modified protocol included superovulation with short protocol using recombinant phorotropin. We started stimulation on the second day of the cycle, further on the 5th to 7th day, depending upon the size of follicle, averagely 14-15 millimeters. We prescribed antagonists and we monitored with US the growth of follicles and determined the relevant time point for trigger. In our modified protocol, we changed ovulation trigger to RH agonist. In the relevant dose, you can see in this slide, after 36 hours of the first dose, we conducted in vitro fertilization, embryo culturing with further vitrification. There was no so-called fresh embryo transfer. And with biopsied embryo at blastocyst station, then conducted the cryoconservation before transfer. We know that in the modern economic realities, we do have everyday practice with our patients. We do communicate with them a lot. We know that the choice of treatment is also influenced by economic factors, and we have to adapt to patients' economic possibilities. I believe that the cost is also matters. The prices also matters. That's why we try to provide not only comfortable but also economically suitable treatment conditions for the patients, taking into account the possibilities. We use many times such gonadotropin as Bemfola in our practice, which appeared recently in Ukrainian market. And it is great pleasure. A few years ago, I firstly knew this drug in one of the leading Brussels centers in Delta Clinic. They use this drug already for a long time, and it is special pleasure that it appeared last year in the market of Ukraine. And we started immediately to use it actively in our clinical activity because it opens a very new opportunity for the patients with to provide a better access. We know that the patients stimulation protocols mean a high economic burden for the patient. So Bemfola became a drug which optimizes the expenses of the patients because it's cheaper than others. I want to underline it in no way lowers the quality of treatment because the drug really is absolutely similar. It contains recombinant FSH, and the active substance besides price is in no way different from other gonadotropins. That is how we get absolutely similar development of mature growth follicles and the expected outcomes in the sense of folliculogenesis and retrieval of quality oocytes. I want to underline that such drugs provide access to high-quality drugs for all of our patients, not to for them not to think about the price. Same regards patients all over the world. And it has absolutely same indications as a reference drug for use in the protocol of controlled ovarial stimulations. Bemfola is very convenient because it has 5 different doses, and it allows us to very well dosage them and to prescribe them. I would like to share with you today data about embryos we obtained with our stimulation protocol using modified schemes of controlled ovarial stimulations. We received the average number of oocytes which was higher compared to other comparison group. And also we have got very good number of fertilized oocytes. The number of non-fertilized oocytes was lower. And basically the number of particles was higher. It's very important for us. The cleavage rate, blastulation rate. As a result, high number of good quality blastocysts obtained. I would like to tell that compared to fresh protocol, progesterone level changed. It is also very important for us because it's influences the efficiency of our protocols. To sum up everything that was said today and to give some practical recommendations, I know that today we have many practicing clinicians working in reproductive medicine. I would like to say that practically women with PCOS also have a number of concomitant pathologies we should take into account. It proves the necessity of comprehensive general examination and gynecological examination of those women before beginning ARTs with them to improve efficiency. We also stress on that it's important to assess ovarial reserve, obesity degree, metabolic syndrome, hyperandrogenism, and other dyshormonal disorders, hormonal disorders. At the stage of pregravitory treatment, I want to underline that the patient should be comprehensively examined, and the patient should be prepared to the next step of treatment with ARTs. And at the stage of stimulation itself, we propose the scheme of short agonist protocol and delayed ET, which allows to achieve higher clinical pregnancy rate. And also, and it is the most important, higher LBR compared to the patients for whom previous standard schemes were used without pregravitory treatment and with long protocols and with fresh embryo transfer, resulting in higher rate of hyperstimulation and lower rate of LBR compared to the scheme we propose and use. We proved that when using antagonist, it is reasonable to provide relevant vitrification of ET to increase pregnancy rate. Very frequently, question is asked when embryo transfer of cryoconservated embryos should be performed, cryopreserved embryon. We advise to do it 2 to 3 months after transvaginal oocyte retrieval, obviously using if there are no contraindications to cryotransfer. If the patient has to treat concomitant pathologies or gynecological pathologies, she has to be prepared very good to ET. I thank very much. I thank you very much for your attention. I wish good day and continuation of your work on the Congress. Thank you very much, Mrs. Maria. The presentation was wonderful. We have questions to you, but we shall pass them to you through chat because we are very limited in time and we have to continue our program. Thank you. Thank you. I wish you a successful work on today's Congress. We continue our work. It's my great pleasure now to invite to the floor Svetlana Zhuk, professor. She asks to use this name. Please, Professor Svetlana. Iron deficiency with focus on IRTs. An interesting topic. Please, Svetlana. Thank you, Alexander Mikhailovich. I'm waiting for the presentation to be loaded. And today, in previous presentations, it was said about a very great role of micronutrients, hormones. Very frequently, the vitamins are preceding the hormones. So we can say that sometimes the details have great meaning, matter a lot, not only in obstetrics and gynecology, but also in reproductology. I would like to talk about iron deficiency with you today. Iron deficient anemia and infertility, in the opinion of many scientists, are directly correlating. The probability of get pregnant with iron deficient states, according to literature, is lower by 60%. I believe it's a very convincing number. The process of oocyte maturation is violated and evaluation. With deficiency of iron in the body, oxygen access to tissues and cells is deteriorated, and it negatively impacts ovarian function and oocyte quality. There's a direct correlation. The hidden iron deficiency is found in 40% of the women suffering from infertility and can result in problems during pregnancy as well. This is a single comprehensive process. So the probability of fertility success with iron deficiency is much lower. I show you the sources throwing light on this issue. Unfortunately, colleagues, time is against us, not with us, not in our favor, but against us. What do I mean with that? The deficiency of vitamins and micronutrients in mother can for a long time have a silenced, hidden character, but for the fetus, the deficiency during, I highlighted in red, several weeks can become critical and the consequences can become irreversible. So, iron deficiency in the early stages of antenatal development is capable to kill all the next efforts of parents to restore the health of the children. What do I mean? First of all, meaning neurologic and psychic mental condition of the child. To restore iron status of the fetus and the child. Thereafter, weeks and months are necessary. In the cases of failure or not timely treatment of the child with iron deficiency before birth can bring lifelong reduce of cognitive capacities. I want to underline it once more. Statistics is always amazing. About the statistics of these issues, consequence of antenatal iron deficiency can be higher level of premature births, 1.5 times, perinatal fetal death, 1.5. Mental disorders in newborns like bipolar disorders, autism are higher 3 to almost 6 times. Neonatal mortality 2.5 times. Mental retardation 2.7 times. Higher rate of depression, apathy, and anxiety 2 times. More frequently, the so-called attention deficit with hyperactivity syndrome, 1.5 times higher. Colleagues, a few years ago, we even didn't have these statistics. We were not talking about such impressive problems with children. You know, there is lack of tables in the classes where children who are not studying so well due to that. And here you see the entire list of problems arising with both newborns and then with children. I want to remind you on the need for iron in the pregnant. And I want to improve your awareness of the information I want to bring to you. Pregnancy and lactation are physiologic conditions where an obligatory ferrodotation is a must. From first to third trimester of pregnancy, daily demand of iron grows from 1 to 7 micrograms. Pay attention, 7 times. On top of physiologic needs of the woman, about 220 milligrams, not relating to the pregnancy. You should add expenses for fetus growth, other 300 milligrams for increasing the volume circulating blood, other 400 milligrams. Placentation and umbilical formation 90 milligram, blood loss during pregnancy 200 milligrams, and 2 milligrams for lactation. Let's sum up. During pregnancy, delivery, and lactation, the woman loses as a whole 1,400 milligrams of iron, very serious number. In 16 to 20 weeks of pregnancy, the need for iron doesn't increase because the process of fetal blood formation is there. Intestinal uptake is increasing, but this compensatory mechanism is not able to provide to satisfy the so-called appetite of the fetus and increased demands of the pregnant women herself. So negative saldo between intake and consumption is resulting in iron deficiency or clinically expressed anemia. I would like to dwell especially and bring to your attention the information on the influence of iron deficiency on fetal CNS development. Why so? Because it goes about programming of next generation health, and it is our future who will take part in the management of the country, who will work in responsible and less responsible offices. There should be a healthy generation in place. Unfortunately, each generation has worse and worse health. So, first trimester, the deterioration of ontogenesis due to negative effects, specifically significant iron deficiency, will be incompatible with gestation continuation because there's high risk of formation of main structures of the system and generally high risk of embryo death. In third trimester, mainly since 20th week, neural centers formation is taking place, providing for main vitally important organs functioning. In the third trimester, there is most intensive differentiation to neurons and glia cells. Growth and myelinization of neuronal axons and dendrites continues, synaptic contacts are actively formed, and violation of this scenario with iron deficiency anemia is accompanied by simplified cortex architectonics, functional incapacity of pulses, neural pulses, and increased time of neuron signal passing. The consequences of early childhood iron deficiency are serious, severe pathological conditions, and the relevant study of delayed outcomes confirms that on almost 100 patients, which during 25 years, colleagues, it is also already a time, a duration, mental, psychic, and physical development of children who had iron deficient anemia in the childhood, in the early childhood studied. What are the results? In 1 to 2 years, the children of main group of iron deficiency anemia were unattentive, were undecisive, had reduced activity, and had quick fatigue. After 5 years, they had lower results of tests for mental and motor development. In 11 to 14 years, they also were retardation from same age children of control group, and they had problems in mental and motor development, had apathy, depression, and attention concentration disorders. In 15 to 19 years, the adolescents of this group also were lower than comparison same agers, and this gap was more noticeable in case of low social and economic status of children's families. So to provide anemia, to provide adequate consumption of women during conception, and it also regards ARTs, this woman has to accumulate at least half of that 1,400 milligrams of iron necessary for good gestation, and the remaining part should be obtained during pregnancy. Unfortunately, there is a very low number of women having balanced iron status before pregnancy, before conception, sorry. Even in the well-doing Europe, so to say, only 20 to 35% of future mothers have sufficient iron depot. The concentration of serum ferritin not less than 70 micrograms per liter, meaning that to pass pregnancy without additional iron-containing drugs. All the rest of the women have problem and may have problems in their intrauterine fetuses and then in their newborns. Regarding gestational anemia, due to all above said, it is mostly common type of pathology in pregnant. In 10 from 10 cases, it's related exactly to iron deficiencies, not with some other cases. In the developing countries, the iron deficiency makes about 80%. In high life level population states and with low birth rate, I mean European Union 21-35%, in Russia 40%. Since 21st century, the rate of this disease increased. There are more questions than answers. We are developing new technologies. We are introducing new drugs. Why it happens so? Obviously, it's clear, because the environmental situation, the ecology is very poor and makes great problem. So, colleagues, once more, we have to pay attention to women with iron deficiencies. They need, they shouldn't become pregnant before compensating for deficiency of micronutrients. It's the background of hypoxic and sideropenic syndromes. Unescapably, there is a placental deficiency which results in high risk of disease for woman and child. Considering perinatality disease and mortality rates in our center, the most common diagnosis is placental insufficiency. You know, when we see the histories, they say, this is placental insufficiency, nothing can be done here. Colleagues, how one can say this? How this verdict can be taken? The placental deficiency, it takes 80% in the pathogenesis of other gynecological conditions. Does it mean we have to lose pregnancies and to lose those children because we cannot do anything? There are many publications, many proposals how to avoid placental deficiency, how to monitor women with placental deficiency and how to help them deliver successfully. There are many of those, but you have to pay attention to that and you have to work very seriously on that. Eventual complications of pregnancy, there can be bleedings, preeclampsis 1.5 times, fetal retardation, fetal growth retardation, low body weight 1.5 times higher, perinatal neonatal mortality 1.5, 2.57 times. According to WHO data, every fifth maternal death is connected to anemia in one or other way. I will not tell you numbers which will be sounded eventually by Volodymyr Medved today about what happens in our country with maternal maternity. It is his specialization, being an expert of the Ministry of Health, and he will tell you this number. We have to do something about that. Continuing my topic, I want to say that iron deficiency will result in deterioration of fetal neurogenesis. I already mentioned about it. I want to remind you that iron is not only the component of hemoglobin, but also the coenzyme of many enzymes which serve for cell viability, for example, for cellular mitosis in the case of neurons. But with the progressing deficiency of this micronutrient, the enzyme pool is reduced earlier than the content of hemoglobin. So the pathologic disorders due to enzyme deficiency in the brain of intrauterine child appear earlier than in the mother. That is how the iron deficiency can, even without anemia, unfavorably impact fetal development. Also, in the brain of developing fetus, there are pathologic disorders due to enzyme deficiency with progressing iron deficiency. They appear earlier than mother. Iron deficiency in mother in pre-gravidary period and the first trimester of pregnancy can produce more dramatic changes in the nervous system of fetus than its deficiency in its second and third trimester. Due to this codex, attention, WHO recommends, and we follow them, recommends all the women with menstruation, reproductive age, and adolescents to take iron drugs 30 to 60 milligram every day for 3 months once a year. Regarding obstetric philosophy, and there is such philosophy already, I want to give you an example of fetoplacental insufficiency. If you want to catch the train which already departed in the first trimester, it is very sadly to see it departing in the second and third trimester. It is one option. Another option, you have to promptly provide a full-fledged depot with necessary micronutrients, and you can have a quiet sleep and have a positive result of pregnancy outcomes. The pregravatory preparation will help us to escape the serious problems during pregnancy, delivery, and postnatal period. Barbara said very well that the nutrients can be useful when they replenish this specific deficit which is not replenishable with nutrition. It's my great pleasure to announce you today the drug Vitroferrobia, which is an optimal combination of gem and non-gem iron, developed especially in case when normal food intake doesn't allow to get sufficient iron to provide for full-fledged functioning of human body. This slide shows the advantages of gem iron, which are very expressed, and the clinical efficiency of Vitroferrobia. The clinical studies shown its high efficiency to increase hemoglobin and ferritin levels. Let me allow introduce an administration way. Adults and children want 2 pills 2-3 times a day with a glass of water, not dependent from meal intake. With iron deficiency, the pregravatory iron consumption for 2 to 3 months is critically necessary to replenish iron status before conception and to accumulate 700 milligrams necessary for the needs of mother and fetus. I hope that by correctly prescribing, correctly approaching this issue, you will provide for the brain of the fetus to be such multicolor and function as I show you in this slide. Thank you very much for your attention. I believe this information will be useful for you.
Ми вдосконалюємо свої вміння, знання та технології вже 120 років, щоб завжди бути поруч тоді, коли найбільше вам потрібні. Гедеон Ріхтер. Здоров'я – наша місія.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life. What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals, the camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Good morning, dear colleagues. I'm happy to welcome you at our section under a very interesting name, Better and Healthier Every Day for Every Woman. It goes about that our reproductive technologies have to be friendly, have to be easy. The women shouldn't have always stress from such treatments. That is why our section has got this name. Today, we shall consider the issues of individual variants of ART cycles, and we shall dwell more in detail on the changes and individual approaches we are trying to introduce in donation cycles of those cells because now it has very great meaning. We shall have 4 presentations today. The first one by our very favorite Professor Christophe Blokil from Belgium, the head of Reproductive Medicine Center. He will talk about intercycle variability, what it is connected with, and what factors do influence it. I hope we shall listen to his wonderful presentation, like all the presentations before. The second presentation will be by highly esteemed Uliana Dorofeeva, who is the head of Bank of Oocytes, OGENE, and also she is responsible for work with oocyte donors in IVMed clinic. She has very great experience of work with oocyte donors, with donation program, with cryobank, and so I hope we will get all the best we can from this presentation. Then Birol Aydin, the head of embryology in IVMed, will talk on technical, biological, micro aspects concerning directly the laboratory work. And he has very many interesting materials, including videos. So I hope it will be a very impressive presentation. And for the rest, I will talk about what happens with eggs donation, oocytes donation, and how we are trying to make this problem as friendly and efficient as possible. I invite to the floor Professor Christophe Blokil, please. Dear Professor.
Ladies and gentlemen, dear colleagues, thank you for the kind invitation to be able to talk about the cycle-to-cycle variability and optimization of the follicular phase in reproductive technologies. Of course, I would have preferred to be among you live, but let's say that, or let's hope that it will be the last couple of months that we need to do these webinars. So I would like to start by stating again that an IVF treatment, an ICSI treatment, is of course an extremely complex, time-consuming, expensive, and stressful event. And of course, we always need to think in terms of how to improve the patient's experience, because did you know that actually 1 out of 3 of all infertile couples, and there are many infertile couples, will eventually require IVF? You know that around 1 out of 6 or 1 out of 7 of all couples are suffering from infertility, so this is quite a lot. And when they perform an IVF treatment, then we know that only 30% of all top quality embryos will lead to a healthy liveborn. So we really need to think in terms of this burden. And the first step is to try to find the right protocol. The right protocol means, of course, the GnRH antagonist protocol. I think that today, and we don't need to go too much into detail about this, but today we are quite convinced that in terms of OHSS, GnRH antagonists are performing significantly better. We know that at the end of the day, there is no difference anymore between agonists versus antagonists with regard to live births. It is very well established that even by Hesham Ali Nani from Egypt, that there is no differences anymore. One of the shortcomings that you could have with the GnRH antagonist is, of course, the recruitment of the number of oocytes. According to the Cornelis Lambalk meta-analysis that was published a couple of years ago in Human Reproduction Update, he stated that yes, with the antagonist protocol, you reach a lesser number of oocytes as compared with the long agonist protocol. But of course, this is what we are aiming at on a daily basis, to try to optimize the FORT, the so-called follicular output rate, the number of pre-ovulatory follicles on the number of antral follicles. So, of course, we are disappointed if the FORT is only 30%. Of course, it is not nice to see when we cannot enhance the number of recruited follicles that we have available. So, and this is one of the reasons why in our center we use quite a lot of the corifoliotropin alpha compounds, you know, the long-acting FSH that lasts for 7 consecutive days, while we also observe, and also based on these 2 nice series of studies, both in Europe and in Asia, published by George Griesinger, that when we prescribe corifoliotropin alpha, that we can have a kind of exploiting of the ovarian reserve. When we look at the number of follicles and look at the oocytes retrieved, the higher the antral follicle counts, the higher number of oocytes retrieved as compared with daily injections of recombinant FSH. We have now around 6,000 to 7,000 cycles with corifoliotropin alpha, both in poor responder patients and in normal responder patients. You know that to keep it on the label, the antral follicle count should be lower than 20 in order to start corifoliotropin alpha. When we establish the right protocol, so the antagonist protocol, which I need to admit that we only use it in around 85 to 90% of the cycles. We still have some long agonist cycles, but when we establish the correct compound to stimulate, then of course we need to start the stimulation. And with a stimulation, I mean a stimulation, not some mild stimulation, and I don't refer to wild stimulation either, but a conventional and adequate stimulation. If there is a risk of OHSS, then we trigger with an agonist, and then we can vitrify our embryos to perform a frozen embryo transfer later on. And people who know me, they know that I love oocytes. And well, the question is, of course, the more the better, or not? Well, according to this study of Nikos Polizos, who did it together with us in Brussels and also in Spanish centers, he observed that the more oocytes you have, the higher the fresh live birth and the cumulative live births will be. So the more the better is true, but of course to a certain extent, because as you can well observe in the curve, there is also a kind of plateau as soon as we reach 27 oocytes. And we don't want 10 blastocysts in our fridge. But of course, the question that has always been there was, if we retrieve many oocytes, does it also mean that we retrieve less competent oocytes and then maybe less competent blastocysts? Well, the answer is no, because according to these data, and I need to express my gratitude to Filippo Ubaldi for this slide, he said, well, if we have a higher number of oocytes, you will have a higher number of blastocysts, but you will also reach a higher number of euploid blastocysts. So actually here also, the more the better, as long as it occurs in safe circumstances. If we want to achieve a fresh embryo transfer, then of course we are not talking about 20 oocytes or more. Barış Ata from Turkey, he used to work in the United States with Santiago Mune, and he published this nice story. He said, well, the more the better in terms of blastocysts is right, because the euploidy rate only depends on the age of the female. And you can see that the higher age of the female, the higher the number of aneuploidy, the lower the number of euploidy, independent of the number of blastocysts obtained. So interesting study from the US. Elena Labarta from Valencia, she said, well, if we want to know the euploidy rate, why are we not going to compare donors who are undergoing a natural cycle, unstimulated cycle, versus a stimulated cycle? Well, looking at the chromosomally abnormal embryos, it was exactly the same in both arms of the study. So whether we stimulate it or not, there is no differences in euploidy rate between the groups. Studies of Venitis and Lamarca also show that the number of euploidy is also dependent not only on the number of oocytes retrieved, because the higher the number of oocytes, the higher the number of euploid embryos, but especially at younger age. The higher the age, the less euploid embryos you will have, regardless of the number of embryos. So interesting studies have been published on the same topic. More oocytes means more euploid embryos. But let us come back again to a mild versus wild, or let's say conventional stimulation, but in safe circumstances. And yes, of course, we have the tool of the GnRH agonist in our hands. And as you can see, if we refrain from any luteal phase support, if we do not provide a fresh embryo transfer, if we do not give HCG in the luteal phase, then the incidence of severe OHSS is practically eliminated, practically excluded. So this is how we can safely treat our patients, because you know the differences between agonist versus HCG. And let us maybe go back to what has been the golden standard. The golden standard was always HCG, because of course it didn't give only a very nice LH peak, but also a sustained luteotropic effect. And this was the advantage of the luteal phase. But of course, with the agonist, where you have the flare-up of the LH, but also the FSH, it could enhance pregnancy rates. And you remember the very recent study by Dr. Haas from Israel, stating that the dual trigger, in case of no risk of OHSS, dual trigger versus only HCG gives higher pregnancy rates, gives nicer embryos, and more mature oocytes. So interesting study by Haas. But listen, if there is a risk of OHSS, then per definition, we will trigger with the GnRH agonist. And we did an RCT in high responder patients, patients with more than 18 follicles of 11 millimeters or more, and we randomized into two groups, a fresh group versus a frozen group. And the fresh group, those patients, they received one dose of HCG, 1,500 units, 1 hour after the oocyte retrieval, before starting the luteal phase support, classical luteal phase support with progesterone and also estradiol. Or in group 2, patients were also triggered with an agonist, but in this group, they underwent a freeze-all in 100% of the cases. So agonist, little dose of HCG 1 hour after the oocyte retrieval, the so-called Humaiden protocol, because it was Peter Humaiden who established the protocol, or agonist and freeze-all. And actually, so there was a correct randomization with a high number of oocytes retrieved. We are talking about high responder patients triggered with an agonist in an antagonist protocol. We observed similar number of embryos, similar number of doses, but then looking at the pregnancy rates, HCG positive rates, clinical pregnancy rates, and live birth rates, there was a non-significant higher pregnancy rate in the freeze-all group as compared to the fresh group. And I know that the difference was not statistically significantly different. I know that looking at the clinical pregnancy rates and ongoing pregnancy rate, there was a 6% higher pregnancy rate in the freeze-all group. There is maybe a more important secondary parameter that we need to acknowledge, and this is safety. some patients still developed OHSS when performing an agonist trigger plus HCG 1,500 units 1 hour after oocyte retrieval. And of course, taking these parameters into account, both efficacy and safety, since this study, we do not perform any agonist plus fresh embryo anymore. So agonist and then 1 dose of HCG 1 hour after oocyte retrieval. We have abandoned this. So today in our clinic, we do around 30% of freeze-all cycles, both elective and non-elective, OHSS, progesterone rise, PGT, and so on. But we will not use the agonist trigger and HCG plus fresh transfer anymore. Patients, dear ladies and gentlemen, they want to get pregnant tomorrow and not the day after tomorrow. So if we talk about a freeze-all strategy, we need to take the time into account to start with the frozen embryo transfer. So the question is, when patients have performed an ovarian stimulation, an oocyte retrieval, should we wait 1, 2, or more cycles before starting a frozen embryo transfer, or can we start immediately? So this is the studies that we did in our center together with Samuel Santos Ribeiro, who used to be my PhD student and is now working in Lisbon, Portugal. He said, well, let us do the study and let us perform 2 retrospective trials. One trial was just so after a failed fresh embryo transfer, and the other was after a freeze-all strategy. Do we need to start immediately, or do we need to delay the frozen embryo transfer? And actually, the results were quite interesting, because whether we start immediately with the frozen embryo transfer or whether we wait for 1 or 2 months, pregnancy rates turned out to be the same after a failed fresh transfer, but pregnancy rates were higher when looking after a freeze-all strategy. So let us go and have a look into detail to this study with more than 300 patients included. We performed it together with the Center of Dr. Lan in Vietnam. And we looked at the data and we saw that if we perform an immediate transfer after a freeze-all protocol, that pregnancy rates were higher. So of course, this is a retrospective study, and there is some bias that we are never able to exclude, but at least it is not a lower ongoing pregnancy rate that we observed if we perform a delayed frozen embryo transfer. So we do not need to tell our patients, listen, you need to wait and the ovaries need to rest now for 1 month and so on. No, we can start immediately. So the time to pregnancy shortens significantly by these studies. What about cycle-to-cycle variability now? Well, we have some very interesting data by our TRUST trial. When the studies with corifoliatropin alpha were established, patients underwent consecutive cycles with corifoliatropin. So in cycle 1, 680, then in cycle 2, patients who did not get pregnant, so 375, and then the others who did not get pregnant, again, 200 cycles in a third cycle. And actually, it was very interesting because it was an immunogenicity testing study that there was no anti-FSH antibodies seen, so the immunogenicity was 0. But maybe a more interesting also story was that patients who got the same medication, the same dose, consecutive times, well, there was an intercycle variability observed. And it was striking to see that around 25% of those patients changed from high responder to normal responder, from poor responder to normal responder, from normal responder to poor responder, and so on and so on. So actually, patients remain patients. And of course, we need to individualize. But the intercycle variation is so big, 25%, that it is, of course, very difficult to draw firm conclusions after one cycle in IVF. But therefore, the purpose is to stimulate adequately. And I know that we are not yet there for the one cycle, one child strategy. It remains a challenge, but we have tools and we can have the right protocol to remain patient-friendly on one hand, but to reach a good efficacy and a good safety profile on the other hand. Let's love oocytes and try to enhance the number of oocytes, always taking the safety into account. And then we can start immediately with a frozen embryo transfer cycle if we need to perform a freeze-all strategy. Because to delay or not to delay a frozen embryo transfer will have at least the same results. Thank you very much for your attention.
Dear colleagues, on behalf of everybody, I want to thank Professor Blockhill for a wonderful presentation. Can you see, this is a very interesting trend we observe. A few years ago, we discussed freeze-all as a know-how which escapes hyperstimulation, everything is good, we froze all the eggs and embryons, then we transfer when it's convenient to the patient and all the stakeholders of the process. Now we have a reverse trend. We have to reduce the time from the moment the patient came to us to pregnancy. Because this time, the time is the most valuable resource we shouldn't lose. Let us see what will happen in a few more years after that. Now I want to invite to the presentation highly esteemed Uliana Sergeyevna with the presentation oocytes donorship expert practice or a fundamental approach. Dear colleagues, Uliana Sergeyevna, please. I want to remind she is the head of Oogen Bank of Oocytes, and she is also a head of oocytes donorship department in IV Med Clinic. Please. Good morning, dear colleagues. It's my great pleasure to be present here today. I'm thankful to the company Organon Ukraine to introduce the topic, which is very important, oocytes donation expert practice or fundamental approach. When planning our future, we have to remember what from everything started, and oocytes donorship started 37 years ago. For 37 years, we are practicing it up to now. 11 years ago, we started to use vitrification method. We do continuously improve it. This is a method which is very good for egg donation and which provided further breakthrough in its development. Oocytes donorship is an integral part of modern artificial assisted reproductive technology. The World Federation of Reproductive Association published the most complete global assessment of reproductive policy and practices condition up to now. The responders were centers and experts from 97 countries, from 132 countries where ART services are published. They were published in March 2019. Many of us also have got these 94 questions in English with translation, and we answered in the previous center where I worked in 2018. And for many countries, same for Ukraine, where a single official registry is missing. It is the only way to get information regarding the efficiency and globality of ART's use. You can see the map with the countries highlighted in blue. The countries who answered the questionnaire and submitted the information according to this information, the trends in use of embryos and gametes donorship in 2014 were as follows. Sperm donation was allowed in 64% of countries, participants of the questionnaire, but are conducted in 85% of all countries. Outside donation is allowed in 57% of countries, but is really conducted in 80%. You can see also the data for embryo donation accordingly. From the registry, from ESHRE registry, these are data showing only those countries where some number of donorship programs over 1,000 is conducted. This is the last complete register of EU countries for 2016. You can see that Ukraine is belongs to the number of those countries where in 2016, and this number is not yet complete, but it is already higher than 1,000 cycles. So we are already in the list of countries being leaders on the number of donorship procedures like Czech Republic, Greece, Russia, and Spain. General number of donorship procedures in making share of all the procedures at that time and made 7.6%. That's why it's so important to talk make aware of this treatment method. This is a choice method for those patients who tried all the modern approaches. Yesterday and today we talk a lot of poor responders. We selected the best suitable tactics for them, but for a great part of them the donorship will be the next step to achieve the so important maternity goal. Talking about more recent data concerning popularity of the approaches where outside donation is considered, it is not a scientific resource, but this is an independent resource where patients approach who look for the possibility of treatment through outside donorship. These are data for November 2019 to August 2020. Absolutely fresh data covering COVID period. At that period, patients considered treatment in other countries. Ukraine occupies a leading place, being the second after Spain. Ukraine is for today exactly the country and the location considered by our international foreign patients. And they trust Ukraine. We clearly know that we have successful programs and the efficiency is good, and professional and correct approaches are practicing there. You see there is a number of requests which grows in Ukraine for such treatments. Ukraine belongs to the list where Czech Republic, Greece, and Russia are also about donorship programs. So the trends for further development of donorship, they consist in. The need for outside donorship is growing from time to time. It is true that for many clinics of Ukraine, they are interested in such outside donorship programs. It means work with foreign patients, pooling the eggs in banks, working with embryologic material. It is a available, accessible practice which is already proven thanks to the market players which already were there present. This practice is efficient, desirable, and also improvement of vitrification technique allowed to improve survival and to develop outside banks. Also, the combination of demand and offer promotes development of logistics and cooperation between clinics. And global pandemic and limitations especially impacted development of export and import of biomaterials. I know how much it is demanded now. So if all the clinics of Ukraine will unite in offering treatments with outside donorship, even in that case, we will not cover the demand existing as of today in that area. You see in world map, you can see the transfer export of biomaterials from Ukraine. We all know the requirements to outside donorship. The procedure number 787 for ARTs in Ukraine describes it. I will not dwell on them, but it's very important to focus on general provisions, like, for example, blood test for HIV, B and C hepatitis, or for chlamydia. Because if you want to talk about international practice and the best practices existing, who knows why? For patients' treatment, we read publications, we follow guidelines, we are improving the processes we use, but in outside donorships for many practitioners, we use more basic approach. So let us consider world examples further on. Talking about the first criteria, donor choice. Donor age is number one. And what is the distribution in Europe and the world? Outside donorship has to be over 18 years age in 15 from 36 European countries where donorship is regulated. Maximum age has been defined in 25 countries. It's varying from 34 years in Serbia to 38 in France. In most countries, 35 years is upper threshold of donor stage. In some countries like Bulgaria and Denmark, the upper limit of donorship age is not regulatable in case of close relationship or well-known donors. Same happens in France, where egg sharing is main treatment program. It is not a pure donation like we are used in Ukraine. That is a patient who decides to share his biomaterial with other patients. If he has efficiency depending upon donor age, these are our data after distribution of donorship base and efficiency assessment in such provisions like the number of retrieved oocytes and follicles, number of used oocytes, percentage of blastulation, and overall percentage of oocytes used in treatment programs. We see that the group of donors over 32 years age has somewhat lower efficiency parameters. Accordingly, we do see that a need or a possibility to change criteria, our own criteria, so to limit the age of donor, to establish it at 32, not 35, like it is now according to our legislation. Also, we analyzed databases of outside donorship for 10 recent years. We compared about 2020 outside donors profiles with 1,654 oocyte donor profiles in 2010. Comparison criteria view average age, number of children, children's average age from donor, AMH level, family status, employment, and motivation why she wanted to become a donor. Accordingly, we saw that not only age level of our patients is increasing, but also our donors become older. Practically, the average age difference 20 compared to 18 years is 2 years. Other parameters didn't change. The number of children, average age. We were not able to assess age in 2010. We miss it for all the donors in database. As of today, the database is updated. The average level of MH is 5.33. Family status, single or divorced. Woman, not working or partially employed. Her motivation is defined as compensated altruism. Regarding the known databases, which are absolutely open, you see the information from IGFA. This is 2017 update. Average age of British donors also was 32 in 2012, and all the next years, 31 years. You can see the distribution per age of donors group registered in UK every year. And you can see all the donors who probably are well-known donors or ex-sharing donors. And there is a group of from 30 to 25 groups. Confirmed fertility is a criteria to be included in donorship program in Ukraine, outside donorship program in Ukraine. It's interesting to note that just few countries like Ukraine, Belarus, Bulgaria, and Hungary is where donors should have at least one own child. This condition is desirable but not obligatory for outside donors in Romania and Sweden, but many other countries, practically all the rest of the countries with regulated donorship, also include women with no children for donorship. I would like to dwell on one of the rules recommended in Europe and in the world. This is the rule of psychological testing of outside donors. You see extract from good practice recommendations of ESHRE. And why this good practice recommendation was issued? Because we have to take into account that in donorship programs, not only the needs of donors, yes, it has to be considered first of all, but also a recipient's need and the need of the children who will be born as a result of donorship programs. What for psychological assessment of donors is used? To study some available psychological problem or psychopathy in donor candidate, study inheritance problem connected with mental health, possibility of team working and functioning in society, and also efficiency interact in many relations connected with donorship. To conduct psychological interview, clinic interviewing is made, observation of donors' behavior and testing. Testing allows in a standard and objective way to confirm information obtained during the interview. These processes are interconnected. You couldn't say about psychopathology without confirming it by testing. Same way, you cannot comment on the test without interviewing. The value of psychological assessment is different. First of all, it means interest and care about donors' interests, interest and care about recipient interests, and same interest and care on the interests of donorship program and on the clinic. So, the interest of all interacting stakeholders, including relationship with socium and solving the problems of attitude and fears. The results of psychological assessment and the assessment of potential instability or psychopathy foreseen potential psychological risks in the interaction with candidate donor. assessment of financial or emotional enforcement available to participate in the program, and the assessment of consciousness of decision taking to participate in the program and its potential consequences in the future. Also, the psychological assessment at counseling and testing is required in US and obligatory, and also in Australia. After 181 tests performed in our donors database, we have seen and we have selected potential unstable donors or donors with signs of psychopathology, 9%. We foresaw potential psychological risk in interaction with candidate for 11%. And we saw some enforcement to participation, 0%. And assessment of conscious decision taken, 78%. Also, it's important to genetically test outside donors. Although in different laws of different countries, it is represented differently. The recommendations of certain associations, including interpretation of family and medical history of donor to assess probability of disease. The family tree of third generation for the donor and its analysis, recommendations for genetic screening, obligatory testing for among the most critical infections in the population. In our population, that's karyotyping, cystic fibrosis, SMA, fragile X, phenylketonuria, neurosensoric deafness. Increased genetic testing for a selected cohort of donors, interpretation of genetic test results, and relevant genetic tests. The advantages of broad screening are broad spectrum of studied diseases, including tens and thousands and hundreds of genes, panethnic panel, new generation sequences, since when coding sequences are studied completely, not just for most frequently mutated genes. We studied 70 donors with 302 genes. You can see among critical mutations, no one mutation was found in the research genes. 14% of our genes. No one mutation was in 10%. In 10 donors, or 14%. All other were carriers of some mutations, critical or not. Most common was cystic fibrosis, the 10%, Smith-Lemli Opitz syndrome, 4.3%, mucopolysaccharidosis, 2.9%, and some other pathologies in insignificant amount. Also some non-critical mutations, with the most common hemochromatosis, Usher syndrome, inherited neurosensory deafness, and other mutations. You ask, what next? Shall we dissuade those donors from participating in the program? There's a great percentage of donors with found pathology. The recommendation is to conduct genetic matching. The male should be also studied. That is how we provide for potentially maximally healthy embryons. Next very important screening part is infection screening. We mentioned HIV, syphilis, and hepatitis tests in general understanding we have in our procedure, but in the world the testing method is clear: serologic screening or PCR for critical infections. Very often both methods are combined, and also the frequency. At least twice or even 3 times within donorship, outside donorship programs, infection risks for donors has to be assessed. And also, it's reasonable to have a limited quarantine term. For example, the last 9th edition of Code of Practice of British Association requires screening with PCR and serologic method also with a repetition through certain period of time and a quarantine period if no PCR was made in some repeated period. On top of that, the laboratories conducting the testing of outside donors have to be certified by ISO according to ISO 15819. Unfortunately, not very broadly is the standard present in Ukrainian laboratories. Talking about screening algorithm, upon the results of 841 contact with potential donors by phone call and completed online form, 319 were not allowed after the primary conversation due to social psychological factor taken into account, or as a candidate refused after knowing about all the conditions of the program and reading through the contract, understanding the liability for participation in the program. 237 were not admitted due to medical contraindication by ultrasound gynecologist or viral reserve testing. 4 were excluded after infection tests, 9 after gynecologist testing. 1/3 of patients were admitted for further complete examination and stimulation programs. 3 from 10 potential candidates become our donors. What changed in the approaches, in the medical approaches and in management tactics for outside donors? All we understand those gold and maybe single standards, the only standards that were before. Long GnRH agonist protocol, CG trigger. As for today, the only correct protocol with agonist and GnRH antagonist protocol. We don't use oral contraceptives for donorship programs. The donors are planned with no oral contraceptive. Estrogenic primer is possible. Progesterone use, random start is a routine approach to site donorship programs. Programs with use of fresh donor material were changed by use of vitrified donor oocyte. It is absolutely equal in efficiency, both clinical and embryologic, and also with a proved economic reasonability both for the clinic and the patient. How should be an ideal protocol for outside donor? Ideal protocol should provide for synchronous growth of homogenic cohort of follicles, growth and maturation of optimal number of antral follicles, and optimal amount of drugs should be spent. What is most important, this protocol has to be safe for the donor. We have to understand our responsibility for management of such protocols, because this is an altruistic approach of our outside donors. Those are absolutely healthy women who have their own wish to pass this procedure. So we should divide any unprofessional practices like donor puncture without anesthesia, unprofessional puncturing, stimulation, or even just communication with such patients. An ideal protocol should be clearly understandable for the donors, which has clear dosage, which results in the parameters we want to achieve. And often we use in our practice chorefolitropin alpha. I believe same for you, it is a drug choice, and drug number 1 in outside donorship programs. There is a positive fact with this drug that it is controllably administered and it has a prolonged action. So you shouldn't control administration or introduce other concomitant drugs. It is safe for the patient. It's good for our group of outside donors. The average MAH level in our database is 5.3. For normal responders, for donors, AMH level 3.1, we use it as a practice. For those who have AMH higher than that, we use daily gonadotropins. Also, our donors state that it is very suitable, comfortable for them to use a long-action sustained release 1 week injection. It's much more comfortable. Also, inclusion criteria for donors is assessment of reserve, ovarial reserve. And here, each clinic has its own practice. Each professional has an opinion about antral follicles count and AMH level, and calculation of stimulation drug dose for primary oocyte donors our team uses. As for the hidden age of donors, here age and AMH level. This is a start FSH dose. If we assess key efficiency parameters, we compared here the group of donors with inclusion criteria. We had a practice of using inclusion criteria like AMH over 2 micrograms per milliliter and AFC over 14, and other group with AMH over 3. Inclusion criteria was much higher, and AFC number over 23. The comparable actual number of initiated cycle 300 with higher criteria, 310 with lower criteria. You see number of follicles, average number of oocyte per cycle with AMH over 3 is 27 compared to other group. Inclusion over 3 is 19. Correlation of retrieved oocytes to the number of punctured follicles is accordingly 87-81. Correlation M2 to retrieved oocytes 85-81. Percentage of utilized oocytes, those who have been taken from M2. We have to select oocytes with not only embryos should be tried, but oocytes also have their own morphological criteria, being their quality parameter, not only morphological but also genetic ones. Accordingly, we changed the laboratory and not for AMH change level and AFC, but for embryological lab factor. Utilization factor was different, 94 against 94. So our team has no predefined norms of a correct number of oocytes for donorship programs, but our KPI state about such norms as a number of oocytes to be used after morphological assessment from 20 to 30 oocytes. You can see that the inclusion criteria over 2 micrograms per milliliter in 21% of the programs, those have been with less than 12 oocytes. We believe this criterion is low, obviously, because from point of view of economic feasibility and from point of view of that we ourselves the control inclusion criteria, we have to get more than 12 oocytes for the category to be used in the cycle. According to these parameters, we conduct analysis of every donorship program after its completion. In case of deviation from optimal outcome, we correct it, we plan next stimulation program. Regarding maximum number of retrieved oocytes, it's a frequently discussed question. What was the greatest number of oocytes in your donorship program? How it correlates with efficiency? It's our own study where we divided the groups of donors per number of oocytes retrieved in treatment program. You see groups from 1 to 11, from 12 to 35, from 25 to 35, and 31 plus. And the data for the number of retrieved oocytes, matured oocytes, percentage of vitrified oocytes, matured oocytes for UXC, overall number of utilized oocytes, blastulation, and used embryos rate, we practically don't see a difference in KPIs such as fertilization, blastulation rate, and used embryos rate. But there is certain reduction in oocytes, in mature oocytes. So the ratio of mature to harvested oocytes is reducing with increase of the cohort of oocytes. I believe it's not rational to get over 30 oocytes per puncture, although with correct donorship management, such a cycle absolutely will be safe with correct trigger, with correct function management structure, and monitoring of donor condition after program termination. Talking about other practice, Anna Kobo presentation shows that in their practice, they retrieved 30, 35, 40, 43 oocytes, and the cumulative birth rate with use of such donor oocytes is increasing. With increased number of retrieved oocytes, we have cumulative growth of efficiency. This data compare time of ovarian stimulation start for donors. I already mentioned for our team, this is a huge sampling where we confirmed absolute safety and efficiency of random start of stimulation for site donors with the only condition absence of dominant follicle at the time of stimulation protocols beginning. The parameters are not different for number of matured and used oocytes. Same there, these data are confirmed by world publication on that we have to have an optimal number of oocytes which will increase the chances for pregnancy. When we use oocytes for the patients, the more oocytes will be used, the higher will be efficiency. You see in the screen the comparison of cycles with 8 oocytes used for patients program and 12 oocytes. Accordingly, the parameters of efficiency in the programs with 12 oocytes were higher. Such parameters as pregnancy rate per cycle and cumulative pregnancy rate. What's important regarding the point of view of international experience, availability of registers, certain type of ART national registers exist in 32 countries of the world, and it's important. The register of donors exists in 16 countries, and it's obligatory for everybody. It is organized by a competent authority in 6 countries, or by Ministry of Health in 3 countries, or other government authorities in 3, or by professional associations like in Sweden, or it's given to volunteers like in Iceland. A maximum number of donations is important. It is shown per country, and also it's important to monitor the number of newborns. It's due to that if you come back to the interest of many market stakeholder players and many clinics to exit to the international level, such questions will always be put, and we have to be ready to that. If we don't focus, if we don't collect this information in our own register in one or other ways, it will be reflected. For example, IHFEA update 2017, you can see data on Ukraine that in 2015 there have been 9 donors registered in HFEA through cooperation, and there is efficiency of oocyte defrozen rate, blastulation, clinical pregnancies in 1626 and 1773. So in the remote clinical perspective, the clinical efficiency will be known not only from marketing tools, and that's why it depends upon how can we advertise ourselves, but the real efficiency will be available same as in US National Register, publishing the number of defrozing of biomaterials, and the expanded information is given according per by the licensed center which provided this biomaterial, which produces biomaterial. It's important to select all sites using morphological quality criteria, same as we select embryos. But Birul will talk more about it. He will talk about it in his presentation. I've introduced you to morphological distribution efficiency numbers. You see comparison of all sites efficiency K1, K2 with much higher survival and fertilization rates and much better blastulation compared to Q3 category, which were somewhat morphologically different. So to have higher efficiency parameters, the sites should also be sorted out. A unique new methods NGS testing of our sites. Our team proposed it. Everybody knows young women also are APOLOG carriers, same as donors, and the group of donors which were examined, over 20% of our sites were unemployed. Accordingly, when the patients want to use donorship materials, they want much higher efficiency parameters than for our sites. There is a sense to conduct NGS testing of our sites. As regards clinical outcomes per all sites, the data are different in different clinics and the populations where they used. Each component is important. Same regards the staff working with donors, recruiting, who controls screening process, medical and embryologic process, pregnancy rate per one defrozen. But one thought those sites can be different from 3 to 12%. Conclusions. Outside donorship is important and integral part of modern assisted reproductive technology. The criteria for site donor selection are important for success and efficiency of programs. The principle do not harm should be a priority for such category of women. Clinical KPIs are shaped up according to clinical group. They are not clearly predefined and can be personally adjusted by a clinical expert. The protocols for working with outside donors should be added and adapted according to international recommendation. Expert approach will provide for success in each direction, same in this direction. I'm sincerely thankful to you for your attention. I'm ready to answer your questions. Dear colleagues, it's my pleasure. It was my pleasure to listen, as always, an interesting presentation and saturated presentation of Uliana Sergeyevna. I have some questions. Being a facilitator, I shall ask those questions. Our audience eventually also might ask this question. Uliana Sergeyevna raised a very interesting and important topic: creation of national register of outside donors. I'd like to ask a question. How do you see, Uliana Sergeyevna, the possibility to create such a register in our country? We all try to go towards Europe, towards civilized medicine. And the fact we don't have such a register is somehow limiting our opportunities. How do you see this? How could it be organized by Ministry of Health or by voluntary basis? What is your opinion in this area? Because eventually we shall raise this question with our Ministry of Health. Thank you, Galina Volodymyryvna. It's a very topical issue. That's why I included it in our today's presentation, and as I gave an example of the registers existing in different countries of the world. How are they organized? As a matter of fact, we have many reforms ongoing in the health sector of Ukraine. It can be organized by a Ministry of Health. It can be a profiled, a dedicated committee. It can be an association. Very important with all those options is for us, being professionals, is issue to initiate, and we already talked about, to bring to the end what becomes more and more. We should bring to the end the creation of this register. In 2021, in May, there will be a final decision on registration of biomaterial created outside of EU to be registered in EU. This decision is very close to be taken, so it's very topical and urgent. So we can initiate it with a dedicated committee of the association or of any other associations. There are different examples available. It's important for the clinics to cooperate. It's next question. Should be an independent association with many cooperating clinics. As of today, we don't have it. We have the single authority, Ukrainian Association of Reproductive Medicine, but it covers the whole industry. What is your opinion? Should this register unite all RT cycles, or should it only concern donation cycles? Because in most countries, those issues are united. All ART programs registered are there, and then a separate link is sorted out, the donor cycles. Ideally, would be to have a register of all activities in ART technologies in Ukraine. Even if we consider the questionnaire by International Federation of Fertility Associations, there were 94 questions. It takes 1 hour, 1 hour and a half to completely fill in this questionnaire for the entire area. All of us submit a report. Obviously, the report has to be edited and expanded when talking about the goals of oocyte donorship. This report can serve as a basis, but it has to be reviewed and edited, or an alternative option should be created and implemented. Thank you. Thank you. It's very important for you to discuss this issue, because I believe it will be the next step and next task for our Association of Reproductive Medicine for the next year. Another question for you. You gave wonderful statistics for genetic mutation testing of donors. Certain number of these donors participate in the program eventually before they have been tested genetically. What's your opinion? How should we inform the patients who already used these oocytes and that new data appeared for some genetic examination of those donors? Currently, this category of donors which was examined using new algorithms, those were primary donors who participated for the first time in our donation programs. So we don't have biomaterials of these donors. We didn't use them earlier. Once more, this issue regards to the previous issue of an open register. We understand if the donor comes for the first time to our clinic, even if she says it is her first donorship program, she might hide 6 times of being a donor in another clinic. The critical mutations, as I do see it, and the recommendation of geneticists we also follow, is not to use donor oocytes with critical mutations available without conducting genetic matching with the partner who will use these oocytes in treatment program. So we propose, knowing about mutations, these oocytes could be used under condition of partner testing. If partner is not testing, then those oocytes wouldn't be used in future programs. Thank you very much. It's very important. Genetics is developing very quickly, and there is a great demand from the patients on that the donors should be tested very thoroughly. By the way, it's not indicated in our order, so most clinics don't perform it, but we do not know that certain percentage of donors, even those with healthy children, anyway, are carriers of serious mutations. I believe it's next step to be considered to improve our new order to be issued. Thank you very much, Elena Sergeyevna. We shall continue our meeting, and our next presentation will be by Birol Aydin, who will talk about advanced technologies and machine learning in ARTs. He will talk in English. Birol is the head of embryology department in Ivy Med Clinic, and he is also scientific director of Ovogen Bank. Birol, I'm very happy to welcome you.
To see you. Please, Birol, we are happy to hear your presentation.
Thank you very much, dear dear colleagues, dear doctors, and participants. My pleasure to meet you today, and I will try to share my experience. And thank you very much for such high-level scientific organization to Ukrainian Association Reproductive Medicine Organization Committee. Also, I would like to say many thanks to MST company. They always support us as a medically, also as scientific based. They never leave us alone. So today I try to prepare a kind of presentation. Mostly as embryologists, we try to find out some scientific issue which we can use at daily practice. So I try to prepare different videos which all embryologists can use in their daily practice, and I believe they will get the benefits on that. So when we try to check for future development in IVF, there are different categories. We should organize the laboratory. We will talk about morphological oocyte assessment, embryo culture, how we should culture the embryo, how we make the embryo selection the best embryo for the embryo transfer, how we should manage witnessing, while in Ukraine mostly we are working for egg donation and surrogacy cycle, and witnessing is really important for us. And the genetic part is the main part of IVF now, while IVF is developing so fast. Now we are in the pandemic period, and all of us already tired from this, but what big advantage given that pandemic period, we have enough time to read more and to find a more scientific research for our development. So let's talk about the laboratory, what we should do in laboratory to get better benefits, and what will be the future development for the IVF lab. So of course, for automation, for the lab quality management is really important. We will go to details on the next slide, how we can automate the quality management in the lab. Time-lapse technology, how we can invent time-lapse technology in our lab at daily practice. Microfluidics, especially for male factor, how we can avoid the risk. Artificial oocyte activation, while if we have high age group, reproductive age group, how we can manage a better quality of blastocyst outcome from the low quality of oocyte. Mitochondrial transfer, this is the third party of IVF, how we can give alternative to egg donation, who doesn't consider to make egg donation. And of course, accreditation and registration, which are now very important for each lab to show to their patient and their agencies, the doctors, to be more trustful. So the laboratory daily digital control is very important. While if we back the 10 years before, how we were doing, we were taking a note everything, we were measuring, calibrating, and take note. Now we are working a more automized. So we can control a daily humidity, carbon dioxide level, the pressure, temperature, even our phone application, even if we are not in the lab. So what will give us advantage? Of course, we will solve any question while we are not in the lab. All risk factors we will be avoid. Regarding to gas parameter, which is very important for our incubators and embryo culture. like a lab atmosphere, especially for the temperature, to optimize particles level, which is really affecting directly to embryo development, and oxygen level control while we are doing many of the storage we have in our labs, all of us. So how we can avoid the risk from the oxygen risk for the staff side, embryologist side. As you see, there are different kind of automation which we are using now in the lab, so which we can control the incubators for the different parameters for surface temperature, carbon dioxide level, and carbon dioxide pressure in the incubator. Sometimes we may have a problem, especially when we get the gas from the supplier. Gas can have inside part of air which can give a damage to our incubator sensors. So how we can avoid such risk? Of course, such automation always give us opportunity to find out. So work area, lab area, how we can control humidity, pressure, and also temperature. Also that one can be automated by online work and online application through by our phone. And fridge, so which we are using all media, which we should keep in a cold chain between 2 to 8 degrees or -20 for some of the media and biological material. So how we can control that? Also, we can use automation for that. This is part of automation for the different things, while we can automate the pH measurement directly from our incubator during the culture from the day 0 to day 6. We can know how media giving a reaction for pH range, different factors. While we are opening incubators, we are checking embryos, we are changing fish, we are using one-step media, single-step media. Do we need to change even single-step media? How we can find all of this information by such automatical measurement will give us a big advantage. Also cryo storage, how we can control level of liquid nitrogen, how we can control quality of liquid nitrogen and the temperature if we are using a different kind of dry vapor. So also electronic map, while we are using it, many material inside, when we take the material, automatically we can release from the tank, from the storage, and also we can make on the time of witnessing, electronic witnessing, which we can control safety of the biological material. Quality management system for your in vitro fertilization clinics laboratory. Why we need to bother for that? Actually, that is the main factor. Most of the lab, if we back 10 years ago, they were more focused about the embryo culture. But if we back to now, we are trying to get high quality of air system, high quality of incubators we are trying to use, and many advanced technologies we are inventing to our lab to get a better result, because we already find out, research already find out, there are many factors which have a direct effect to embryo culture, and especially unemployed rate on the embryos. So time-lapse technology is a really important, because continuous monitoring of embryos via time-lapse provide more information about embryo morphokinetics and morphology development daily, because we are not able to find out such information directly under regular microscope checking. And embryo selection is really important, while we have to choose the best development of the embryo. Most of the embryologists, when they consider to get time-lapse technology, and clinic management is asking, oh, how much we will increase our pregnancy rate if we get a time-lapse incubator? Actually, it is totally wrong question, because a time-lapse is not a kind of technology will increase your pregnancy directly, but it will protect your level, and it will give you optimized level for embryo development and embryo selection. So embryo selection, we already know, is not depending just for morphological criteria. While we are checking the most important things, if you are using a time-lapse, 27 hours of a cleavage development. If we have two options in front of us, and day 3, 72 hours of compact embryos, also we have, which we determine different embryos on a 27 hours get early cleaved. If both of them go to blastocyst, one of them can give high quality of blastocyst, but early cleavage can give BB quality of blastocyst. Of course, my choice will be the BB quality because early cleavage embryo has a better morphokinetic activities and can give a more potential for implantation. So time-lapse imaging allows to make a more detailed assessment for morphological assessment. So while we can measure directly if we are using even some kind of software which is implemented as artificial intelligence, size of blastomas, size of zona pellucida, size of embryos, degree of fragmentation, and different parameters as well. This is typically how time-lapse activity are working for the morphokinetics. When we start from day 1, from the zygote till day 5 or day 6 blastocyst development, as you see, there are different image B and C shows a different fragment levels and different blastomer zones which can directly affect the morphokinetics activity. So if we check that those direct cleavage and more than 6-cell image, so we will find out time-lapse morphokinetic activities directly will measure development of blastomers as well by individual. So that will give advantage for the time-lapse to suggest us best potential of the embryos. The use of morphokinetics activity for the implantation, while as we said, for the embryo selection is a much more important to get an early cleavage phase and morphokinetic activities, we will find out from the implanting embryos and non-implanting embryos and different range, we will see when the morphokinetic activities is high and better, we get much more implantation. When we choose the embryo by ourselves, like direct morphological criteria, implantation rate is much more lower. Because in each different hours, development hours, from the day 0 to day 6, we have a different morphokinetic activities. So embryo can start to develop perfectly till day 3, but after that, morphokinetic activity can get some damage for the different reason, for mitochondrial activity, for culture media, or like a gas parameter can affect, or aneuploidy can affect. So that kind of morphokinetic activity, especially if we are not using NGS or PGD techniques, so to avoid the kind of risk, will be better to use, of course, morphokinetic activities, and that can be possible with time-lapse. So what about microfluidics? Microfluidics is mostly working as a sperm chip technology. So what it does, actually, how we are using actively in our practice. Mostly when we make a spermiogram test, we find out morphology, we find out progressive motility, concentration, and everything. But when we go deeply, after the especially karyotype, to make sperm DNA fragmentation test, even for the normal zoospermia, sometimes we find out a very high sperm DNA fragmentation. In this case, microfluidic sperm chip is really helpful because inside has a different channel. When we put the outlet channel to spermatozoid, when spermatozoids start to swim in the channel, so kind of activity inside of the channel, also like a morphological activity, because in the head there are carry out as DNA on the spermatozoid, especially in the acrosome side. When sperm start to move inside of channel, only high quality of the DNA of spermatozoid will reach the final destination, an inlet droplet. So when we get the spermatozoid from this side, most probably we will find high quality of DNA of the spermatozoid. Of course, that will increase the chance of fertilization, and that will increase chance of high quality of the blastocyst as well. Now I will try to show in a video how actually sperm chip technology is working. As you see, when we leave the sperms from the outlet, most of the sperms just stay on the beginning, and they cannot swim because of the liquid inside of channels does not allow if sperm doesn't have high quality of the DNA breach. So when DNA have a high quality, just all sperm get the main final destination, and we can use them for the fertilization. So this is our work already published in different publications. So we just show how high DNA fragmentation in a control group and blastulation rate in a control group and a sperm chip technology, how it affects. As you see, when we use the sperm chip technology, like a fertilization rate is high, but when we use high DNA fragmented of the spermatozoid regularly without sperm chip, of course, fertilization rate will be low. If we come to blastulation rate, same as well, and 3 times higher result we can get with the sperm chip technology. Also, for the donor oocyte, even if we use with sperm chip technology with oxidative stress test, also because oxidative stress test directly correlated with the sperm DNA fragmentation. Mostly when oxidative stress is high, sperm DNA fragmentation also getting high. They have a positive correlation. Same result we get on a fertilization rate, not as critical as DNA fragmentation, but still fertilization rate and blastulation rate much higher with sperm chip technology. If we check effect of microfluidic sperm sorting on the fertilization and blastulation and implantation rate, we find out already very high result with the sperm chip, almost 7 to 8% more than a regular way, even with the normal zoospermia factors. Another important thing is artificial oocyte activation. There are 2 kinds of artificial oocyte activation. First is as chemical activation, which exactly can give a kind of result, but which we cannot measure directly the effect of chemical artificial activation. And another one is a piezoelectric stimulator activation, which we can give a kind of electrical way and try to open calcium channels, to stimulate calcium channels and to pass more calcium inside of egg. So if we check the result on the fertilization, we find out with activation, we have a higher fertilization rate, mostly very high day 3 cleavage rate, better day 3 embryo growth rate, and very high blastostem pregnancy rate. When we look through the video how piezoelectric artificial activation is working, it is so simple. Just we are trying to give a wave of electric to channels, and calcium channels is opening and giving much more activity to pass calcium inside of fertilized egg. What is the advantage of this one? Firstly, we are increasing mitochondrial activity. This is a very important, we are finally increasing the energy inside of oocyte. And second, we are increasing the balance of sperm and oocyte activation. And third is, which is important, we are also helping for the oocyte maturation, while sometimes we cannot control when we do ICSI timing, we can miss out cytoplasmic activation, maturation. So if we check the effectiveness of the ICSI with piezoelectric stimulation, we will find out, according to the research from Volkan Baltacı and team, we find out with a piezo group, we get, this is a sibling group which has at the same time tried with piezoelectric and without piezoelectric in same cycle from the same group of oocyte, and we find out very high fertilization rate and grade 1, grade 2 embryo rate with a piezoelectric group. So what about mitochondrial transfers? This is the third part of the IVF, and it is just direct alternative to egg donation. So for the mitochondrial transfer, we should have kind of parameters while we should do mitochondrial transfer. Not only the alternative for egg donation, but also high maternal age, polycystic ovarian syndrome, low ovarian reserve, different genetic factors, especially for mitochondrial disease, endometriosis, because it's increased directly the quality of the oocyte, and mitochondria in an egg cell breakdown. As you see, there are two kinds of video here I will share with you. One is for pronic layer transfer, another one is spindle transfer, and I will try to talk about details how it works. For the pronic layer transfer, when we open the zona pellucida, we just try to take out fertilized pronic dose, fertilized oocyte, to take out the pronic dose and to transfer high quality of the donor oocyte. What is the advantage of that? Actually, we will use a mitochondrial DNA, high quality of mitochondrial activity in the donor oocytes. We will use exactly DNA of the biological mother and father, but we will use 1% of the total DNA of the mitochondrial DNA from the donor eggs. So what will give advantage? It will help for better morphokinetic activities during embryo development, and also from the energy factors from mitochondrial activity will give much more advantage to get higher chance. If we talk about the spindle transfer, it's a similar way. We will not fertilize the oocyte, but we will use pure male DNA with a spindle. We will use a special spindle weave technology. We will just aspirate the spindle and then transfer to, by the same strategy, to inside of donor oocyte, while donor oocyte have active mitochondrial DNA. But of course here, much more important, to avoid any kind of cytoplasmic DNA carry-up, we are using special vectoral virus here to avoid any kind of cytoplasmic DNA fragment, which will increase also chance of DNA mix-up. So we are trying to give a pure DNA, just inject the inside of donor oocyte from the biological mother directly in the spindle. So if I talk about outcome and our experience, we already done a 29 embryo transfer from the pronic layer and spindle transfer. 13 clinical pregnancy we achieved, and from 13 clinical pregnancy, 6 live birth already get. So technique is, of course, working well, but still need time to develop much more and need to support with more scientific publication. Let's talk about accreditation and certification. Actually, there are two positive things I can say about accreditation and certification. Firstly, you can protect your laboratory standard and you can follow up regularly, because accreditation and certification always control your lab. And the second thing, of course, all of this quality management will increase your practice and your quality of job as well. So there are different accreditation and certification programs as HFEA UK, FDA USA, ISO certification, European fertility certification, and CAP registration, which if you have several of this, that means your laboratory is going under high quality of the standards. Morphological oocyte assessment, why important? Well, important because we are working for egg donation, most of us, and most of us making either egg banking. When we do morphological oocyte assessment, we detect the oocyte with a different way, not just to make a denudation and check under a microscope and to say, okay, this oocyte looks fine, let's freeze. No, because egg banking has also commercial value, and it should be carefully, while patient considering to pay big amount of money, less number of the cells, and of course they are expecting pregnancy. How we are making a morphological oocyte assessment? Zona pellucida detection by the pulsoscopy. So we are doing with the pulsoscopy technology, spindle weave technology, and we are measuring the zona pellucida birefringes and thickness. Meiotic spindle detection by liquid crystal technology is very important. While we have a lot of information, when we visualize the meiotic spindle, we have a better fertilization rate and blastocyst outcome. Artificial intelligence-based oocyte morphology assessment, I will talk in a future slide, and you will see how we optimized artificial intelligence for the morphological oocyte assessment. Actually, this is the first in the world like which we are working directly for morphological assessment for artificial intelligence. Time-lapse imaging and video during oocyte vitrification process. that's just to protect how we done all process. Sometimes you are just sending your frozen oocytes to different clinics or patients, and next embryologist is saying, okay, we thought this oocyte, but there was no survived egg, or there was no egg even in stroke. So this kind of time-lapse imaging and video during oocyte vitrification protect your reputation as well. And donor oocyte polar body NGS testing, also this is a unique technology which can avoid aneuploidy risk from the oocyte. What we consider cumulus oocyte complex morphology, zona pellucida thickness, perivitellin space, first polar body appearance, oocyte shape, meiotic spindle location, is there any granulated cytoplasm or not, centrally located granular area, and a time-lapse activity of the oocyte we are considering before to choose oocyte for egg banking. When we look to meiotic spindle determination, abnormal meiotic spindle always affect directly chromosomal configuration and can increase aneuploidy rate of oocyte as a complex aneuploidy, which will give mostly cleavage arrest. So you have a perfect oocyte as morphological, you are towing, survive perfectly, but on day 3, embryo stop in 3/4 cell and not developing. So one of the big reasons for the meiotic spindle damage. So each donor oocyte are observing before the vitrification process to locate at the meiotic spindle place. Even time-lapse image can be sent to a practice clinic which will work this material. They can find out where is the location of meiotic spindle, and they can make a fertilization without risk of meiotic spindle damage. So this is how meiotic spindle can be determined and can be worked by ICSI technology, because sometimes meiotic spindle can be in a directed direction of your ICSI injection pipette. So it can give a direct damage if you touch the meiotic spindle. Yeah, it's not so common, but it is practically possible. And if you give the damage of meiotic spindle, mostly your egg will not fertilize, or will be degenerate, or will have cleavage arrest. So this is the publication with meiotic spindle and without meiotic spindle. If we check day 5 and day 6, there were huge difference for the number of blastocysts. So that shows aneuploidic risk is getting lower if you determine a meiotic spindle. Embryo culture, when we talk about embryo culture, we should talk about single-step embryo culture or sequential media. This is a big dilemma, which one have a better result. So culture oil quality, culture dish quality, and especially how we can optimize temperature of the culture dish and general pH and temperature for the media. If we check the single-step culture media versus the sequential media, according to a different study, actually there was no such significant big difference between the single and sequential culture media. But in the practice, what is important, if you have a stable lab, if you have a high quality of air, if you have high quality of incubator or time-lapse, then it will not be a big question while you are using sequential media or single-step media. But if you have non-stable lab, which you can not manage so easy, which you cannot invest to your lab to develop quality of the lab as a structure, then best way, of course, to use a single media, while you will not make many manipulation. You don't need to make a change of dish. There are still pHs question, but at least you can protect your embryo culture and embryo quality. When we check about oil, quality, which type of oil we are using can influence the quality of embryos. There are two kinds of oil. One is a regular light oil and another is paraffin oil. When we check between regular light oil and paraffin oil, we find out that paraffin oil gives a better outcome. What is the reason of that? Because of paraffin oil has thick layer. So what does mean thick layer? So it can affect directly to, firstly, about components which is coming like particles or such effects from outside the culture dish. Paraffin oil can protect much more. And the second thing, so paraffin oil can protect temperature balances much better than light oil. So that is the exactly difference between paraffin oil and light oil. But if you are asking, there are a huge difference between as an outcome, no, it's not a very big difference, but especially again, same as I was talking about single step and sequential media. If you have a best lab condition, if you trust your lab condition, as for me, there is no difference between light oil and paraffin oil. But if you have a doubt about the lab quality and quality management, so then you should choose a much careful way, and to use a paraffin oil will protect much better. Let's talk about the temperature, because it's a really important. Most of the clinic and embryologists are working with a single drop. So when you work big amount of media in a culture dish, like 500 microliter, 1 milliliter, is more easy to protect temperature balance in incubator. But when you use a micro drop, and when you try to make a different manipulation as you are doing the biopsy, fertilization, daily checkup and change. Of course, the temperature on the drop depends on the surface of the dish can be changed. It's very important how you set up your heating area on the microscope and the laminar flow. So that is the best way, of course, to measure periodically your heating surface and to find out how it affects to your drop temperature, because it can also directly affect your drop temperature, and it can increase evaporation rate. When evaporation rate is increasing, free water inside of the media will be spread and will destroy your pH level. So then on the dish, you will find out regularly 7.2 to 7.3 pH, and it will dramatically increase to up to 7.5. Why? Because you get a temperature damage, water increase inside of free water inside of the drop, and already imbalance your pH. So this is a different dish, Petri dish measurement in a different temperature surface. As you see, sometimes when you set up your laminar flow or heating stage on the microscope, even to 40 degrees, you can find out type of dish which shows only 30 degree of the temperature. So we are waiting, we are expecting to find a 37. Yeah. In the second, you see the 41.8 already set up laminar flow, but final dish temperature is 34. So how we can avoid that? Of course, the type of dish very important. So when you choose the dish, you will try to take care of thickness of the dish. So when thickness is increasing, of course, temperature balance is much more difficult to keep it. So you will try to decrease thickness of the dish. You will try to use certified, CE-marked, even FDA registered Petri dish, which can have already tested for also temperature balance. This is also one new advanced technology for round spermatid injection technique, which can give chance who doesn't consider sperm donation and they are azoospermia, which we make a testicular surgery and we couldn't find any spermatozoid, so we can find out round spermatid injection. This is a kind of how we are using IVM technology for the oocyte. It is a kind of IVM technology which we are trying to develop spermatozoid from the round spermatid cell. So if you see the video now, you will find out how we are making a round spermatid injection. So we just isolating round spermatid, and we just inject as we are doing ICSI inside of oocyte. So it's a totally same way as how we are doing intracytoplasmic sperm injection. We are just fertilizing this oocyte with a spermatid. But after that, of course, we should support that with artificial oocyte activation, which will help to maturate this sperm and develop this sperm. So for these techniques, of course, chemical oocyte activation will not work. So we need to use piezoelectric oocyte activation to develop round spermatid to get a spermatozoa and to fertilize this oocyte. Also, single sperm cryopreservation. So sometimes we have a very low concentration of sperm. Even we make a testicular surgery and we find out only several spermatozoids, we are not able to use a fresh cycle, but we need to freeze. In this case, this device will be very helpful, which you see in the image. So that device will give individually selected sperm, which we select, or which if we have chance only find one sperm and find out after the thawing and to fertilize. Or we have many sperm, like we have case of, for example, round spermatid. We have case of globozoospermia. We have case of Oligoastana teratozoospermia, and we have only one high quality of spermatozoid as a morphological. We can use this device and we can freeze this sperm safely, and when we thaw this sperm, we will find out easily. Let's talk about embryo selection. So when we talk about embryo selection, we have to consider pronuclear scoring, early cleavage timing, early blastocyst formation, morphokinetic activity, time-lapse, and artificial intelligence. Of course, what I am saying, all of this can be possible if you are using advanced time-lapse technology. So if we are talking about pronuclear scoring, why it is important? Because when we manage the pronuclear scoring can give a directly information about early cleavage timing. So they're connecting. If we have a regular pronuclear formation, that shows that embryo will have a possibility and a potential to develop regularly. Early cleavage timing, as I said, as for me, should be the main thing for embryo selection. I'm putting side of NGS testing, of course, but the main thing for the embryo selection, for the transfer, early cleavage timing. So if you are using time-lapse, just go to 27 hours to see if your embryo start to make early cleavage. This is the best choice for you for embryo transfer. Early blastocyst formation. So this is, you check the 27 hours, you have a 3 different options on the 27 hours to give early cleavage. But you check, you got a 2 morula and 1 early blastocyst on day 4. So which will be your choice? Of course, the early blastocyst, which start to develop much better and faster. Morphokinetic activity, which you can measure only with a time-lapse technology with artificial intelligence model. So it will give you best opinion about embryo selection, because you will find out also morphokinetic activity. Time-lapse and artificial intelligence will complete all these things, what I am saying, and will give you direct answer without any human factor. So if you check the study, like they use different embryo selection methods. First is with aneuploidy screening, other with metabolomics with time-lapse technology. And they find out a different kind of pregnancy outcome. According aneuploidy screening, of course, we get the best result because, as I said, morphokinetic activity doesn't mean just you have a euploid oocyte. Morphokinetic activity just shows that those embryos have a potential for euploidy, but it doesn't mean direct information about euploidy. Still, even if you have a time-lapse, even if you are using morphokinetic activity software, still you need to consider to make aneuploidy screening. So this is from USA yearly report for different kind of techniques for the embryo selection. As you see, like a cycle every year increasing, implantation rate every year increasing, and also live birth rate every year increasing. So what is this result? What is happening to help this increasing? Of course, is a main thing when age especially increase, woman age, still we see like a result is increasing. Of course, they are implementing advanced technology and they are using a much more automated lab technologies to increase the chance of pregnancy. Electronic witnessing, as for me, it should be, especially in Ukraine, while all of us working with egg donation and surrogacy, it should be priority for every lab to have a witness technology. While we are using, of course, human witnessing, I understand like each process can be checked for 2-3 embryologists, but still there are chance to get some kind of biological error, which I will show in some result. You will understand what I try to explain. So this is a kind of electronic witnessing model, how it works. So when donor or patient come directly to the doctor visit, all process start for the witnessing. So just this patient got the identification of electronic witness system with rice band, with electronic chip, RFID chip, for the all Petri dishes, all biological material, tubes, blood, sperm preparation, cryostropes, for all step identified by RFID chip. So if you have any kind of mix-up or mistake by embryologist or human factor, so RFID automatically will find out. This is our study which published in ESHRE. So you can find out in a lab, different lab, I'm talking about 15,000 IVF cycle, which is really high from the different clinics which they share with us their experience. And as you see, even each lab has 2-3 embryologists which making a witnessing. So 14 times during punction, we get error. So in denudation, 17 times. When we go to transfer, 68 times. So that means those labs are using electronic witness system. If they don't use electronic witness system, that means from this 15,000 cycle, 68 cycle could be biological material mixed up. So believe me, this occurs in every lab, because it's difficult to avoid if you are working with different nationalities especially. So electronic witness will avoid this risk. If you check during vitrification and thawing, even much more error rate for the witnessing you will find out. That's why for your safety, for your patient safety and clinic safety, electronic witnessing system should be priority as for me. Let's talk about the genetic screening for the PGTA, carrier screening, PGTM, endometrial receptivity mapping, aneuploidy tested oocyte, which is totally new technology which we are working on it. So PGTA, why we are doing, we are trying to find out, even if we are working with egg donation cycle, we are trying to find out which embryo has aneuploidy risk potential, and to avoid this and to get with a single blastocyst transfer in the first time pregnancy, especially on the surrogacy. So carrier screening, of course, before to go PGTA and all. So we should have a carrier screening for the donor cycle. We should avoid kind of mutation. You can find out such mutation, which is very rare, but I have experience, even for the very rare carrier screening, still male and donor can be matched. So even chances of 1%, but still this can be happen. And this is a risk, especially if you are using this cycle for the surrogacy. PGTM, there are a lot of monogenic disease. Of course, we should actually, like my experience in Ukraine shows, we should develop much more in Ukraine as a clinics to work more for monogenic disease and to avoid risk for those patients and for next generation as well. Endometrial receptivity mapping. So endometrial receptivity mapping, this is a very important, like to find out exactly implantation window through the genetic analysis, through the different chromosomal measurement, to find out when exactly we can find out receptive endometrium. Especially if we are working with a surrogacy cycle. Of course, they have a proven fertility. Even in Ukraine, for me, much more safety surrogacy and egg donation in the world in Ukraine. Why? Because we are using the proven egg donor and proven fertility egg donor and surrogacy. So, but even in this case, it's really difficult to control sometimes to endometrial receptivity on the surrogates. Also on the patient, of course. How we can avoid that, of course, endometrial receptivity testing is helping so much to detect exactly implantation window and to detect receptivity period and to transfer embryos. Especially if we have a single embryo and single chance, this is the best to use this technology. Aneuploidy tested oocyte, I will talk then about next slide. Still, we have to know 20% of egg donors, donor egg even, should have aneuploidy risk. This aneuploidy risk can be carried up after the embryo development and also can give result for embryonic aneuploidy. So there are two kinds of techniques I will show. First is a polar body biopsy, how we are doing aneuploidy screening from the donor eggs. We just make a zona hatching. It's a safety. We are just trying to aspirate polar body, and just we are making NGS testing for polar body. This gives us advantage, especially if patient get only 4 to 6 donor eggs. So we are able to give opportunity to patient to get from us a directly euploid oocyte. That will decrease the chance of aneuploidy on the embryo. Of course, still there are sperm factor, male factor, but as all of us know, mostly aneuploidy risk carried up by the donor eggs and normal patient eggs. So from another side, for the regular biopsy, for the trophectoderm biopsy, for NGS testing, which also should be considered for every case before the single embryo transfer to increase the chance of pregnancy. If we check about different age group of the egg donor, which our experience from the oocyte polar body testing, you can see we find out from euploid oocyte, euploid blastocyst matching rate 89%, even young donor group 91%. That means from the 91% of donor oocyte, which we analyze and we find out euploid, that will be directly euploid blastocyst. So it is very important for us and to consider to make this test to give high quality euploid oocyte to our patient. So if we can come directly to machine learning, so machine learning is important for best embryo selection for transfer and cryopreservation, best morphological oocyte selection for egg banking, a comparison of multiple parameters, and automate embryo and pronuclear scoring. So this is how artificial intelligence is working, is directly detecting on the pronucleus stage the pronucleus, and to make automatic annulation system from the PN till blastocyst development. So this is how system is ranging for high quality of blastocyst, which has a higher implantation rate. So system will give a different score for implantation rate. As you see in the image, it gives 7.8, very high for implantation rate, and system suggests us the transfer. So this is, as you see, how artificial intelligence detecting it like a pronuclear development in the different blastomeres also. And on the left side, you see the blastoma development, and right side you will see the morphological oocyte selection by the artificial intelligence. So this is how system is working. System is detecting different criteria from polar body morphology, polar body size, zona pellucida thickness, diameter of oocyte, and collecting all of this data and giving us a best quality of morphological oocyte for cryopreservation and egg banking. So this is between embryologist and machine learning about grading oocyte. So when embryologists grade the oocyte, 81% of quality one in the same group of oocyte, artificial intelligence say 71. So there are always a 10% of difference between artificial intelligence and regular morphological selection with embryologists. So if we come to conclusion, new laboratory technologies give better outcome. Artificial intelligence and machine learning avoid selection risk. Electronic witnessing need to be used in every IVF lab. Azoospermia and male factor have reliable solution. Egg donation and poor egg quality may have alternative, and responsibilities and risk factors may reduce for embryologists with advanced technologies. So thank you very much for your time and participation.
Fantastic presentation, really a lot of interesting and new information. We are a little bit out of schedule, so only one question for you. Your opinion about spindle view. How it improved the fertilization rate? It is a lot or little bit, or what is your opinion about this technique?
Spindle view will not affect the direct for fertilization rate. So how it can affect if you are giving damage to spindle during ICSI. So then, of course, it will affect fertilization rate, but it will not happen often. But it can affect the direct for morphokinetic activities of the embryos. So if there is no visualized spindle, that embryo will not develop like a regular, will increase the chance of aneuploidy, and of course a blastocyst outcome will be lower than visible spindle. So it works like this. A direct effect of fertilization, I cannot say like a 10% or 20%. Depends on fertilization technique also.
Okay, thank you very much once more, and we will move to another presentation. Шановні колеги, я хочу від всіх подякувати.
Dear colleagues, I want on your name thank Birol for his wonderful presentation. And the last presentation in our section is my presentation. It will regard the variability of stimulation response, whether is it predictable and what should be done with it. My task is much easier after the previous speaker's presentation. Accordingly, I will try to stick to the schedule. So let's talk a little bit about the variance of response for stimulation. What should we do with it and why it happens? Our section regards oocyte donorship. So I give the example of our donor cycles because those are the cycles which expectedly have to have a good response, good egg quality. It's always sad when it doesn't happen. Let's look at the reasons which could create such sadness. Let us talk about the following. Why donorship is topical? Ulana Sergeyevna talked a lot about this. What from outside donorship program success depends how the inclusion-exclusion criteria should be response variation and standardization or individualization. As you know, there's a trend in ART clinics today that every decade the average age of deliveries is increasing 2 years averagely. If this trend will not stop, then in this century we shall have average delivery at 50 years of the mother. Obviously, it goes against the physiological norms. That is why, eventually, probably, the percentage of donorship programs and the interest towards donorship programs is increasing. We know that the educational level of women is increasing continuously. Employment level is increasing. Women are having higher and higher social demands. So we see the trend to delay delivering. That's why patients come to us when they have the age we cannot use their own eggs. This is the data of National ART Register from 19 and 20. What we observe here, the women after 35 years of age make 46%. These are aggregate data from all the clinics. We have this trend in Ukraine, same as all over the world. This is comparison of National ART Register data for the programs between years 16 and 18. There is a difference in 2 to 3 years. We observe that the percentage of donorship program was 7.5, now 8.8 programs. The interest to this topic is growing. According to the data of our clinic in 2019, the average age of the patients every month, we do see that in good months, so to say, it is about 35.7 years. In bad months, the average age makes 40 years. Yes, the patient don't come to us when young. Accordingly, when the average age is 40, we understand a great part of those patients will need use of donor oocytes. This is the analysis of our data on the number of patients and on the percentage and number of donorship sites. Since 2014 are those data, and we do observe the number of increased cycles. A small reduction happened in 2020. We all know, unfortunately, due to the pandemic, and we have about 10% reduction in the number of overall cycles. In the same way, the number of donorship cycles reduced, but this year the situation is already improved. For the first 4 months of this year, we see that we did over half of what was achieved in 2019. So there is a trend to overall growth of number of sites, but at the same time, the percentage of the use of donorship oocytes is increasing. This is a graph showing how many donorship cycles will begin in the same way. In 2020, we have a little drop, but this year, in 4 months, we did as much as during the entire last year. We see the percentage of donorship cycles 17, 18, and in this year we have almost half of the donorship cycle. It is connected with creation of the bank of donorship oocytes, and the demand for donorship programs is also increasing. Let's talk about inclusion criteria for the program. Olena Sergeyevna talked about those criteria. Those are our standard requirement described in MOH order. We are trying, our goal and task is to get at least 15 oocytes, meaning 15 to 20 antral follicle with AMH over 3. Why so? Because we all know that AMH over 3.5 is already too large, too a high response to stimulation. We know that's 20-25 oocytes, and we know there's correlation between AFC and retrieved oocytes, and between AMH level and AFC there is a linear correlation. If MHE is about 3, we shall have 15 to 20 oocytes. This graph shows it a little bit better. This is our cutoff, 15 oocytes. Why so? Because in reality, not all oocytes of the donor can be used. Not all oocytes are of good quality. Both Birol and Olena showed that even the eggs of young donors, they have lower quality. We see that the so-called Q1 oocytes make about 60-70% of all the oocytes. In 9 to 10% of donors have only low quality oocytes. Talking about their use, we have to take this all in account. We calculated the statistics for 2019, so to understand what is the minimum number of oocytes required, we were based on that averagely. We got 26-27 oocytes from a donor. After we got 70% of MH cells and a rather high fertilization rate, we had averagely 9 to 10 blastocysts. From those, about 60-70% were of good quality. Accordingly, to have approximately 4 to 5 blastocysts, we have to have such number of eggs, nearly 20%. Accordingly, To have 2-3 blastocysts for transfer, we have a minimum of those 15 oocytes. That's what we are relying upon. But analyzing the real statistic, what do we see? Having such criteria, inclusion criteria for this program, having the criteria on AFC, the standard stimulation protocol, and good levels, good AMG levels. We had, for example, the analysis for this year of 174 punctures for oocyte donors. We have got less than 12 oocytes. Why so? We expected as a minimum 20 to 30. Why so? Because up to 30% of cycles showed not matching our expectations. 9.7%, the number of oocytes was substantially lower than expected. In 16%, however, we have got the response higher than expected. It's not ideal because it's difficult to, we have to ideally clearly forecast and match with the expectation. There is certain discordance between cycles. What could it be caused by? It could be connected to stimulation protocol with start dose of gonadotropin type of gonadotropin protocol type. Can be connected to suboptimal response, trigger response. We shall dwell on it separately. It can be connected to that the woman has higher weight and the pharmacodynamics of the drug is a little bit different. There can be a problem connected to the accuracy of detection or measuring the ovarial reserve. We dwelt on it more in detail in yesterday's section, and we shall talk today on the clear and accurate determination of ovarial reserve using AMH specifically also can be variable. There can be mistakes in administration of drugs, exactly triggering. There can be technical problems during pickup. Our standard protocol for oocyte donors stimulation is corifoliatropin alpha and then the relevant agonist and trigger with a GnRH antagonist and trigger with agonist. Why the weight is so important? Because we know that the pharmacodynamics of the drugs is different depending upon the weight, body weight. You see on the slide the woman of different weight, the difference in plasmatic FSH concentration is almost double. That is weight. The weight matures in certain cases. The publications show that when comparing women with BMI 18 and lower compared to BMI less than 27, it is not yet obesity, but already the excessive weight. We see reduction of FSH additional dose by 20%. If the weight will be higher, then the difference will be also higher. We analyzed maybe our variability was due to a different body weight. We compared oocytes, donors. We see the age is averagely similar. AMH is different, but excess of fat can influence AMH level. So as a result, it could be a little bit lower than in reality. So we compared women with different BMI. You couldn't say it is too high, 26, but anyway, it's higher than norm. And we haven't got basically any difference in the average number of used FSH, nor in the average number of oocytes. A little bit less in women with higher BMI, but it wasn't there wasn't statistically significant difference. Accordingly, in the protocols we use, and with BMI not higher than 28 or 30, we can say that the use protocol doesn't give a significant difference in the output, in the rate of oocytes and in their quality. Pay attention to the study on comparing folitropin alpha and daily RFSH. We compare this data, how women's body react on dose depot or daily injections. This comparison and imitation models, it was proved that 150 micrograms dose was sufficient, and both with weight over and under 60 kilograms produced similar number of oocytes. The design of the study was to compare existing studies and compare daily doses with depot doses in low, middle, and high responders. We shall not dwell on that in detail. I just want to show that all the studies showed that the use of chorefolitropin alpha, this final result, gives averagely more oocytes, approximately by 10%, gives better stimulation response, and basically with BMI not higher than 28-30, doesn't show great difference in the response to stimulation. It's very important in donor protocol with use of donor oocytes, because we use to do them most standardized and most comfortable for our donors and patients. It is first of all connected to that the synchronization of the cohort of follicles, because in the standard protocol with antagonists and daily doses we have recruited not all the follicles due to, now I will come back to the slide where it came, where we have, when using the depot formulation, we have excess of this FSH dose, which allows to maximally recruit all follicles sensitive to stimulation. That's how chorefolitropin alpha in women with high ovarial reserve allows to get optimum regimen, thanks to separating the critical necessary threshold. In those women, no critical increase of SSG and no reduction of oocytes quantity is observed. We know exactly if we administer this dose in clinic, it will work. Second reason for variability could be the variability of AMH. We have to understand what we get from analysis of measured AMH and from real AMH in the blood. Those can be quite different, absolutely different values. Variability could be due to physiological reasons like intra and intercycle variability. Such states as obesity and pregnancy can be caused by oral contraceptives or some hormones, namely estrogens. AMG variability could be connected to cooling, prolonged storage with under 30 temperature, preliminary warming of the sample can influence AMH level after testing. The analytical stage, same variability can make up to 10% depending upon what equipment this testing is made on. If you have variability influence, if one factor variability, for example, if the real AMH level in the woman is 1.5, we can get the measured from 1 to 2, in the range between 1 to 2. If there are 3 variability factors working simultaneously, not frequently, but it can happen, we can have from 0.5 to 2.5 variability. Then you have to have it in mind. You have to determine ovarial reserve based on several factors. One of reliable factors is assessing of viral reserve by AFC. You all know very well about this, and there is a guideline on how to do it correctly. And currently, modern ultrasonic devices allow to obtain more accurate diagnostics for viral reserve. Obviously, it can depend upon whether the patient takes oral contraceptives, if she is treated with agonists. It can depend upon the constitution, endometriosis, other factors. This variability can make in different menstrual cycle periods up to 50%. So if the woman has a second phase of the cycle, if she has functional cysts, sometimes you should recalculate for the beginning of the cycle when it will be more adequate. Another important point connected with variability is the trigger of final maturation of oocytes. We have the following statistics here. We have the system of control of trigger response by measuring LG second day after trigger. Anyway, in 25 cases, from 712 punctures of donors, we have got very unsatisfactory maturity, notwithstanding all the adequate parameters of LG. Also, the literature says the mistakes, the errors are main problem of the situation during the management. In our case, that mistakes were not very high, but those have been kind that when only the solvent was introduced or in correct time, but in most of the cases that was inadequate response to trigger. This problem of superreaction to antagonist trigger revealed in that the women will have low level quality of oocytes, reduced blastulation, and reduced frequency of pregnancy rate. In donation cycles, we cannot use chorionic gonadotropin because it's connected with hyperstimulation risks. Accordingly, we try to prevent this complication in such a way, but we have to understand how shall we do, what shall we do in case of suboptimal response to agonist trigger. Same relates to the so-called empty follicle syndrome, when the eggs are not retrieved at all. These are interesting works to this regard, which were published, which show that depending upon what level of progesterone and LH we do have next day after triggering with agonist, we can plus or minus forecast, shall we have oocytes or shall we have conduct repeated trigger with antagonist. This red dots low level of antagonists, yellow with insufficient matching, and these black dots when everything was good. It can be said that the successful level of progesterone upon the threshold from which we can calculate for retrieval of these oocytes when we had triggering with agonists and measuring next day after the trigger, it is minimum 3 to 5 nanograms per milliliter. It has to be minimum 12 to 15 units. What else influences this suboptimal response? Very low levels of LH the day of trigger. As a rule, it happens with the women who took oral contraceptives for a long time. If we have 0.1 level, then we have up to 25% risk of suboptimal trigger response. If we have too high total dose of gonadotropins, we can have a risk up to 5% of suboptimal response. If the body weight is increased, we have the risk of this suboptimal response. Knowing that, we can forecast when such problems could be expected and prevent them eventually by using double trigger. The algorithm of work in such cases should be the following. If we have trigger with agonists and we perform time measuring in 12 hours and have received the values of LH and progesterone lower than those shown, then it's desirable to conduct the same day repeated triggering with antagonist. If we have better figures, we perform the puncture. If we have no X, we repeat the triggers. Other causes which can produce abnormal trigger response: early atresia of oocytes, receptor mutation, abnormal bioactivity of certain series of LH antagonists, increased hepatic clearance, and mistakes. So, dear colleagues, as conclusion, I would like to say that the use of standard protocols of stimulation with choreofolotropin alpha allows to obtain optimal recruiting both with normal BMI and with increased BMI. The dose of gonadotropins has to be increased additionally if we shall have BMI over 28-30. Have to see this as well. If under 28, this bolus dose allows basically to obtain optimal reproductive notwithstanding body weight. AFC and MAH markers sometimes might be not very exact to show ovarian reserve. You have to know about it, pay attention to it. You have to thoroughly collaborate with the laboratory testing for AMH so that this parameter could be as efficient as possible, because it may have high variability. You have to pay attention to final oocyte maturation trigger, because it also can substantially influence the final quantity and quality of oocytes. Thank you very much for your attention, dear colleagues. I want to say once more, I want to thank once more Organon Ukraine company for the support, with the support of which we conducted this wonderful session. Unfortunately, we completely exhausted our limit of time, so it will be my pleasure to answer individually all of your questions. So thank you very much once more. I'll meet you again.
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Bizen Healthcare – це світовий фармацевтичний лідер інноваційних гормональних препаратів для жіночого і чоловічого здоров'я. Сьогодні Безен – це всесвітньо відома сімейна фармацевтична компанія зі штаб-квартирою в Монако під керівництвом 5-го покоління сім'ї Безен. Наші зусилля сфокусовані на жіночому та чоловічому здоров'ї, замісній гормонотерапії, вирішенні проблем фертильності, акушерстві та гінекології, урології та андрології. Ми перші на ринку інноваційних продуктів винайшли трансдермальні форми на основі гелю, ідентичних ендогенним гормонам – прогестерону, естрадіолу, тестостерону. Надали світу перший мікронізований прогестерон в капсулах для вагінального та перорального шляхів введення. Препарат Утрожестан.
Доброго дня. Good afternoon, dear colleagues. We continue our symposium. It's my pleasure to open a new section, the seventh section under the name Systemicity and Rationality of Using Hormonal Correction in IRT and Obstetrics. We have 4 presentations from those 2 by our guests. It's my special pleasure to give the first floor to well-known specialists on the issues to be discussed today. Mr. Paul Piet, professor, scientific and medical advisor of Bizen company. He is from Belgium under the name Pharmacodynamics and Safety of Progesterone in IRT, what clinicians should know. Mr. Piet, please, if you are online, the floor is given to you.
For this nice introduction, and I want to thank the organizing committee and the UARM to invite me to this very interesting webinar. And my presentation of today will focus on the pharmacodynamics and the safety of progesterone as luteal phase support in assisted reproductive technology. And I will try to answer the question about what clinicians should know in this field. We all know my financial disclosure slide. I'm a consultant for the Sun Healthcare Global Company. So what I was focusing on my last publication in the YBEO journal last November 2020 about the pharmacodynamics and the safety of progesterone is the importance of the nature choice when you look at intervention during pregnancy. And as you may know, natural progesterone has a unique pharmacodynamic profile and certainly a unique safety profile, but it will also depend the route of administration. So progesterone is a real fascinating molecule. And what's very unique in the pharma industry is that we are using extensively progesterone in IVF procedure, but the discovery and the use of progesterone was due to one Nobel Prize, his name Adolf Butenandt, who was the first to be able to synthesize progesterone and to identify how it works, at least in IVF procedure, later on, due to Sigard-Jones. So very uniquely, 4 Nobel Prizes were involved in this fascinating molecule. And as I published 2 years ago in Climacteric Journal 2018, it's in fact a never-ending story. So the first message from my presentation is to emphasize that different progestogens may differ in their hormonal activity depending on their structure. For example, here you have 2 close molecules, progesterone and dydrogesterone, but you can immediately see that progesterone is a flat molecule and that dydrogesterone is a truncated molecule with a different chemical structure. You have a double liaison here that you don't have here. And as a consequence, dydrogesterone, which is a chemically modified molecule, will have small structural changes in the configuration of the parent steroid molecule, which is progesterone. and that will induce considerable differences in the activity of the derivative. So small difference in structure, different metabolism, and I will show you different pharmacological activities. The route of administration is also very important, and looking at the same molecule progesterone by different route of administration, oral, vaginal, or intramuscular, you can see that at the steady state level, only the vaginal route of administration and at least a daily dose of 600 milligrams a day progesterone or 200 milligrams twice a day will deliver an adequate progesterone blood level, which is above this kind of magic cutoff level of 10 nanogram per ml, which is the recommended blood level when you go, for example, to the FDA to get an approval for luteal phase support in ART. You have to demonstrate that your drug is able to increase the blood level by 10 nanogram per ml, which is the case of the 600 milligram daily dosage. And that's the reason why most of the centers around the world are using 600 milligrams a day for IVF. Interestingly, when you administrate progesterone by intramuscular route of administration, even if you administrate lower daily dose, 100 milligram, you will reach 5 to 7 times more progesterone as a blood level comparing to a natural luteal phase. So you have to increase that much this blood level of progesterone to have adequate tissue level when you administrate progesterone by intramuscular route of administration. So in this publication last November in the YBO journal with a nice impact factor of about 5, you can see the unique pharmacodynamic profile of micronized progesterone for pregnancy maintenance. But what's important in this cartoon is to look at not only the effect of the mother molecule, which is progesterone, but also the effects of the metabolites, which are participating to the activity of progesterone, because they don't only activate or bind several progesterone receptors, progesterone A and B, for example, but they have also direct, very quick effect binding membrane receptors, which is not the case with synthetic progestogens or dihydrogesterone, for example. But that's true that all progesterones are able to induce an endometrium secretory transformation, decidualization, vasodilatation, and decreasing the apoptosis, promoting the extravillous trophoblasts invasion in the maternal decidua, and remodeling the local vasculature. That's the major effect of progesterone as luteal phase support to favor implantation. We know that progesterone, but also dihydrogesterone, modulates the maternal immune response, protecting the mother against what we call a semi-allograft, which is the fetus, because half of the genetic material is coming from the father. But what's unique with natural progesterone, and that you don't have with synthetic progestogens like dihydrogesterone, for example, or 70-hydroxyprogesterone caprolate, only the mother natural molecule is able to improve the uteroplacental circulation, favoring implantation and the maintaining of the early pregnancy. And for the implantation process, also what's important is to look at the reduction of the uterine contraction, the uterine contractibility during the implantation process. So progesterone decreases definitely contraction, and that's not only important in the late pregnancy, but that's crucial to favor implantation because most of the early miscarriage occur because you have an early contraction rejecting the trophoblast and making the implantation not possible. For sure, progesterone suppresses the fetal immunoplacental inflammatory response, and that's a key message because progesterone, on the contrary of synthetic progestogen like dihydrogesterone, is a very potent anti-inflammatory hormone. That's the most potent physiological anti-inflammatory hormone, and that's the reason why we can claim this is that it blocks totally the production of corticotrophin-releasing hormone, which is responsible for the release of inflammatory prostaglandin, who will induce the cervical ripening and who will induce the risk of premature labor in the late pregnancy. So, as you can see, progesterone and all those metabolites are very important to explain the efficacy in clinical settings. So before looking at the clinical data, let's go first to the guidelines and the recommendation. We all know the first recommendation by the American Society for Reproductive Medicine, published in Fertility Sterility 2012, but we are in Europe, and so I will focus on the ESHRE guidelines, which were published in May 2020, updated very recently in March 2021. But if you look at the full study report, the full guideline development group expert committee conclusion, you will see, and that was nicely summarized in Human Reproduction Open Access in May 2020, you will see that by the ESHRE expert committee, there is a strong recommendation for progesterone as luteal phase support in IVF and ICSI procedure. And that was stated in February 2019 and confirmed in May 2020, published in Human Reproduction Update. On the contrary, you can see that for dydrogesterone, even if in 2019 they were considering efficacy and safety being equal to progesterone, this sentence was not in the last update recommendation anymore, because the guideline development group of experts, even if they were considering that dydrogesterone is an orally active progesterone, different in structure from natural progesterone, there were some concerns regarding the safety for the offspring. And the guideline development group considered the data, even after the publication of the Lotus 1 and the Lotus 2 studies that George Griesinger was presenting yesterday, they were considering those data as insufficient to make a firm statement on the rate of congenital abnormalities, and because there was a lack of long-term offspring health studies. So we are waiting for further safety study with dydrogesterone. More importantly, when you compare progesterone to oral dydrogesterone with similar ongoing pregnancy rate, unfortunately, in the meta-analysis, and the one presented yesterday by our expert John Griesinger, the results from frozen and fresh transfer cycle were pooled, so questioning the validity and the robustness of those meta-analyses, mixing apples and pears. So we have to be very careful when you pull results in a meta-analysis before taking final conclusion. What about the dosing, when to start luteal phase support, when to stop, and how long? That's the ongoing debate. But looking at the ESHRE recommendation, we have to take into consideration that the dosing of natural progesterone has evolved empirically. So usually dosage are including several doses. It can go from 25 milligrams, but it depends the route of administration. That's for subcutaneous progesterone, till 200 milligrams twice a day when we are speaking about micronized vaginal progesterone in oil capsules. So the daily dose is depending the route of administration. We all know that we have to start progesterone as soon as possible during the luteal phase, and it should be between the window between the evening of the day of oocyte retrieval and day 3 post-oocyte retrieval. And that was nicely confirmed in a meta-analysis by Mohammed in Fertility Sterility 2019, showing that earlier you start luteal phase support, just the day or the evening after the oocyte retrieval, better the results. There is no consensus for the duration of luteal phase support. If you look at the ESHRE guidelines, they are saying that it should be administered at least until the day of the pregnancy test. But looking at the most recent guidelines by the National Institute for Health and Care Excellence in the UK, there is no evidence to support and to continue any form of luteal phase support beyond 8 weeks of gestation. So, and that's what probably most of the centers around the world are doing, using luteal phase support for 8 weeks of gestation. But based on a very recent data, we can raise the question, does vaginal progesterone supplementation improve live birth rate, for example, in women at risk for threatened miscarriage? And based on this last update of the Cochrane review published last month, you can see that for women with one or more previous miscarriage, and we agree that it's in natural pregnancy, but there are a lot of women with previous miscarriage in IVF pregnancies. And in case of early pregnancy bleeding, which occur often in IVF procedure, we know now with a good level of evidence that vaginal micronized progesterone increases the live birth rate compared to the placebo. So we can raise the question, is it a matter of a good sense to prolong a progesterone after 8 weeks of gestation, just in case of a higher risk of miscarriage? Is it the same story with synthetic progestogens, like dydrogesterone, for example? So is the question, does dydrogesterone improve live birth rate in women with threatened miscarriage? And based on this recent meta-analysis last month, the Cochrane review, the overall available evidence suggests that oral dydrogesterone probably make little or no difference to live birth rate for women with threatened or recurrent miscarriage. So the answer is definitely not with synthetic progestogen. The reason why you cannot mix the results with natural progesterone and some synthetic progestogen. And that was nicely shown in this very recent randomized placebo-controlled study by Shan, published in Human Reproduction 2020, December last year, showing clearly that in this placebo-controlled study, the number of miscarriages before 20 weeks of gestation, or even the live birth rate, didn't differ statistically from the placebo, even taking into consideration age of the woman, compliance, history of miscarriage, and excluding the abnormal fetal karyotypes. So none were correlating statistically with the results. And so we can have now, we can claim with a good level of evidence that oral dydrogesterone doesn't work for threatened or recurrent miscarriage. But moving from the general awareness to practical experience, what did we learn from clinical trials? And for sure, to take any conclusion, we have to balance effectiveness and safety. So comparing, for example, the PK characteristic of two major routes of administration for progesterone in IVF, painful, for example, intramuscular injection or vaginal administration of progesterone, we all know that intramuscular administration will lead to supraphysiological progesterone growth level. You need a nurse assistant to inject the intramuscular, and that's the reason why in Europe we don't use intramuscular progesterone anymore. And even some adverse events, like the allergenic reaction to the oil content of the injection, dry abscesses, of even sometimes acute eosinophilic pneumonia, were described after intramuscular administration. On the contrary, when you administrate progesterone twice a day, because the short half-life of progesterone to do the tissue, you will reach constant and systemic levels. You avoid the first hepatic passage, and that's very important for liver toxicity. When you administrate progesterone by the vaginal route of administration, you have no intensive hepatic metabolism, and there is no irritation of discharge depending the formulation. So even the formulation for your vaginal progesterone plays an important role in the patient compliance. So what about patient satisfaction? There was a nice comparison in the publication by Janu Polski in the US, published in Fertility 2010, looking at the convenience and the administration of the route of administration for progesterone, the ease to administrate, and the overall satisfaction of the patient. And you can see that the odds ratio was statistically significantly favoring the vaginal route of administration, reason why in Europe we don't use that much anymore intramuscular progesterone. An interesting publication by the group of Tomic was showing in 2011 that you can tentatively decrease the abortion rate or even the bleeding, which is really boring in the early pregnancy, by increasing the dose of progesterone. That was a study comparing the Crinone gel, the 90 milligram progesterone daily intake, with an additional oral progesterone, 300 milligram in oil capsules a day. And you can see that they were decreasing statistically significantly the abortion rate and the bleeding, which which was confirmed in the results of the PRISM study in women with threatened miscarriage and early bleeding. So, looking also at what is the clinical practice in the real world, and I think that the next speaker will address this survey, you can see that consistently vaginal progesterone only is used as luteal phase support, and the rate of use increased from 64% in the first survey 2009, and it go up to 80% now of the procedure, based on a very recent update of those survey done by the group of Brussels, where in fact they were the principal investigator of the Lotus-1 study. And so despite the results of Lotus-1 study, the non-inferiority study comparing progesterone to oral progestogen, you can see that the use of oral dydrogesterone or oral progestogen is very limited in a real practice in the IVF world, lesser than 2 or maximum 5% based on the most recent survey. So why is vaginal progesterone still considered by most the first option? Is it due to efficacy? And to answer the question, for sure, you can look at all the randomized controlled trial performed with vaginal progesterone capsules since the first pivotal study in 1992 at Brussels Fertility Centers by the group of Johan Smits and Paul de Vrooy. And you can see that since 1992 until 2017, the Lotus-1 study, there were more than 5,500 patients randomized in comparative or placebo-controlled study, looking consistently that there is an adequate clinical and ongoing pregnancy rate with a daily dose of 600 milligrams a day, which is the usual dose, or even, for example, in FET cycle, a daily dose of 800 milligrams a day. Comparing in terms of efficacy, the vaginal route of administration with the intramuscular one, which was considered as the gold standard for luteal phase support, you can see that you will have similar clinical pregnancy rate based on this pivotal study done in the 90s. But interestingly, that was the first study emphasizing the effectiveness of progesterone by vaginal route of administration to decrease the miscarriage rate during IVF procedure, and it was statistically significant. So I told you that probably the formulation of vaginal progesterone is also important. And when we were comparing in this blinded comparative study, 2 formulations of vaginal progesterone, the capsules, the oil capsules versus the progesterone gel, surprisingly, the positive ACG in clinical pregnancy were significantly higher with the vaginal capsule, and the equivalence of the treatments in terms of ongoing pregnancy rate could not be demonstrated because the ongoing pregnancy rate was favoring the progesterone oil capsules because the interval of confidence, the difference in ongoing pregnancy rate, did not lie entirely within the pre-specified equivalence interval rate. So all vaginal progesterone are not comparable. Looking now at non-inferiority study, we have to be very careful because before taking any conclusion. And if you look at the abstract of both Lotus 1 and Lotus 2 studies, the authors were saying that the analysis of the results were powered to consider only the clinical pregnancy rate, but the live birth rate was of greater clinical interest. So in conclusion, the difference between the treatments in terms of live birth rate observed in Lotus 1 and Lotus study should have been therefore made with caution. So before taking final conclusion in non-inferiority study, the study needs to be powered for the right endpoint. So is efficacy also related to the dosing or the route of administration? Again, when you do non-inferiority study, you have to be very careful comparing, for example, vaginal route with subcutaneous, because the daily dose is not the same. So you are comparing 600 milligrams with 25 milligrams, apples and pears. So before concluding that one route of administration is more efficient than another, you have to think about the daily dose. But at the end of the day, when you look at the public assessment report published by the UK agency, the MHRA agency, there was a clear suggestion that the subcutaneous administration, route of administration for progesterone at the dose of 25 milligram, which is the approved dose in Europe, was not as efficacious as the vaginal preparation. And that's the reason why the MHRA was suggesting the subcutaneous progesterone for women who might not be comfortable with using vaginal preparation and therefore might be of benefit to some women. So again, all routes of administration are not equal. Why is vaginal progesterone still considered by most the first option, even after Lotus 1 and Lotus 2 study? It can be also due to safety. And when you look at the safety and the comparative study, we have now more than 9,000 patients in placebo-controlled study, all placebo-controlled study, showing the safety on the neonatal effects, the health infant, the cost, even the cost effectiveness when you use vaginal progesterone, and that was demonstrated with a level 1 of evidence. So when we are comparing the safety of all those interventions in pregnancy, all the agencies in Europe for medicinal products will adopt what we call the precautionary principle. And based on this principle, they reject the indication of dydrogesterone during pregnancy because if an action or a policy comes with a suspected risk, for example, a risk of safety or to be harmful for the mother of the fetus, and in absence of scientific consensus, then the action or the policy, the burden of the proof that is not harmful fails to those taking action. So we have to wait for more safety data with dydrogesterone when using it in luteal phase support. And that was nicely confirmed in the publication last March in Open Reproduction Open Access, where the conclusion of the guideline development group of ESHRE was considering that there is no argument to consider an adaptation of the current recommendation regarding dydrogesterone for luteal phase support, just a conditional recommendation versus a strong recommendation for progesterone. And the reason, there are many reasons. And you know the publication that was mentioned yesterday by Joel Griesinger in the Lancet with an impact factor of 60, I remind to you, so a big peer-reviewed journal suggesting this association of oral progesterone, dydrogesterone intake during the early pregnancy and an association with congenital heart disease. And this most recent expert review of clinical pharmacology, again in a high-ranking peer-reviewed journal with an impact factor of 3.5, and that was not only based on the retracted publication mentioned yesterday by Joel Greenlinger, but that was a meta-analysis of all the study available with dydrogesterone during IVF procedure, including the Lotus 1 and the Lotus 2 studies. So we have to be very careful about the safety profile of dydrogesterone. That's a case report in the American Journal of Case Report 2020, reporting a fulminant hepatic failure in a woman attending an IVF center. She was pregnant after an IVF procedure in Thailand, and she was requiring an urgent liver transplantation, and for sure she lost the baby before the transplantation. Again, a mother taking dydrogesterone during the pregnancy. In this famous center of IVF in Singapore, there was also an abnormal high rate of fetal abnormalities, 2.4% from the live birth rate, and those women terminated their pregnancy due to fetal anomalies detected at the fetal anomaly scan. And so there were 7 cases in 290 live births. So again, we have to be very cautious when it goes to intervention during pregnancy. And as you look at the drug safety in placebo-controlled study during pregnancy, you can see that regarding the natural progesterone, congenital abnormalities, termination of pregnancy, in the PROMISE or in the PRISM study, we are speaking about 800 patients in the PROMISE trial and 4,000 pregnancy in the PRISM study. There was no increase in congenital abnormalities or in termination of pregnancy in the woman taking progesterone versus the placebo. So the safety of natural progesterone was also confirmed in this recent Cochrane review 2 months ago, published in the Cochrane Review Journal. But again, they were claiming that there are limited data or very low certainty evidence on congenital abnormalities and adverse drug events for the other oral progestogens, including dydrogesterone. So my final slide here is to raise the question, is it worth to monitor progesterone blood level during pregnancy? And I think that the next speaker will address this interesting question. But at the end of the day, we have to take in consideration that you cannot monitor progesterone blood level when you administer dydrogesterone, because to be active, dydrogesterone need to undergo an intensive hepatic first pass metabolism, and you need a highly costly and specific chromatographic assay to monitor dydrogesterone level. And even though we all know since the publication of Balash in the 80s that there is no modification of progesterone blood level when you administer dydrogesterone. So the key message is you cannot monitor progesterone blood level, certainly not in fat cycles when you administer oral dydrogesterone. So in conclusion, why should progesterone be the treatment of choice in IVF? We know that we have a first uterine path effect leading to high local uterine concentration. We have an optimal endometrial late secretory transformation because this daily intake of progesterone by vaginal route of administration with an optimal bioavailability. It's user-friendly, as it was mentioned by Janu Polski. It has been extensively used not only in fresh, but also in frozen tone embryo transfer cycle with a lot of clinical evidence with live birth rate as an outpoint, as a clinical endpoint, and not only ongoing pregnancy rate. And last but not least, you avoid the first liver and pass metabolism, which will not induce any side effects, irritation at the gastrointestinal tract when you administer progesterone by the vaginal route of administration. I thank you for your attention.
Благодарите.
Дякую вам.
Thank you very much, Paul. We have questions, but you know, we have to stay within time schedule. So unfortunately, I don't give you the opportunity to ask those questions. I thank you sincerely for your presentation. I would ask you to stay in connection with us. Maybe some time will be saved and we shall have the opportunity to ask questions to you during our further work. Dear colleagues, we continue our work, and it's my great pleasure to invite to the floor a well-known scientist of Ukraine. These are not just words, it's reality. Esteemed Professor Volodymyr Isakovich Vedmid, who is the head of internal pathology of pregnant in the Institute of Obstetrics and Gynecology. The topic is brands and generics. Using RT in obstetrics, precautions and grounds to be for the doubts. Please, Volodymyr Isakovich. Thank you very much, Svetlana Ivanovna. It might be the first time in my life when the name of my presentation will not be matching 100% its content. But I will tell you about brands and generics, about precautions and grounds to doubt, but I'm not sure that it will go about using them in RT and obstetrics. Another point. When I was preparing to this presentation, it was very interesting for me. I knew many new information, and I hope it will be interesting for you as well. So, colleagues, according to the definition by WHO, its experts, brand its original drug, firstly synthesized drug which doesn't have analogs and has passed complete volume of preclinical and clinical researches. The active substance of this drug is protected by patent for a certain time. Generic is a drug of a concrete manufacturer having the same content in active substance and the same formulation that the original, and its bioequivalency was proved. I want to draw your attention to the necessary conditions for the generics. Their bioequivalence to the original drug has to be proved by special studies. And the hybrid drugs, it's the third category of drug. It has the same content of active substances as the original drug, but may differ in either formulation or in administration route for active substance to go to the body or to the target organs. Brands and generics. Generics are the copied drugs, but the manufacturers say they will have the same efficacy and safety as in the original ones. Let us look whether it's true. I will give you examples which are very remote from obstetrics, moreover from reproductology. The first example is as follows. It regards aspirin. Everybody knows this molecule, very simple one, and which exists for a long time already in the medical practice. Acetyl salicylic acid by different manufacturers in the same dose and in the same formulation haven't achieved the efficacy the original aspirin was achieving, produced by Bayer. Nobody could understand why. What is the reason? Same molecule, same dosage, same formulation. Just with time, it was found out that Bayer has special method of crystallization of this drug. Here is the difference between brand and generic. Here is when talking about their interchangeability. Next example, Certains, very commonly used in cardiology. as antihypertensives and for treating heart failure. This study impressed me by its beauty of design and its volume. Look, 136,177 patients were followed up for 24 months in the period when there was a protection, patent protection of originals, and there were no generics in the market. The same patients, within 12 months after generics appeared in the market, generic certains appeared in the market, also were followed up. What was found? Such adverse events which enforced to refuse from the drug, to cancel it in this study. Before generics appeared in the market, that indicator was 0.0073, 73 ten-thousandths of percent before generics appeared. After generics, on losartan, INN, ethicyanine, 8% refused from taking, valsartan 12% refused from treatment, candicertan 14%. Imagine the difference between 0.073 and 14%. Thousands of time of difference in adverse events. And now the last, third example, clarithromycin as antibiotic. The study was made in US. It is a comparative pharmaceutical analysis, not by impact on humans or adverse events, by the structure of active substance, solvents, etc. The pharmaceutical analysis compared Classidum by Abbott with clarithromycin, clarithromycin with 40 generics. What were the results? In 8 drugs from those 40 generics, the content of the active substance was not to the standard. I want to repeat. The study was made in the US. 28 drugs had much slower solution time than the originals, and it's critical for antibiotics. And in 24 drugs from 40, the 3% threshold limit of allowable admixtures was surpassed. Here, colleagues, what we can say about brands and generics. And now, how the brand comes to the pharmacy? I give you very interesting numbers now. Every year, 30,000 molecules, new molecules appear, claiming to be in the future an active substance of the drug. Those are candidate drugs, candidate active substances. With time, only 2,000 of those, making 6.7%, pass the preclinical trial stage. Meaning many thousands even don't pass to clinical study because the scientists get disappointed even before those drugs comes to animal clinical studies. After the preclinical trial was passed, 200 remain, meaning 0.67% from those 300 and so thousand of primary candidates. They come to the first phase of clinical trial, 200. From 40 molecules, not drugs. 0.13% come to the second phase, 12. means 0.004% come to the third phase. 8 drugs come to pharmacies, meaning they have passed all stages and become drugs and are sold in pharmacies. And only one drug, making 0.003% of a percent, remains in the pharmaceutical market in few years. That is, colleagues, what means original brand drug. And another two numbers, from the synthesis of the molecule up to registration of the drug, they are about 10 to 5 years. And the average expenses of pharmaceutical companies to develop a new drug, which has the name original, makes averagely $1.3 million. What about brands? Okay, we shall come back to the brands. What about generics? There is a rather large list of a number of pharmaceutical factors influencing the so-called bioequivalency or interchangeability of drugs. That is physical and chemical properties of the substance, excipients used to formulate the molecule, ampoules, pills, candles, etc. All this influences bioequivalence of the drugs. And now, at the end, the registration of generics takes different procedures. The participation of healthy volunteers is very limited. Now a conclusion was drawn here that in obstetrics, especially in obstetrics, where the price of the mistake or of insufficient efficiency is too high when using generics, when there are big grounds to doubt. And this is a dramatic slide. Bioequivalence, unfortunately, doesn't mean therapeutic equivalence, clinical equivalence. But anyway, talking about bioequivalence, what it consists in, I would like all of you colleagues to answer me. Have you known about it before this second? There are 5 types of generics, and they are assigned with these letters B1, B2, B3, etc. B1 is the drug which interchangeability was proven by in vivo studies, meaning on the contingents of population of sick persons. Bioequivalence can be B11 when it goes about comparison with original brand, or comparison with other generic, B2 with previously authorized generic B2. The bioequivalence of this drug is proved by in vivo studies, solution test. Imagine what about it goes. They take a pill of brand and a pill of generic and dissolve it in water. And by the degree of dissolution, they judge. There is nobody to participate. There are no patients, no pharmaceutical studies, only based upon dissolution test. It is recognized that these drugs are bioequivalent. In my opinion, it generates many doubts. B3, bioequivalence is proved by comparing pharmacodynamic studies. In my opinion, this is the best way, pharmacodynamics studies, meaning the blood of the patients is tested for concentration, elimination curves are calculated, all pharmacodynamic parameters are calculated and compared to the brand. This new generic is compared to the brand or to the new generic. It is B3, but there is also before a drug which interchangeability is proved by comparative clinical studies, and the drug which doesn't need proof and confirmation of proved pharmaceutical bioequivalence. When we come to the pharmacy and we ask a drug using INN, who from us knows whether this generic is coded B4 or B2 or B1? Where from comes this information, colleagues? How can we be sure that when prescribing generic to our patients, she'll get exactly the effect and exactly the number of adverse events described for brand drug? At least we have to know what generic it goes about, B1, B2, B3, or B4. Also, after this B4, B5, there is 1 and 2. Where from can we take this information? I will show you where. I'm sorry, I'll show it here. In the United States of America, there is a so-called Orange Book. It contains complete information on the drugs which obtained approval of FDA with assessment of their therapeutic equivalency. The electronic version of this book is updated almost daily based upon and to the extent of appearance of new generics registration. This is, I would say, a serious approach which justifies the goal for which this book was created. What happens in Ukraine? We also have Orange Book here. Here it is the reference book for bioequivalence of drugs edited in the new edition of 2020. I was very happy when I knew we have such a book. Was preparing today's presentation, I looked through this book and I looked how can we assess generics of progesterone from the point of view of the efficacy and safety. Please look, this is a table of all generics available in our country, talking about progesterone. And except for those for position, to those for position B4, B3, B2, all regarding to the ampule formulations of oil solution or water solution of progesterone. No one oral progesterone or vaginal progesterone is labeled with this B1, B3, B4, meaning we have the book, the Orange Book, we have the table, the drugs are there on the shelves of the pharmacies, but no information on the equivalence we do have. That is where doubts are arising. Do we have a moral right to use those drugs in the obstetrics, in the reproductology, where the price of the mistake is very high one? In the guideline of World Health Organization regarding the registration requirements to determine interchangeability of drugs, it is said it's impossible. The impossibility to guarantee for equivalence can harm the health of the patients. Who is responsible for that? Authorization bodies and authorities should be responsible for that, but the prescribing doctor should get that information. American Association of Physicians doesn't recommend to prescribe a drug labeled by B2 code with FDA, mean generic code. Those are the drugs which, due to different reasons, couldn't be considered therapeutically equivalent to these relevant reference drugs. And this is the statement by the Association of Physicians in US. That is why, dear colleagues, in our clinic, I can know what happens in our clinic only. We do insist in using exclusively original drugs in most cases, and specifically when it goes about the need to use preservation therapy or maintenance therapy in different stages of pregnancy. We use utrogestan, which firstly in the history was created like micronized progesterone, like in formulation of soft capsules for vaginal administration. More than 30 years of clinical practice. It's registered, authorized in more than 100 countries of the world. In many countries of the world, US, Canada, EU countries, it's the safety of its use in early and late pregnancy terms was proved by many randomized controlled studies. And this table proves to unprecedented evidence base, which exactly this drug has. The RCTs of use of vaginal capsules of micronized progesterone for luteal phase support in ART cycles. Here it goes about ART already. Were made with involvement of almost 5,000 patients. And here are shown all studies based upon the principles of evidence-based medicine. Coming back to the general issues. What are main advantages of original brands? Yearly clinical effect, reduction of treatment time in many cases, better compliance, reduction of number of hospitalization, reduction of need for additional prescription, and reduction of treatment time for the so-called course drugs. Talking about antibiotics, the brands have the advantage to reduce the number of antibiotic-resistant strains. These are the reasons in favor of original drugs compared to generics. What are the realities in our country? What is the bioequivalence of drugs in Ukraine? These are the data given in the daily Gazette Pharmacy with reference to pharmaceutical workers. The brand is substituted by generics to sick patients who came for recommendation to generic 68%, generic replaced by generic 12%, generic by generic 20%, 100%. You see the reality. 68% of all replacement seems to the first glance it is the replacement of a more expensive drug for a cheaper one. This is the value of drug use, but switching from brand to generic, from original to generic, it is the main reason of adverse events, as it was proved already. Not to talk about therapeutic efficacy. Thank you for your attention. And now, Volodymyr Volodymyrovich Kotlik will join me. He is already in the studio here. Please let him pass here and sit down. Because my statement produced some confusion. Volodymyr Volodymyrovich Kotlik is near me. he has to introduce me, but it didn't happen. So Svetlana Ivanovna introduced me. Vladimir Vladimirovich, you have a debt because she undertook your function today. So do you have questions? If not, then I give the floor to the next speaker. Please take your seat, Vladimir Vladimirovich. Thank you very much for the attention, colleagues. And now our third presentation by Professor Peter Platon. He works in reproduction medical center of Brussels Vrije University in Belgium. Peter Platon is a very well-known specialist. You know him well because he also was coming to Ukraine and he had live presentations, not only online. Today's presentation has the name Luteal Phase Support, the Balance of Efficacy and Safety. Please, Mr. Platon.
Thank you for the nice introduction. I must admit that I would have preferred to be in Ukraine live than sitting here at home. But bon, because of the circumstances and the pandemic, it is not possible. So I will speak about luteal phase support today in this session. And before starting, I wanted to show the luteal phase in a natural cycle, in a physiological cycle. And here you see all the hormones, and I feel a bit embarrassed to show this to gynecologists, but this is the hormones of a menstrual cycle. And as you can see, the important one is the blue line, which has the LH levels, and the green one, which is the progesterone levels for the luteal phase. The blue line, LH, seems to be a very flat line with a surge and then again a flat line. But this is deceiving because, in fact, this blue line is an accumulation of LH peaks during the follicular and luteal phase, as you can see here. So, in fact, under the control of the hypothalamus, you get these LH pulses, which are different in amplitude and in frequency during the cycle. But it is these pulses that keep the luteal phase going. If you stop or interfere with these LH or LH pulses or amplitude, you will have a problem with your luteal phase. So what gives luteolysis? What interferes with it? Well, everything, as I said already, that interferes with LH peak. And a clear example is an agonist trigger that we use a lot in patients who are at risk of hyperstimulation. We give, for example, a triptorelin 02 trigger instead of ACG to make an ovulation. But we know that this trigger gives a much smaller peak of LH, a much smaller amplitude than in a normal natural cycle, which then has the effect on the luteal phase afterwards, which has a big problem and which needs to be supported, or we need to freeze all embryos. All the other problems that we see are due to ovarian stimulation during the follicular phase, where we create supraphysiological levels of estradiol and also progesterone. And I think it's mainly the high progesterones that interfere with the luteal phase, which then have an inhibition, a negative inhibition on the hypothalamus, where then the LH pulses will disappear and you have a luteal phase defect. Here you see it even clearer, this effect of the supraphysiological levels of mainly estradiol, but I believe mainly progesterone, which have a profound effect on the hypothalamus, where the LHRH is cut off, is inhibited, and then, of course, there's no LH pulses anymore, and this interferes with the luteal phase. So this is sort of the mechanism that we have in our IVF cycles when we stimulate, why we need luteal support. Here you see it even clearer when you have a hyperstimulated cycle, and this is a cycle where there is an induction with ACG. Of course, you have luteal support in similarity or in relation with the half-life of the ACG, which doesn't cover the full 14 days. It covers about 7, 8, 9 days. But then you have this gap of 3-4 days until the pregnancy test, and then you have the endogenous, hopefully, ACG that will take over the support, and there we could stop with our luteal support. But to cover this gap of 4-5 days, we have to give luteal support in our stimulated cycles in IVF. On the contrary, you see in a normal cycle, you don't need this. So here you see one of the older studies where people bravely did randomized controlled trials where we compared placebo in luteal phase with progesterone. And as you can see clearly in the pink bars, you see significantly higher live birth rate, ongoing pregnancy, clinical pregnancy, whatever, compared to placebo. So it's very clear that luteal support helps in our stimulated cycles. The other way is that if you do not give luteal support, it shows also that even with placebo or even no luteal support at all, you get live births, although significantly lower, which means that in every study that you do in stimulated cycles, IVF cycles, you have this effect that even without luteal support, you can have pregnancies. So I believe that in the future, and it's a pity it's never been done in the past, that these big randomized controlled trials for proving one luteal support against the other, the different medications, this should have been done in frozen cycles, egg donation cycles, which are fully artificial cycles, where their placebo will not give any pregnancy, which is clear. And I think for comparing drugs in the luteal phase, these artificial cycles should be used in the future and not IVF cycles. So what do we have for luteal support? And the first speaker already alluded to this. We have vaginal ones, we have rectal ones, we have injectable ones, intramuscular or subcutaneous ones, and we have oral ones, with all their pros and cons that have already been discussed before. So what about efficacy? And I'll show you a few slides where studies were done, meta-analyses were done, where one is compared with the other in a randomized way. And here you see intramuscular versus oral one, and there is no difference in efficacy. Here you see intramuscular versus vaginal or / rectal. There is no difference in efficacy. Here you see a vaginal one versus the oral one. There is no difference in efficacy. Then here you see low-dose vaginal versus high-dose vaginal. There is no difference in efficacy. And then you see the comparing between micronized versus synthetic progesterone, no difference in efficacy. Vaginal ring versus the vaginal gel, no difference in efficacy. Subcutaneous versus vaginal gel, no difference in efficacy. Vaginal versus rectal, no difference in efficacy. Sorry for the boring slides, but I think it's very clear that at the end of the day, with the evidence that we have, and we have numerous studies already done between these things, that there is no evidence that there is any benefit in efficacy between one or the other products that we have here on the market. So before going further, I just want to pay attention for a few minutes to some new things in luteal support. This is sort of a new trend that's coming up since a few years. It's mainly the Spanish group from Valencia that introduced this new concept, where they claim that if we measure progesterone levels on the day of embryo transfer, that if these levels are under a certain cutoff point, the pregnancy rate will be lower than if the levels are above this cutoff point. Further studies have been done in patients with frozen cycles, mainly patients who had PGT, so where all the embryos were frozen, that we know that the embryos were genetically normal, and then in an artificial cycle, in a frozen cycle, they were replaced. And here you see clearly that serum levels of progesterone on the day of the transfer, if they were lower than their cutoff point, the chances for a pregnancy or a live birth were significantly lower than if they were above this cutoff point. Also, the miscarriage rate was influenced by the levels of progesterone on the day of the transfer. A very recent study from another Spanish group from Barcelona made another study, and that was a prospective study in the same field, where they also looked at PGT patients, where embryos were frozen after the biopsy, I suppose the blastocyst biopsy, trophectoderm biopsy, and they also looked at the cutoff point of progesterone, where they did the blood test not on the day of the transfer, but the day before the transfer, with the idea that if the progesterone levels were low at that stage, that they still had a backdoor to bail out and to give these patients extra progesterone, so to push their chances for a pregnancy up to the normal levels if they would have been above the cutoff point of progesterone. So here you see it. Group 1, where patients where the progesterone levels on the day before transfer were normal, and group 2, where the ones were under the cutoff point. And there you see in the lower bar what they used as cutoff point. So all people who had a lower progesterone level received the day before the transfer and then continuously till pregnancy test subcutaneous progesterone. And here you see that although there is no control group, so we don't know if this really extra subcutaneous progesterone helped, yes or no, but if you see this in view of the previous studies that we've done, you see that the two groups of patients didn't have any difference in live birth rate or ongoing pregnancy or even in miscarriage rate whatsoever. This is all very, very nice, very interesting also and new. But I just want to share my doubts still at this moment about this new concept. First, we need some properly randomized controlled trials. There are difficulties to understand when to do the blood test, because some people, as you saw, they do it on the day of the transfer. Is it a day 3, a day 5? I don't know. But then it might be too late. Some people, as I showed you, do the Barcelona study, do it the day before the transfer. But of course, then if you start comparing these cutoff levels on different days of blood tests, it starts to be difficult. And then even there are groups who say, well, the hour and the time when you do these blood levels are important. It seems that progesterone levels might fluctuate a little bit during the day. from the morning till the evening. It also has an influence on the time interval between your blood test and the last vaginal ovule that the patient puts in. I can imagine if she just put it in, or if it's 6 hours later and you do the blood test, it will give you different progesterone serum levels. What is the cutoff? Well, I see that every study has a different cutoff. They all fluctuate around 8, 9, 10, 11, but between 8 and 11 there is quite a big difference. My confusion is also that there are some studies where the backup, or if the levels were low, intramuscular progesterone was given. And it seems that with intramuscular progesterone, it doesn't work. It doesn't improve the pregnancy rates, where in subcutaneous progesterone, it works. For me, it's very difficult to understand that. And the last remark that I have, and maybe I'm a bit too simple in this way, but I just wonder why we not, if, according to these studies, 30 to 40% of our patients are under the cutoff level of progesterone the day before transfer or at transfer, why don't we start just with higher dosage of vaginal progesterone from the beginning, so we don't have to bother about these blood tests, extra interfering, phoning the patients, creating anxiety, and it will all go well. A study that I want to show you for this last remark that goes a little bit in that direction is a Japanese study from some years ago, where they compared two groups of patients over the years that they gave luteal support. One group of patients received 1,200, so 6 caps of vaginal progesterone a day. And then at a certain moment, they started decreasing in their luteal support, this group of Japan, and they were giving 900 only every day. And then retrospectively, they analyzed their data. They're comparing the group who received 1,200 with the one of 900. And it was shown that the one who had 1,200 had much better pregnancy rates than the one of 900, which supports my remark from the previous slide. Interesting also is that when they looked at progesterone levels on the 5th day of luteal support, in the 1,200 and in the 900, the levels were higher in the 900 than in the 1,200, which is very difficult to understand. But it just shows that this matter is very complicated, because the vaginal absorption will be completely different from the subcutaneous or from the intramuscular absorption, and it will be very difficult to measure in the blood what was happening, what the concentrations are in the endometrium or at the uterine level. So how do we prescribe our luteal support medication? Well, I think we do it on the basis of efficacy. As you can see in the beginning, there is not much difference between all these products. Price, I suspect in Ukraine, it will be the same as here. There is not so much difference there either. Patient friendliness, yes, of course, an oral tablet is much friendlier than an intramuscular injection, which gives also complications, as the first speaker already mentioned. And then last but not least, which already was touched on, the safety of these products. So what are we doing in practice? So we have all the literature, we have all the data, we have all the key opinion leaders who talk about progesterone support. And it seems that there is a big discrepancy between what's published, between what is said in conferences, and between what we do in daily practice. And there are two surveys about it. One was from us and one was from the World Web survey from Dr. Shoham, which was already presented by the first speaker. But here you see over the last 10 years, they asked all the IVF centers what they were using as luteal support, when they were starting, etc. And you see here, when they started up till 2019, there's on an average about 250,000 cycles that were asked what they were doing. So here you see the first question to the survey: when do you start your progesterone? And it seems that over the years there is a little shift towards the day after egg collection. Before it was more on the day of egg collection. Now it's more the day after egg collection. The majority of our colleagues are starting the day after egg collection, which I think is very logic. The day of pickup, patient might still be bleeding because of the pickup, and it's very not so nice to start starting with vaginal progesterone tablets at that time. So I think the IVF world is shifting to one day later. When do we stop with the progesterone supplementation? And there it seems, although scientifically from the literature we know that once the ACG is positive in a normal IVF cycle, we can stop with luteal support because the ACG produced by the pregnancy will take over the support. Although we know that most of us are continuing luteal support till 8 weeks, 10 weeks, even 12 weeks. There also we see a shift from 10, 12 weeks toward 8 and 10 weeks. I suspect again, because we know that we could stop already on the day of the pregnancy test, on again that we might be a little bit suspicious or say anxious about giving all this medication in the beginning of the pregnancy. First speaker already mentioned about teratogenicity, about the doubt about certain products of the safety in pregnancy. So I suspect we clinicians, being a little bit conservative and being very, very worried about this teratogenicity, that we shifted a little bit to the left. And then what do we use? And here it seems over the last 10 years, we didn't change much from our practice. It's vaginal progesterone over the last 10 years, and it doesn't change. ACG, I think, has been done, mainly because of the risk of hyperstimulation. Intramuscular and subcutaneous is going down. I think it's mainly the intramuscular who's going down because of the side effects, and it's not very nice for the patients. The oral one is not picking up at all. It's even going down over the years. Agonist spray, nothing. And then the combination, yes, there's about 17% that combine, probably I suspect with the previous story about serum levels of progesterone, vaginal with subcutaneous or intramuscular progesterone. So why is this oral progesterone, the dydrogesterone, not picking up? Well, I think there are two main reasons for it. One, more and more the philosophy of measuring progesterone during the luteal support is picking up. And dydrogesterone is not measurable in the blood. So if you believe in this concept, and I believe that more and more people will go towards that, there is no point to use oral progesterone because you cannot measure it, so you cannot do anything with it. And then the second reason is mainly the safety, which the first speaker already mentioned. About the safety, I'm a little bit sad that there are so many discussions, and it's a degrading discussion about, and I can understand that every company tries to protect his product, but when it comes to such a low level in a scientific world, it saddens me, and it's really sad that we going into these low-level discussions. It's very clear that, and the worry that I have about this teratogenicity is that most studies are done by very independent authors, people who have nothing to do with the IVF world. Here, the Lancet paper from Zakout. Zakout is a neonatal cardiologist who has no clue about luteal support, has no clue about IVF, and he completely independently produced and published this paper, where you see the differences in teratogenicity, which are much increased if you use dihydrogesterone. And then the other ones is Coren papers, the prenatal cardiology, and in other papers now, who is a toxicologist, again, no affiliation with IVF at all, where he goes in all the medications that we are using in our fertility world, where there can be problems, yes or no. And here you see this meta-analysis where the dihydrogesterone is clearly much more at risk for teratogenicity than other products in luteal support. And here you see all these studies that have been done over the last years, which is a very, very worrying thing. And I think the pharmaceutical companies should publish and clearly show us, demonstrate us that there is no risk with their products to be used in the luteal phase, which is important for us. And that's as clinicians what we ask. We don't ask these endless, useless discussions where they say this one was not good and this guy is not up to level. We just want studies and showing, proving that this is not a problem with this product. So in conclusion, I think luteal support is necessary. You better are safe than sorry, although placebo might work. This monitoring of the progesterone levels, I believe it's an interesting concept, but the last word is not said about it. We see that from all the studies that have been done on luteal phase support over the last 10 years, we didn't change much. Well, we stopped maybe a little bit earlier and we start maybe a day later, but we still use vaginal progesterone, and I suspect it will continue for the next 10 years. And the last word is, of course, this teratogenicity chapter for dihydrogesterone, which I suspect the last word is not said either, but I hope we can have some decent data from the pharmaceutical company showing and proving that there is no problem with it. Thank you very much.
Дякуємо вам, Пітер, щиро, і знаєте.
Thank you very much, Peter. You know, I was listening to you attentively. From my side, I want to thank you for your such scientific honesty and principality and absolute clearness of the position which you delivered to the Ukrainian physicians, Ukrainian doctors today. From your presentation, it was absolutely clear which categories have we to use, have a clinician doctor to use if he wants to bring favor to his patients, not to others' interests, just to the patients. Thank you very much for such an approach. We are within the time schedule. Have you questions to Peter, colleagues? Colleagues, do you have questions? No questions. Thank you. And now we have the last presentation of our section by domestic, not foreign guest, very well-known specialist in the area of reproductology, Volodymyr Volodymyrovich Kotlik. He is a chief clinician, if I'm not mistaken, of the clinic Mother and Child Assessment of Modern Leverages on the Reproductive Competence of Endometrium. This is the name of the presentation. Please, you have the floor, Volodymyr Volodymyrovich. Good afternoon, dear colleagues. Basically speaking, I'm cooperating with Besen Healthcare company for many years. We have been cooperating, and we are striving to deliver certain scientific and practical information regarding the tools, leverages on reproductive competence of endometrium and its receptivity. I would like to notice that last time, when we had also our online session 1 year ago, quite a few questions remained from the audience, from the practical clinicians. I'm the practical clinician who, using evidence-based medicine, I'm striving to deliver certain information to the clinicians, and I'm using it in my practice, day from day. I would like to notice that the questions of the last meeting were not answered, and I want to dedicate great part of my presentation to such informal, unofficial, non-standard approach to the presentation, like it should be on such a meeting. It will be 20 minutes of answers to questions after a rather short introduction I'm doing now. Since 1937, when it was a year when Rock and colleagues, a group of researchers under his guidance, identified first morphological changes in endometrium relating to the disorder of its secretory function. Practically, this year was the beginning of the studies, fruits of which we use up to now. Later on, there was a joint study on luteal phase assessment, fundamental one, and up to now, very interesting classification by noise, and also a number of other studies which already today brought us to the diagnostics and sequencing of endometrial microbiome and diagnostics of endometrial machinery receptivity, and also to the attempt to discover, to open that black box, which up to now is the so-called implantation window or window of receptivity. It has different names in different studies. Rather interesting picture, in my opinion, very interesting one, which compares what happens in endometrium with what happens in subground metropolitan lines. We reproductologists are wandering along these metro lines, along regeneration, along those endometrial changes near blastocyst in the stages of migration from proliferative tissues to secretion to decidualization. We approach the implantation to that green circle wherein ideal blastocyst has to come, so to increase pregnancy chances and make them maximum. What do we want, colleagues, when we are walking or when we are wandering in the labyrinths of this miraculous metropolitan metropolitan system. We do want to achieve a maximum result, to achieve 100%. Is it possible? Is it a philosophical question? By the way, Carlos Simon was the first to ask the question in his work last year. Carlos Simon and Cecilia Valdes, who raised several questions at the issue of fundamental science, fundamental study of endometrial physiology. When talking about morphologically unchanged endometrium, then a group of researchers who published this paper in Fertility and Sterility, they had a task, an opinion that the failed implantation is not a pathology. It is a asynchrony of receptivity of embryo and quality embryo in development period. Desynchronization of these two processes, which are basically normal for us as a biological species, is the only and the main reason and the main factor which unfortunately influences and creates the serious problem we encounter, especially when it goes on multiple repeated implantation failures. This slide shows rather a complicated process of communication between the hormones and a number of cascade of proliferative most variable reactions inside the cell and extracellularly, which arrange for a sophisticated machinery which ideally would result in a maximum receptivity endometrium and successful uterine embryonal dialogue finishing in implantation. Basically, as of today, we have two real tools of influence on endometrial receptivity. These are progesterone drugs and estradiol drugs. Concerning proliferative phase of the cycle, not only in my opinion, but also in the opinion of many researchers, it is a little bit in the shadow. A main focus we pay to problematic issues of implantation are, first of all, around in factors directly impacting the luteal phase of the cycle, but the proliferative phase of the cycle is the ground, is the base upon which ideal receptive endometrium will be built up after consecutive secretory changes in luteal phase of the cycle. And some biochemical points, some enzyme cascades coded by a number of about 238 genes coding, for example, biochemical changes. And sometimes biochemical breaks in phospholipase, protein kinase, phosphatidylacetylsurekinase, metabolism and other biologically active substances influencing the processes resulting in normal endometrium receptivity. All those points and details have been studied well, but unfortunately we don't have tools to influence, to act on those processes, except for estradiol. If we take a case of ideal endometrium, and we have ideally studied it from the immunological point of view, we have studied it for those reproductologists and scientists who trust and who are confident about immunological factor of pregnancy failure. And they do study NK cellular immunity. They have studied immunological link. We have rather broad information material and research material regarding molecular genetic study of endometrium concerning research of its receptivity. I'm talking about endometrial receptivity array studies which started in 2012-2014 in different clinics and universities. Our friend and colleague, Professor Carlos Simon, rather deeply studied, researched. He is a scientific and medical director of EVI clinic in Spain. All those researches in great volume, to my opinion, shaped up an illusion and opinion that practically we have already all the information necessary, all the tools, all the leverages to practically approach up to 900-100%, meaning, say we studied receptivity of endometrium at the level of genes expression. If we excluded immunologic disorders of endometrium and if you've detected them, then to a certain extent we already positively influenced endological disorders. And with multiple implantation failures, we treated the uterus with granulocytory colony stimulating growth factors which already are routine in some clinics. Have we catched the goat by his beard? Have we done it by 100%? No, colleagues, we don't have 100%. We have ideally examined embryo. We have ideally examined endometrium in between, as appears to us. But the efficiency of ART's programs is not arriving high as 60% as of now, meaning 10 years of study of endometrial receptivity at the level of RNA in the school and the research center of EVI Clinic on one side brought advantages, but now we have alternative thoughts. Please pay attention to the research of 2022, which was published in Fertility and Sterility by the group from Boston University, which tried to assess are there some advantages in evaluation of endometrium receptivity with the so-called personalized embryo transfer and frozen embryos transfer when we study and when we focus the so-called implantation window with previous embryo biopsy in the previous cycles, determination of genes expression, study of implantation window and embryo of already studied embryos, examined embryos. These are the results of these studies. They are not very optimistic about the forecast of ERA method, which basically should and could already be a routine study, and some clinics do have it as a routine examination of women with multiple implantation failures. But if you look at these two groups, the examination is not ideal, has not an ideal design up to now, and according to the number of cases, it is far from being ideal, but you may compare that statistically, there is no statistically significant difference in LBR. I want to stress on that the main goal was exactly to compare LBR in those two groups. So there was no statistically significant difference in LBR in cycles between the patients whom ERA was performed and those for whom ERA was not performed. This is practically the first serious study which starts to more critically look at ERA, not with such admiration that was before. Now this attitude is more cold to look what many researchers studied upon. And as of today, the freshest guideline of the British Society of Reproductologists about repeated implantation failure is also not very assuring about RNA diagnostics of endometrial receptivity. More, I want to say you, the clinical efficacy was not proved, was not confirmed. Accordingly, the British Society for Reproductive Policy Issues doesn't recommend to use in routine practice the immunological studies, even the diagnostic hysteroscopy, without certain indication. If we don't see on ultrasound, if you don't see certain pathology on ultrasound, there are no high certainty studies to recommend routinely all the patients as a hysteroscope, diagnostic hysteroscopy. Regarding thrombophilia, polymorphism genes, there are no good evidence which would suggest to recommend even examination, testing thrombophilia polymorphism genes with patients, even to patients with multiple implantation failures. The examination of uterine microbiome at DNA level, use of immunoglobulins, even with proven endometrial changes and violated levels in the blood. As of today, there are no grounds to recommend immunoglobulins to the patients when treating the conditions which haven't been proved to have direct effect on the factors leading to multiple implantation failures. Use of growth factors. Colony stimulating granulocytary growth factors we used to treat practically. So basically, we have an empirical approach to this issue, and we treat uterine cavity up to now being at experimental stage without going further outside of this experimental phase. We use PRP drugs for endometrial receptivity activation and for certain issues regarding restoration of follicular reserve. All those issues, all those named methods of research and treatment remain at the level of experimental studies. We have to be honest with ourselves in this regard and with the patients. We have to honestly say it to the patients, because over 90% of the psychs in Ukraine are conducted in private clinics. So this experimental direction is paid by the patient. And they have to understand what we are proposing them from the above said doesn't belong to the range of evidence-based medicine up to now. So we have to focus on that. We have to have it in mind. Positive conclusions. There are recommendations, proved recommendations, evidence-based ones for normalization of pregnancy after refusal, after giving up smoking. It was proved D vitamins should be prescribed with D deficiency, treating hypothyroiditis. Not always due attention is paid to it. It is one of the main factors of endometrial receptivity loss with multiple failures. Diagnostic hysteroscopy in case of polyps and submucous moems, removal of hydrosalpingosis, and also optimal protocol of endometrial preparation. And the last points is the green light, which entitles us to quietly, based upon these guidelines, to move ahead in the sense of examination and treatment of this rather complicated group of patients. Colleagues, I would like to stop to dwell on practical issues. Practical questions you asked me last year. Unfortunately, I had no time to answer them. After 1 year, the topicality of these issues didn't change. So I would like, although basically all these questions have been discussed, there have been publication in 2020 in the journal Female Physician. I would like to dwell on them. Those are the questions you put in your chats. I saved them. The company helped me to reanimate them. And the second final part of my presentation will be dedicated to practical aspects of estrogenous priming. What criteria are used for hormone replacement therapy when conducting estrogen priming? In this practical sense, those are empirical criteria, meaning practical experience of a physician, of the clinician, which has no grounds in clinical guidelines and sometimes even common sense. Main points. Should pituitary blockade be used or no? Pituitary suppression. There is a certain agreement between scientists and practitioners. Pituitary suppression is recommended to use the so-called long protocol for endometrial preparation before FET when there are medical indications for that. We have to understand it increases the cost of the program and sometimes results in that the treatment effect is being delayed. So pituitary suppression should be indicated exclusively to endometrial patients or to the patients with hyperproliferative changes in the endometrium if the patient has this history, or with uterine fibromas. In the rest of the cases, it's recommended to use just a replacement hormone therapy if it goes about replacement hormonal therapy. There are two main types of protocol: suppression, no suppression. Monodose protocol is very easy, elementary. It's easy for the clinician who prescribes it. And it has minimum of mistakes in the patients. But generally, the overall dose of estrogens in this protocol is higher. Concerning regime of increasing the dose, the amount of the same estradiol will be lower with the same effect we can achieve with that. looking in this protocol, this is protocol back to nature. It is maximally close to the natural cycle. Administration routes. I would like to underline they are very important. Why? So why it's now important, today important, during the pandemics? Because transdermal forms on top of being more efficient, they are very safe, especially regarding hemostasiological risks. Disorders, venous thrombosis in peripheral forms are much higher. Now, when we live in a situation when more than 50% of the population practically had COVID and 10% already have COVID second time, and those patients come to us for replacement hormone therapy, the risk of thrombotic complications when using oral forms is rather high one. Understanding that the transdermal, transcutaneous form has minimal risk, we have to understand that the transdermal form estrogel has to be drug of choice in a selection of hormone replacement therapy to patients with multiple failures. And to all patients who are preparing to FET cycle with estrogenous priming. This data show the use of replacement therapy in any patients, but I believe it's topical for reproductive age patient treatment regarding less adverse events than compared to use of oral forms. Macronized progesterone, it is clear here. As of today, it's leader not only in efficiency, but also in absolute safety. When ultrasonic testing should be done, I would like just dwell 1 minute on what have we to see when we conduct ultrasonic testing of endometrium. We are measuring its thickness, and we expect it to be 8, 9, 10 millimeters. The recent very interesting research analyzed 40,000 transfers. You see, in cryo-embryo transfers, it doesn't matter whether the endometrium is 6 or 10 millimeters. The difference makes 5%. It's not significant. In the fresh sites, it is critical. In cryocycles, it doesn't matter. We see big number of successful pregnancies with the thickness of the endometrium 6 millimeters. Question: do we need to continue estrogel after embryo transfer? In my opinion, in the opinion of doctors working with estrogen priming, the continuation of estrogel after confirmed pregnancy should be up to heartbeat detection, when we start basically to reduce, to lower progesterone. That's when we gradually start to reduce our estrogen priming, because very quick reduction can produce bleeding in early pregnancy term. What about embryo transfer? Which day should it be made? Should the dose be reduced or cancelled? Most reproductologists in the world, over 25,000 cycles were analyzed with Avio Feedlight system. Anyways, they use the support of to 10-12 weeks of pregnancy. I conclude my presentation with my favorite table representing 5 series randomized controlled trials suggesting use of otrexestan in the dosage of 800 milligrams. 600 milligrams is our favorite dose, but if you use 800 micrograms, both for the patient and for the clinician, it will be more quiet way of management of the patient, because the chronic discharge in the patients who use 600 milligrams intravaginally and 200 per night is a gold standard up to now, confirmed by a number of randomized controlled trials. Thank you, colleagues, for your attention. Thank you, Volodymyr Volodymyrovich. I think sincerely all of our listeners who in this weekend day, Saturday, preferred to listen to our section, eventually knew something. Our time is over, so please put your questions in chat. I promise you, we shall pass your questions to the speakers and they will answer your questions in written. And eventually next year, like it was today with Volodymyr Volodymyrovich, he remembered all of your questions and answered them. Thank you once more. Meet you again next time.
Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування. Компанія Безен продовжує своє глобальне розширення через мережу партнерів і власні представництва по всьому світу. Сьогодні 30 наших продуктів представлені у 100 країнах світу. Наша мета – забезпечити лікарям та пацієнтам найкращий доступ до наших інноваційних методів лікування та знань для безпечного та успішного їх застосування.
Доброго дня, шановні колеги. Мене звати Микитенко Дмитро Олександрович. Ми продовжуємо конференцію Української асоціації репродуктивної медицини в режимі онлайн і попереду секція ембріології.
And now we have the session of embryology and genetics. So join us. I promise you it will be interesting. We have 4 presentations in the section today. The first one will be mine. And then we shall have 3 speakers from different countries. I ask everybody, each speaker to be organized and to stick to the schedule. So let's go. Enhanced genetic screening in ART programs. Is it needed? Oh no. Everything we shall talk now, you have to understand we shall talk about rather rare issues. And we have to understand and most of the phenomena taking place in our life, both positive and negative, have been determined by something in our past. So not to get some unpleasant surprises for the future, we have to study those rare issues. It will go now about hidden carrierships of mutations which might come to very tragic cases in ART. So what are the main requests? It depends, first of all, on the problematic situation the patients themselves encounter it. They are absolutizing. They are very rarely looking ahead. The patients suffering infertility ask the question about impossibility to become pregnant. The patients who have miscarriages ask about this problem, and those who have genetic disorders and have the relatives with genetic disorders, they are the only saying that they want to deliver a healthy baby, and this request is correct and mature one, as a matter of fact, because this picture of happy parenthood everybody is imagining, for it not to convert to black and white, non-colored one, we have to inform information on possible future risks. Exactly. If we look at the structure of congenital pathologies, nearly 30% of newborns have some congenital malformations. Chromosomal ones take about 1/4, multifactorial pathology about same, and about same is the influence of environmental factors on the body of the pregnant women, and we have about 50% of unknown. Genetic researches and genetic council. Genetic researches and genetic council doesn't belong to the list of obligatory studies testing. In case of ART, we can prescribe this testing only when there are certain medical indications for that. Notwithstanding this, please look. There are cases of children born after ARTs who have passed through my hands. This is the side event of that. We in patients, we don't understand up to the end, down to the end, the weight of genetic factors in the development of pathology. Could they be prevented? Yes, it could and should be prevented. Let's understand what we're afraid of, first of all, recessive carrying. The genetic pathology when both father and mother are hidden carriers of mutation. For example, for cystic fibrosis, SMA, phenylketonuria, neurosensory deafness, and the risk of delivering sick baby in this case makes 25%. What second we afraid of X-linked recessive inheritance, for example, Duchenne disease, immunodeficient conditions, X-linked chromosome, and also we are afraid of X dominant inheritance when there is a possibility of Martin-Bell syndrome in the newborn. Let's look at the range of gene diseases in Ukraine. I took the data of Vera Alexeyevna Galgan. Unfortunately, from that time, no new information appeared. Among X-linked recessive inheritance, you see main monogenic diseases. Anhydrotic dysplasia, dysgenesia of gonads, and spinal muscular atrophy. In autosomal, those are phenylketonuria, cystic fibrosis, mucopolysaccharidosis, spinal minor muscular atrophy, etc. If you look at other peoples, the data are different. As you can see, phenylketonuria, cystic fibrosis, lysosomal storage diseases, hemoglobin pathology come to first places. And other publication for once again cystic fibrosis, hemoglobinopathy, phenylketonuria, Smith-Lavely-Opitz syndrome, and separately there's a range of diseases which as a rule are not tested with standard point analysis or sequencing methods. Martin-Bell syndrome, spinal muscular atrophy, adrenogenital syndrome, so on. The range of diseases is a little bit different, but anyway, there are some points which are overlapping. As regards regulation and recommendation for examination and testing of patients and donors before ART cycle and at the stage of family planning, you can see, as you can see, there is committee opinion of American College of Obstetricians and Gynecologists. We shall come back to this document more than once. What it talks about. On that information should be delivered to every pregnant woman. The optimal time for screening is a period of pregnancy planning. If in both patients the mutation carrying in one gene was found, it is diagnostics of embryo. Screening at pregnancy stage doesn't replace neonatal screening, and screening for carriership of SMA and cystic fibrosis should be proposed to all women. Other pathologies, independence of ethnic features, and in case of family history. There are other documents recommending national norms. By the way, in Israel, it's the only document which is a directive, not recommendation. It is a spinal muscular atrophy, cystic fibrosis, and Fragile X syndrome. In Canada, they do recommend preliminary medical genetic counseling with the history of 3 generations. Further treatment depending upon ethnicity, but look at the diseases. SMA, cystic fibrosis, the testing is not recommended to everybody, depending only on ethnicity or history. Australian committee recommends preliminary screening for thalassemia. It can be genetic or non-genetic, and also obligatory cystic fibrosis, SMA, and once again Martin-Bell syndrome. And also you can see the screening can be conducted in an expanded form. Regarding expanded screening form, unfortunately, there is no single position, single document. We can refer to other document of the American College of Obstetricians and Gynecologists, where it goes about standard positions on pre- and post-test counseling. The necessity for the disease and panels of screening match to national criteria. And also, it's not recommended to test to produce mutation with unknown significance. Most associations don't recommend expanded screening due to lack of standards for its conduction and lack of any data, any evidence on that its use may improve reproductive outcome. What are the criteria for diseases and genes to be included in the expanded? First is well-studied genotype-phenotype and correlation. For the second, high rate of carriership in certain examined population, and those data have to be known. Then remarked negative impact on life quality of the sick baby and manifestation from prenatal to early infancy with possibility of prenatal diagnostics. Pay attention that among the panels of expanded screening existing in the market, that were existing at least as of 2017 and included from 300 to 400 diseases, 73% of those haven't matched this inclusion criteria. So what volume of genetic screening should be used? Pay attention. One was a publication. There were 314 couples with inherited malformation, congenital malformation in children. If the screening was according to the recommendation of American College of Obstetrics and Gynecologists for SMA and cystic fibrosis, then we can detect only up to 1/10 of carriers. If he introduced certain national criteria, then about 1/5 of carriers of recessive diseases could be found. If we go beyond 100 diseases, we can cover the maximum. So how many diseases should be included in the panel? Pay attention. If we need to cover about 90% of cases of risk in the couples, then this panel should include about 100 genes and about 100 diseases. There are another studies for the volume. The target diagnosis includes 50 most frequent mutations with diseases requiring special approach, like spinal muscular atrophy, Martin-Bell syndrome, adrenogenital syndrome. Then we can detect about 70% of carriers. If we expand the screening to 100 mutations in the most common populations, then it will be nearly 19. To cover almost 100%, we have to to replace targeted diagnostics of mutations with full genome sequencing, and it will allow add 10% to the limit of detection, but it will increase a lot the cost of test. So the question arises, where is this golden middle of cost effectiveness? What is the incidence of recessive mutations, carriership? Pay attention, nearly 20% of patients have at least one recessive mutation of the most common diseases when studying over 400 most frequently encountered variants. This study was made on 23,000 patients. Other publication for 88 genes with complete deciphering makes about 25%. We conducted theoretical calculations in 2013-2015. Pay attention, these rates coincide with the practical one, and the share of conventionally healthy population which are hidden carriers makes from 21 to 23%. If we add here more rare pathologies, it will make about 41-43%. And we shall come to it a little bit later. Regarding examination of couples, pay attention. If we unite carriers into couples, families, as they come to us, 1 from 44 families has a risk of birth of a child with recessive disease. It's average statistics, and accordingly, the risk with the relevant risk of birth of a sick child. As regards donors examination, we can examine them for a larger number of diseases. Why so? Because the patients have to give their consent for examination. The donors from the very beginning agreed for any testing. That's why clinics can choose wider panels. Unfortunately, this paper shows absolute number. If we recalculated it into percentage when studying over 2,000 diseases, 40% of potential donors carry at least one, 11% carry two diseases. If we expand these panels to clinical exome, which includes 6,000 diseases, 60% of donors will be carrying at least one recessive disease from those. If we expand our study to clinical exome, by deciphering all the genes, we shall see that the ordinary citizen is carrying from 7 to 12 hidden diseases. The question comes once more, where is the reasonable limit in the screening of patients, of donors? And if so, when we are switching from dot point screening to expanded screening, we have to change the algorithms of consultation of couples for donor selection. We cannot exclude those donors from RT programs. We shall be enforced to find such combination to make impossible the birth of data with exactly this recessive pathology. Let's come back to the issue of ethnic panels recommended by the American College of Obstetricians and Gynecologists. Pay attention. If we use such panels exactly for the ethnic groups, then beyond these ethnic groups, we can miss 36 to 50% of the carriers. The only conclusion to be drawn from here is that the ethnic panels are substantially underestimated for the incidence of exactly those mutations. Coming to the program of screening of our patients, it's obvious that such a screening has to take place, and we realized the program of genetic screening of hidden mutations carriership. It has the name responsible parenthood. It covers 2 diseases, spinal muscular atrophy and cystic fibrosis. It's minimorum recommended one, but we are now removing the principle of a separate submission of tests, not to burden patients with extra consultations. We put it in a comprehensive set of services. What does it include? And step-by-step examination of the couple with ARTs, conducted or prenatal diagnostics in case when risks are found. How is it made? If we work with a couple with unknown risks, which comes to pass this genetic testing program, first we examine the woman for genetic screening for hidden carriership of mutations. If no mutations are found, we can state low risks and the package is closed. In case the woman is carrier of mutations, then we see and state the risk is increased. We include the partner here, and it also makes part of the package. After partner examination, we can have 2 options. Low risks in case there are no mutations, we close the program. If the partner also has mutations, accordingly, it makes high risk of birth of a child with congenital malformations. And for recessive diseases, it makes 25%. Therefore, we have to prevent birth of a child with genetic pathology. This prevention can be made by prenatal diagnostics or PGDT on monogenic disease and testing and transfer of healthy embryo. Here, the program includes some discount for a full complex of tests, independently from the choice of the couple. I want to conclude my presentation with a few key messages worth remembering, not conclusions as classical conclusions, because the conclusion is drawn from all information. These messages are more general. Screening has to be made. It is a need. It is not a caprice. Not to have problems in the work with patients, not to get claims of patients due to sick baby births, we have to take the screening. Moreover, if there is natural pregnancy and the patients get sick baby, obviously there are nobody to blame about. In case the cycle was made in the clinic, there is certain ethical responsibility to the patient. Why so? Because at least we could recommend, we could bring this information to the patient. We could educate certain concerning the patient as regards genetic diseases, and then ask questions whether did we do everything correctly? Have we given complete information to the patients about possible risks? Minimum list of diseases should be there, including spinal muscular atrophy, cystic fibrosis, and ethnic panels. Obviously, it's not sufficient. The best is not true for this case, not the best solution, because by expanding these panels, we first substantially increase the cost of the testing. For the second, there is a number of diseases which doesn't respond to the criteria of the screening, and for the third, we start to cover the diseases, the frequency of which is not known in our population, and also to cover those diseases, contention, for which the frequency of de novo cases, meaning spontaneous disease, spontaneous mutation, is higher than the cases of disease with inheritance of mutation, meaning by excluding this disease, we cannot guarantee the birth of a healthy child. What would be the reasonable approach? We have to achieve consensus here, but obviously 3 diseases are not sufficient, and this optimum has to stay close to 100, 150 most frequent diseases. Next, target analysis, meaning the analysis for separate mutations, separate genes, is more accurate than NGS screening. The screening of 100 diseases simultaneously. Why so? Because any universality of the method, including new generation sequencing, is achieved at the expense of the quality. Target analysis is more accurate, more precise, but more expensive if you come to full panels. So where is this cost-effective algorithm? Maybe something should be made by NGS, something by target analysis. What should be made with NGS with further confirmation by target analysis? All this should be calculated for a number of diseases simultaneously, and introduction of the panels which the clinics or the laboratory intends to introduce. The screening is not just diagnostics. Obviously, it will never become diagnostic. Why so? Because the task of the screening is to screen the highest risks for the most frequent diseases. It's for the first. For the second, we cannot exclude the possibility of a birth of a child with spontaneous mutation, and that is why any screening is substantially reducing risks, but it's not putting them to zero level, and the patient has to know about it. In the case of mutation carriership by one of the partners, maximum examination, maximum testing of other partners should be made for the involved gene. Ideally, it should be Sanger sequencing with analysis of deletions and duplications further on, but with taking into account frequencies and post-effective algorithm. In case of mutations carriership, the pre-implantation diagnostics of both partners on mutation or prenatal diagnostic. Pre-implantation diagnostics is more preferable. Why so? Because if it goes about some diseases not compatible with life, or disabling disease which substantially reduces the health of the child or the life of the child, like immunodeficient conditions, lysosomal storage conditions, spinal muscular atrophy, etc., the choice of genetical diagnostics should be chosen. If the diseases are highly curable, one of the most frequent is neurosensory deafness, which is very well treated with cochlear implant, or phenylketonuria, which also can be treated currently. So would it be ethically to terminate pregnancy in case when the child inherited such a mutation of neurosensory deafness, and practically no, the rest it will be healthy? Yes, in such cases eventually more ethical it will be to conduct pre-implantation genetic diagnostic. And the last we have to inform the patients about is that the risks are not distributed in between the pregnancies. These risks cover all pregnancies, each pregnancy. If there is a risk of 25% of birth of sick baby, or 50% for X-linked disease, for example, in boys, then this risk covers all the pregnancies. It's kind of a roulette game. Unfortunately, this roulette has no memory, no consciousness, and these risks have to be understood by the patients. Thank you for your attention. Please put your questions, if any, into the chat, and we shall answer them. Because due to time limitation, we shall separately answer them. Now I want to introduce to you the next speaker, Dunya Maria Baston-Birth. Dunya Maria is a PhD.
Assistant head of IVF laboratory from University Fertility Center of Düsseldorf from Germany, and her presentation about less stress for embryo is less stress for embryologist. Dunya, welcome.
Yeah. Good afternoon. Thank you very much for your kind introduction. Yes, today I would like to talk about stress, and I hope you're not stressful at the moment. I want to talk about stress on the embryo and how to avoid it, and how to avoid stress to us as embryologists too. So first of all, these are my conflicts of interest. And I would like to focus in the first part on the theory. So talking about glycolysis, for example, and talking about the impact of glycolysis, and then showing you data of studies and our own data. So first of all, implantation rates, as we all know, are good in ART programs for women aged below 35, but they decrease to up to 1% for women older than 43 or 34. So the challenge is that we need to understand the zygote and the embryo and its environment, because we are in an artificial environment still. The opportunity is that we can just evolve embryo culture media. And as you know, for example, some years ago, there was the supplement with antioxidants, for example, or with hyaluronic acid. And now today, we are going to talk about glycolysis and the role of low lactate levels. There are some studies, and I would like to present one that was published in 2014. So it's a complex table, and I would like to focus on the lactate and pyruvate ratio you can see here below, because these are all different medias, and we've got single step and we've got sequential media here. So for example, this one, G1, G2, is just a sequential one. And what you see is that they are really, really different. So they have all got different glucose levels, for example, or different lactate levels and pyruvate levels. But it's easier really to look at the ratio. So there's a ratio between lactate and pyruvate, and this one also differs between the different companies. So the lowest one, for example, is here with 5, and the highest one about 100. So 100 more times lactate than pyruvate. But what does that mean to the embryo? Therefore, in this study, they looked at one-cell mouse embryos that were thawed, and they did kinetics. So in time-lapse systems, they looked at the development of these embryos. And this is also very complex, and to use it to just one point. So here in the table, you can see just the ratio or the difference between T8, so the 8-cell stage, to starting blastocyst stage. And this even differs up to 10 hours between the different media. So a different medium leads to a different development of the embryo. Looking at some studies from Gardner in even 1996, this is this table below, and in 2013. So up to date, we need to rethink some old theories. I think most of us do incubate their embryos in 5% oxygen incubators and no longer in 20% oxygen, because we know that we have a higher blastylation rate and more active metabolism in this 5% oxygen that is really physiological. And it's time to neglect the old theory of quiescence. So embryos shouldn't be quiet in their metabolism after 8-cell stage. That's very important, because as you can see, the glucose uptake in embryos leading to a pregnancy is significantly higher in those than in the embryos that didn't get a pregnancy. And what we also learned is that female embryos do have a higher glucose uptake, so a higher glucose level and glycolysis level than male embryos. We need to think about the passage. So from the zygote to the embryo in physiology, the embryo needs to passage through the oviduct or the fallopian tube. And therefore, in here, there was a measurement of pyruvate, lactate, and glucose, also in the fallopian tube and in the uterus. Unfortunately, they didn't measure the different phases in the uterus, because that would be fine. But what they saw was that pyruvate is similar in the different phases, but focusing on lactate here. In mid-cycle oviduct, there's a high level of lactate, so during ovulation, but a lower level during the luteal phase, so during the passage to the uterus, and in the uterus too. And glucose, nearly the same, but we have a drop during ovulation. So low levels of glucose in the fallopian tube during ovulation and the first days of embryo development in physiology. Now, coming again to the commercial culture media, they all do contain glucose, lactate, and pyruvate, and the companies still have their secrets about some components. But what we now see is that the next generation media do have lower levels of lactate. Talking about embryo development, so what we know is that the first key is pyruvate. So the embryo does need pyruvate for its first cleavages up to the 8-cell embryo, and the glucose metabolism and the synthesis of the enzymes do increase during this time. But the embryo is not able to perform glycolysis in this early stages, but starts with a full glycolysis after compaction or during compaction. And we know that there is a shift between pyruvate to glucose, and that was the theory about sequential media. So the first media in IVF had pyruvate for the first 3 days, and then a shift to glucose for compaction on day 5. The mean components, pyruvate, leads to oxidative phosphorylation, And glycolysis, therefore you need glucose, really, in the later steps. Lactate and glycolysis, just to remember that. So we talk about pyruvate, and it's important to know that the lactate dehydrogenase catalyzes this step from pyruvate to lactate. But what's more important even is the regeneration of NAD. And this NAD can then be reduced again in the first steps of glycolysis. So if we have high levels of lactate, for example, but not this usage of LDH, then there is a suppress of the glycolysis. And this suppress and glycolysis might lead to stress to the embryo. And therefore I will show you now some studies. This study was performed in the US, and they found a higher euploidy rate in low lactate medium. And unfortunately, in Germany, we are not all allowed to perform PGT studies or PGD at all. But herein you can see that the percentage of euploid embryos was higher in the next generation media than in the former media. And even here in the older patients. There was a better blastocyst rate. You can see here. So this study just looked on fertilization rate, in usable blastocyst rate, and in embryo quality, so day 5 quality. And they also found a better quality in this low lactate media than in the former media. This study from Turkey examined the frequency in sibling oocytes. So there was frozen ETs with sibling oocytes, and they found a higher implantation rate and a higher clinical and ongoing pregnancy rate using also this low lactate media. Last but not least, I will show you our own data. And I already mentioned that we are not allowed to do PGT in Germany. And the mean age of our patients in our center is about 37 to 38. And we've got no donation programs and no surrogacy at all. So these are real life data from the older patient, I would call them. And what we have is a higher percentage of embryos that we can freeze at day 5 or at day 6. And also we've got a higher rate of 2PN now to freeze. So in Germany, that's very special. We freeze 2PN. We have a limited number of 2PNs that we can culture for the patients. So we don't have this culture all. And what we see, so we started with the former media in 2012 and switched to the next generation in autumn 2019, is that we have this higher percentage of embryos that we can freeze. So these are now preliminary data for 2021. Just to compare the last year of the former media to the next generation one, we have a similar number of ovum pickups and a little higher rate of fertilization in general, but similar rates of normal fertilization, but lower numbers of no fertilization after the switch to the next generation media. The number of ETs was similar, and yes, we have a high number of no ET cycles because we have a high number of patients with freeze all. So freeze all due to, for example, a reduced endometrial receptivity, so patients with an ERA test, for example, and unfortunately some patients with OHSS or with diagnostics going on. Looking at the pregnancies now, We have a higher number, or we had a higher number of clinical pregnancies in 2020. And here it's percentage per ET, so 36% per ET, and an ongoing pregnancy rate with 68.1 that we are very happy about. And now you need to know the number of births and the number of abortions is still limited because I can just follow them up until August 2020. So we're just waiting for some children. But we are happy about this high number of births until now. And yes, we are very happy about this switch. So just to sum up these data, we had even 50 more ovum pickups in 2020 despite the closure, and I think you all had a closure in AAT during the first wave of the corona pandemic. We have less cases of no fertilization, and we have a higher rate of day 5 embryo transfers and a higher rate of blastulation. We have more clinical pregnancies now and a higher ongoing pregnancy rate and more births and less abortions in the older patient. So talking about stress, yes, I think that the switch you just saw the data is just an imagination what can happen if we reduce the stress. So which factors might contribute to the stress? We need to measure the pH, and we do that, for example, every 2 weeks latest. Varying culture conditions, so the switch perhaps between media in the former sequential ones might lead to a decrease in embryo development and in embryo quality. And we also do stress the embryo, and we know that with the dish changes and with handling. So yeah, I'm a fan of the time-lapse systems, so just leave them in and look at the development. And also the high levels of lactate might suppress the glycolysis and therefore diminish the rate of development. The advantages for embryologists, yes, we have less dish changes, we have a lower workload, and we can just focus, for example, on the annotation and even on statistics. And we also reduce the media consumption with this single-step media. And now I would like to thank you all for your attention. I'm looking forward to your questions.
Thank you for your presentation. And we have time for several questions. And as a genetic counselor, just head of genetic laboratory, I speak very often to patients, to our colleagues in different fields, and the couple of questions. What's your point of view about possible role of embryo stress, of suboptimal culture condition of embryos in embryo mosaicism, embryo genetic mosaicism, in DNA degradation on PGT-A, because you show some slides with euploid embryos, but what about suboptimal embryos with DNA degradation, mosaicism, and so on, and the role of embryologist in this process?
Okay, that's a very complex question. So in my opinion, it's better to leave the embryo in the very best condition you can do as an embryologist. So leave them in the single-step media and support them the most possible you can do. And yes, the rate of the mitotic failures is even higher if you stress the embryo. So it's just a recommendation to leave them and not to handle them more than you should.
Thanks. And about the role of embryologist. Can we decrease the embryo stress on the stage of biopsy process? And how?
Yes, so being fast is very recommendable at this point. So yes, handle them again at the lowest level you can, and then pay attention on your work and be fast during biopsy, because the pH, for example, might skip and there might be problems. So you really need optimal conditions during the biopsy itself.
Okay. Next question about metabolomics.
Yes.
Is there a strong correlation between metabolic characteristics of culture medium with embryo status by PGTA? Can we use metabolomic data for prediction of euploidy status, or can we use these characteristics with strong correlation parameters for independent indication for embryo selection?
Yes, there are some studies about that. So using embryo media, for example, for the genetic and the genetic analysis, but there are just limited data at the moment. So I think we need to wait perhaps 1 or 2 more years to have more data about that. And then, yes, perhaps we can lose also a parameter just like glucose uptake, for example, or analyze the DNA from the embryo media for the analysis. Yes, but I think we need to wait some more years to be sure about that. So I wouldn't rely on the media data at the moment already.
So on the modern stage, we are on the stage of data collection.
Yeah.
Okay. The next question from our online chat from one of our participants. Could you please make some summary? What energetic source is better for different stages of embryo development?
Okay, so there is this pyruvate uptake in the first cleavages, and then the shift to glucose during compaction. And then the embryo is able to perform glycolysis on its own. So we have a shift from oxidative phosphorylation using pyruvate to the whole glycolysis in up to compaction stage.
Next question about glucose. I found some scientific publication that glucose uptake correlates with increasing of body mass of children born after IVF.
Okay.
So
yeah.
What is the current status of this question? And
yes.
And do we have some risks, for example, for some diseases?
Oh, that's a very good question. So, in these studies I showed you, there was no correlation to the parents.
Diabetes mellitus,
and there were any diseases, just like diabetes, for example, in the parents. And it's not that easy to correlate the health of the embryo directly with the media. So, yeah, I would be happy to have more data about the health issues of the parents and the fate of the embryos, but that's not that easy to collect. And what we know from physiology is, yeah, that women with diabetes, for example, are more prone to these large gestational age babies. Yes.
Okay.
But I don't think that the uptake of the embryo, because we're just in a nanomolar system during that time point, is really, yeah, just predicting, for example, diabetes after birth.
Do we need some additional genetic markers for prognostication of the risk, or it's only for discussion, or should we use only correlation between embryo part and characteristic of newborn babies? To solve
that's
this
not
question.
that easy. So my recommendation is just for the parents to be healthy as possible as they can, and to eat healthy as possible as they can. And what we know from other studies is that reducing weight, for example, in the female before pregnancy, it's just advisable for the embryo and for the baby itself to reduce the rate of diabetes. But I don't think that we have a genetic marker at all at the moment.
Because infertility very often is a genetic filter from inheritance of different mutation. So
yeah.
Part of our patient with infertility problems are not healthy. Yes,
yeah.
they're really sick with different diseases, and sick parents cannot produce healthy babies.
That's true. Yes.
Unfortunately. Okay. Thank you for discussion.
Thank you very much.
It was very interesting, and I'd like to introduce the next speaker, Gisela Margiotto. She's a scientific advisor from Kitazato DIBMed. Are we ready? We have some technical difficulties. Okay, when we're trying to reconnect with Giselle, yes, ready. Hi, can you hear us?
Hi, yeah. Sorry?
So, yes, we are ready to start.
Yes,
Gisela
I'm also
Margiotto,
ready.
scientific advisor from Kitazato DIBMed company. Nice to meet you. We can start.
Okay, hello. Thank you for the introduction. Sorry about the internet. I don't know what happened. Okay, so thanks for the invitation, and I'm very happy to be participating in this meeting. So my talk today will be focused on providing you an update on oocyte and embryo vitrification and the outcomes associated to blastocyst biopsy. So first I need to disclose that I'm the scientific advisor at Kitazato DIBMed. So during my presentation, I will provide you with an overview on the principles of vitrification. I will review the results reported by the most relevant groups of researchers in the cryopreservation field. And at the same time, I will discuss the limitations of the vitrification technique and the factors that can impact survival and clinical results. Finally, I will analyze the viability of the embryos that are biopsied and vitrified, and in turn, the variables associated with the results after transferring euploid embryos. So unlike slow freezing, the vitrification technique uses very high cooling and warming rates, which in combination with a high concentration of cryoprotectants allows to achieve a glassy state and therefore prevent the formation of ice crystal that can damage the cell. The cells, once vitrified, they minimize their metabolic functions and are kept at sub-zero temperatures in suspended life conditions for a very long time. The efficiency of the vitrification technique will depend on the high cooling and warming rates, on the viscosity of the solution in terms of the concentration of cryoprotectant, and is inversely proportional to the volume of the frozen sample. During warming, the vitreous state returns to a highly viscous supercooled liquid, and with the increasing temperature, this viscous liquid can crystallize. The ice crystals formed by recrystallization during warming have lethal consequences for the cells. However, if we can achieve a high warming rate, this recrystallization can be blocked and cells can survive. For this reason, the warming rate is more important than the cooling rate for survival outcomes, and therefore it is considered the most critical step in the entire process. For vitrification, we use permeant cryoprotectants that would enter the cell to replace the water. The permeability of the different cryoprotectants can also differ. For example, the MSO passes through the membrane quickly and also has a very high vitreous capacity. The non-permeant cryoprotectants work as osmotic agents outside the cell, balancing the exchange between the permeant cryoprotectant and the water, and they also have the ability to increase the glass transition temperature. But keep in mind that all cryoprotectants are toxic if they are used incorrectly. Cells are more permeable to cryoprotectants at higher temperatures, but are more resistant to toxic effects at low temperatures because the cryoprotectants begin to metabolize at high temperatures. The cell's toxicity depends on the exposure time and the concentration of cryoprotectants. The improved vitrification protocols employ combination of cryoprotectants in order to reduce individual toxicities. Cells have a limited tolerance to contraction and swelling. Therefore, dehydration and rehydration protocol must ensure a minimum of contractions and respiration of the cytoplasm in order not to alter cell functioning. The contraction of cells before vitrification makes the cytoplasm more stable and thus avoids some of the cryo-injury damages. There are other components that are also important in the vitrification medium, such as the hydroxypropyl cellulose, which gives a higher viscosity and also improves the detachment of oocytes and embryos from the vitrification device during warming, and this will reduce the mechanical stress and improve survival rate. On the other hand, trehalose, as the non-permeant cryoprotectant, is a better promoter of the transition to the vitreous state and has a greater capacity to protect cell membranes compared to sucrose. Thanks to the high survival rates achieved with vitrification, clinical outcomes have been improved in cryopreservation cycles and has also made fertility preservation and donor egg banking a viable option for patients. In addition, it allows safe segmentation of the IVF cycle, disconnecting in time the stimulation process from the embryo transfer, and this consequently offers additional time when genetic testing of the embryo is required. So speaking of survival rates, the scientific literature shows that for oocytes, embryos, blastocysts, and embryos after biopsy, the results can be found all above 90%. As we can see, according to the Alpha Consensus meeting on cryopreservation in 2012, the competence survival value for day 3 embryos is 70%, and the benchmark value is 80%. And for blastocysts, the competence value is 80% and the benchmark value is 95%. And the Vienna Consensus, more updated in 2017, considers that blastocyst survival must have a competence value equal to or greater than 90% and a benchmark value equal to or greater than 99%. This is a review study from the EV Clinic in 2012 that analyzes the result of more than 3,000 vitrification cycles in different stages of embryo development. They won more than 6,000 embryos with an overall survival rate of 95%. When they analyzed the survival according to the stage of development, whether they were day 2, 3, 5, or day 6 embryos, they observed that the results were similar between groups, always above 94%. When separating according to morphological quality, they observed a trend towards a better survival rates when the embryos were of optimum quality. When comparing only the blastocysts on day 5 and 6, they observed that expanded blastocysts on day 5 achieved better survival and live rates, and on the other hand, they detected that survival was lower in the group of day 5 blastocysts that were hatching or that were totally outside the zona pellucida. Regarding oocyte vitrification, we know that they are more sensitive cells to damage during cryopreservation, and the low permeability of the membrane makes the exchange between water and cryoprotectant less efficient at this stage of development. Therefore, the preferred method for vitrifying M2 oocyte is a stepwise addition of the cryoprotectants in a gradual way. Again, according to the alpha consensus on cryopreservation, for oocytes, the competence value, survival value is 70% and the benchmark value is 85%, being 95% the benchmark value for donor oocytes. So survival rates in donor oocytes reported in different scientific publications are generally variable, and this has to do in part with the vitrification system used. However, if we calculate an average of the survival rates achieved by the different groups of researchers, we can see that it can be above 90%. This study aims to describe if any parameter of the IVF cycle could be a predictor of the survival of donor oocytes, but it finally fails to establish any direct association. The authors conclude, for example, that the number of oocytes retrieved and the storage time have no impact on the survival of the oocytes. However, they show that despite a low percentage, the donor survival failures do exist, and that certain donors have a trend to repeat failure in consecutive cycles. But curiously, these same donors may have good results in fresh cycles. Another interesting conclusion of this study is that the probability of achieving a live birth increases when the number of warm oocytes used in an ICSI cycle also increases. Another study comparing pregnancy and live birth outcomes using fresh versus vitrified oocytes also shows that a cycle with vitrified donor oocytes provides reproductive results similar to those of fresh oocytes when the same number of oocytes are available for fertilization after warming. Regarding the results in oocytes from patients who decide to freeze for fertility preservation reasons, age has a great impact on survival and clinical results, being significantly lower in patients over 35 years of age. This other table also shows the differences in survival and clinical results in the different age groups and confirms that the rates are lower in patients over 35 years old. There are also differences according to the indication of fertility preservation. If they are young patients who choose to freeze for social reasons, the results are similar to those of recipients with donor oocytes. On the other hand, if the patient who vitrifies has an infertility factor, such as being a poor responder, even if she is young, the results that she will achieve will be lower, equivalent to those of women with more advanced maternal age. Another effect of the indication is if the patient who vitrifies has an oncological disease. It has been shown that these patients, even when they are young, the survival of the oocytes and the clinical results are reduced. As with donor, for young patients who freeze to preserve their fertility, the greater the number of oocytes used post-warming, the higher chances of achieving a live birth. However, for patients over 35 years of age, this correlation stops at some point due to other factors related to advanced maternal age. Now, what is the difference between fresh and frozen oocytes? So we are going to discuss or to analyze if there are differences in terms of blastocyst formation, morphokinetic parameters, and the rate of aneuploidies in embryos derived from warm oocytes. Regarding the rate of blastocyst formation, the results published by different authors are controversial, although there are some reports showing that there is a decrease in blastulation in embryos derived from warm oocytes that could be associated with an alteration in the mitochondrial activity. In addition, an increase in the levels of reactive oxygen species and greater oxidative stress are factors that could also be compromising embryo development. From time-lapse studies, it has been observed that embryos derived from vitrified oocytes have different morphokinetic parameters. Division times from 2 cells to blastocyst formation may be slower, so these embryos could be requiring a higher energy intake for the reactivation of all the metabolic machinery, and this reactivation could take longer time for the vitrified oocytes. With respect to chromosomal status, warm oocytes appear to have the same probability of achieving euploid blastocyst as fresh oocytes. So to assess the results achieved from the vitrification of both oocytes and embryos, it is important to take into account certain technical aspects. There is a great variability in the protocols and devices available for vitrification, and they do not all work in the same way. Vitrification is a totally manual technology, and sometimes operators make personal contributions that go beyond the recommended protocol. A learning curve should be established for each new operator and key performance indicators for continuous evaluation in each laboratory. The morphological selection criteria should be adjusted in order to vitrify only good quality oocytes and embryos, and in the case of oocytes, only those mature in metaphase 2. We must be rigorous with the pH and osmolality control through the drop volume used. Using larger volumes could reduce errors and are highly recommended during protocol learning until good results are obtained. We must monitor the temperature of the solutions to allow a correct exchange of cryoprotectant and water and to achieve high cooling and warming rates. We must also control the exposure time to the cryoprotectants since they can be toxic to cells. And at the same time, we must pay great attention to the handling, transport, storage of the samples already vitrified so as not to expose them to accidental thawings that could compromise their later survival. So to achieve the best possible results, we must optimize quality, experience, and reproducibility. And for that, the protocol must be standardized to ensure control conditions, and it is essential that all operators follow the same protocol always. Perhaps in the near future, the automation of the vitrification procedure will allow the protocol to be standardized, generating at least more consistent results. In the case of PGT programs, it is essential to implement a successful vitrification technique to allow sufficient time to obtain the genetic result. It is also required a suitable culture system to safely obtain embryos up to the blastocyst stage, and the biopsy technique should not affect the viability of the embryo. It should involve reliable and informative results, and it should be easy to implement, reducing cost and laboratory workload. This study shows results in cycle with PGT with fresh versus deferred frozen transfers, and it was found that implantation and clinical pregnancy rates were higher in the deferred transfer group, indicating that the reproductive outcome is optimized with embryos with genetic screening, vitrification, and subsequent transfer into a prepared synchronous endometrium. This publication shows a PGT protocol that consists in performing assisted hatching and sequential biopsy, which does not generate any case of blastocyst degeneration after biopsy. The informative diagnosis was 97.5, and the survival rate of the euploid blastocyst was close to 100%. So this confirms the safety and the reliability of the biopsy and vitrification techniques implemented. It was also reported that the highest respansion rate after warming is obtained when the blastocysts are vitrified within 30 minutes after biopsy. The expansion rate also depends on the morphological quality of the blastocyst and the day the biopsy is performed. The more time that elapses between the biopsy and vitrification, the more the blastocyst re-expands before being cryopreserved. And this could be detrimental to the viability of the embryo, especially when dealing with poor quality or the day 7 blastocyst. In this other article, it was also found that the live birth rate in the PGT group was higher than the non-PGT group, which is mainly due to the euploid status of the embryos. The important evidence from this study is that although poor quality or slow developing blastocysts were associated with good survival rates, they resulted in live birth rates equal to or less than 15%, even when euploid embryos were transferred. Therefore, it must be taken into account that embryo quality and the day of full blastulation are factors that can affect clinical results even if they are genetically normal embryos. Embryos biopsied after 6 days of development have also been observed to have higher aneuploidy rates, and this finding is greater as maternal age increases. Day 7 euploid embryos generally have lower embryo quality and have lower implantation, clinical pregnancy, and live birth rates compared to cohorts of embryos biopsied on day 5 and 6. However, the survival and miscarriage rates are comparable between groups. When analyzing day 7 euploid embryos, but those of good quality, it is observed that they can achieve acceptable clinical results. Therefore, the use of euploid embryos of good morphological quality on day 5 and 6 is recommended as a first-line approach during assisted reproductive treatment. However, for patients with embryos that require extended culture, there is a chance for a successful outcome with a day 7 euploid transfer, embryo transfer. The embryo biopsy is an invasive technique, and the number of biopsy cells is one of the most critical factors, since it can affect embryo implantation and reduce the live birth rate by 5%. So fewer biopsy cells can be less invasive, but also result in higher risk of amplification failure, while the increase in biopsy cells may lead to a lower risk of amplification failure, but could increase the disruption of the blastocyst. Embryo quality plays an important role in the biopsy result. Biopsy is usually less invasive for a good quality expanded blastocyst, as it has a higher total cell count than an early blastocyst. This other study also confirms the impact of the number of cells collected during the biopsy on clinical outcomes. In the group where a greater number of cells were biopsied, the clinical pregnancy was lower. But the authors found that the miscarriage rate was similar in both groups. Therefore, they concluded that the embryos that implant, regardless of the number of cells extracted, have the same chance of miscarriage or reaching to term. So this picture shows from A to C examples of desired fragments with good shape and cell count, and from D to F you can see fragments that are lysed or small or degenerated, which we should avoid after biopsy. Although the prevalence of failed genetic tests is low, this implies a waste of embryos. In situations where there are few or no euploid embryos, patients must choose whether to rebiopsy the non-diagnosed blastocyst, to do a blind transfer, or to accumulate more embryos. So each option has its own benefits and drawbacks, as repeating the test involves a second round of biopsy and a second round of vitrification. On the other hand, there are patients who can also request genetic tests on non-biopsy embryos that are already cryopreserved. For example, if a patient has a miscarriage or had a failed cycle with fresh embryos, they may choose to perform a trophectoderm biopsy and genetic analysis on previously cryopreserved blastocysts to allow a transfer of an euploid embryo. In this case, even though a single biopsy is performed, this will require 2 cryopreservation procedures. So in this study, they compared 2 groups, Group A with 1 biopsy and 2 vitrification procedures, and Group B, 1 biopsy and 1 vitrification. They found that the clinical pregnancy rates in both groups are comparable. So warming previously vitrified embryos followed by biopsy and refreezing maintains embryo viability. This study analyzes PGT-A cases that do not achieve a conclusive results and undergo a rebiopsy. The authors obtained a diagnosis rate of 95.2% after rebiopsy, and 56% of the embryos received a subsequent diagnosis as euploid embryos. So the absence of a result was not related to the day the biopsy was performed or to the degree of the inner cell mass of the blastocyst. However, a trophectoderm grade B or C was associated with a higher incidence of inconclusive results compared to grade A. These findings can be explained considering that a biopsy of a blastocyst with a lower trophectoderm quality may result in a smaller cell fragment, so it can increase the risk of an inconclusive result. This table shows the result of the different groups analyzed, cycle with standard PGTA with 1 biopsy and 1 vitrification, cycle with 1 biopsy and 2 warmings, and those with double biopsy and double vitrification. There is a trend towards a lower pregnancy rate and a higher miscarriage rate that can be observed in the double biopsy and double vitrification group, but the differences were not statistically significant. Given that blastocyst rebiopsy produces an euploid result in a high percentage of cases, this strategy deserves consideration for all patients who want to know the ploidy status of their entire cohort of embryos, and particularly for those patients who do not have other embryos available for transfer. An inconclusive result does not change the probability of a given blastocyst to be euploid, and in turn, the pregnancy outcomes after the transfer of rebiopsied blastocyst are favorable. This is a more recent study that evaluates 97 cycles of PGT that have undergone double vitrification, 36 of them with a single biopsy and 61 with double biopsy. It seems that pregnancy and live birth rates in the double biopsy group have a trend to lower results, but the differences were not statistically significant either. Regarding neonatal outcomes, although the sample evaluated was very small, the values were comparable between the groups with a single and double biopsy and did not show any adverse effect. The authors reported that approximately 48% of the rebiopsy embryos were genetically transferable, which indicates that the rescue is worth it when the first biopsy result is inconclusive. So for quality control and quality assessment in a PGT program, procedural, technical, biological, and clinical outcomes should be monitored. It must be taken into account that both biopsy and vitrification are demanding tasks that require rigorous skills, and their effectiveness can vary between operators. Therefore, a specific training period and regular performance monitoring are necessary. Each clinic must establish its own indicators, which must be close to international guidelines or the results published by reference laboratories. Perhaps soon, the non-invasive PGT with the genetic analysis of the spent culture medium will allow to replace the extraction of cells from the embryo, avoiding any damage that the embryo could suffer during the biopsy. So finally, the take-home messages are that vitrification allows to achieve high survival rates and maintain the viability of the embryos. Euploid blastocysts have greater chances because of their genetic status and because they are transferred into an endometrium with greater receptivity. The embryo quality and the blastulation day affect the clinical results even if the embryos are euploid. Repeated vitrification and biopsy cycles appear to maintain embryo viability. The source of oocytes, whether they are fresh or vitrified, is not related to pregnancy or live birth rate, but there are some limitations. Survival failures do occur, and there may also be lower blastocyst formation with different embryo development parameters. The number of warm oocytes that are microinjected has a direct correlation with the outcome. The survival rate and the clinical outcome are related to the indications such as low responder or cancer patients. But age is the factor which has the greatest impact on egg freezing results. The vitrification protocol and the biopsy technique must be optimized and standardized in each laboratory in order to obtain the most consistent and reproducible results possible. Special training and KPI monitoring are essential. The future trends in this field are automated vitrification and non-invasive PGT, so we are hoping for it. So thank you very much for your attention.
Thank you for your presentation. We have some questions to you. You touch a very important topic. It's a PGT on cryopreserved embryos.
Yes.
And we know that repeated cryopreservation has a harmful effect on implantation potential of embryo and further reproductive losses. So is there any way to decrease this harmful effect of refreezing on implantation and reproductive outcome?
I would think that refreezing, like several cycles of vitrification, should not impact the embryo, the implantation of the embryo. If the protocol is standardized and well performed, I would think that maybe
you show
a double biopsy.
With you show the trend with low implantation chances.
But with the double biopsy.
Double biopsy, yes, that's right.
Yes, yeah. Not the differences are not statistically significant yet.
What is the cause?
There's a trend.
It's a double biopsy or double refreezing?
No, I would say that probably it's the reason maybe of a lower trend in implantation and clinical pregnancy. It could be due to the rebiopsy. You are extracting more cells of the trophectoderm, which is very important for implantation. So I would go for that. I would not think that vitrification is the reason of this trend, in my opinion.
So your point of view is repeated vitrification has no harmful effect of implantation rate and potential effect on reproductive losses. Am I right?
Yeah, because I have done like many times, like for example, freezing day 3 embryos, warm them, grow them to blastocyst stage, freezing the blastocyst, warming them, and or even in the case of oocytes, if I would freeze the oocytes, then warm them, do the ICSI, grow them to blastocysts, and then freeze those embryos. I don't see, in my personal opinion, I don't see there is any impact in several cycles of vitrification.
Okay, next question about PGTA. We know that PGTA is not a masterpiece in genetic testing. PGTA has some technical limitation, some biological limitation, and we cannot give 100% guarantee for patient of absence of any genetic problems in embryo. But non-invasive PGTA has much more limitation.
Mm-hmm.
So the question is non-invasive PGTA, it's our future or it's a bullshit?
well, it's the same. You could ask me the same about automatic vitrification. We're always hoping for new developments in the field. So I would think that there are many groups of researchers that are trying to have equal results with comparing trophectoderm biopsy and the non-invasive. I don't know. I still go for the biopsy, the embryo biopsy, but maybe in the future they can standardize the protocol and we can have the same results. I would love to have that because it's much easier. It's not invasive. I hope it's not a bullshit. Like I would hope that the researchers are trying to have a protocol that is similar to the results with the biopsy.
Thank you for your time. Thank you for presentation. We should move forward. And our next speaker is Dmitry Dozortsev. Dmitry Dozortsev, PhD, President.
Dmitry Dozortsev is the head of the American College of Embryology from Advanced Fertility Center in Texas. Dmitry, do you hear us? Yes, I do. It's our pleasure. It's my pleasure as well. You can start your presentation, please. Thank you. To begin with, I want to thank the organizers of this conference, especially Dr. Yusko and Dr. Itzikson for the invitation to this conference and the possibility to talk to you about what seems to me to be very interesting and very topical, which regards the review of the central paradigm of ovulation in human. This presentation is based upon the expanded version of the publication, which was in Fertility Sterility last year, in co-authorship with Dr. Michael Diamond, and it was the first series which was introduced by editors-in-chief of the edition. Like a theory, like a hypothesis, they believe are fundamental in the sense of their influence on the change of understanding of the reproductive physiology. This graph is well known to everybody. You can see what we studied in the institutes, in all text, is present in all textbooks. You see less or more linear slope of estradiol, which achieves its peak in some moment. And this level produces a surge of LH and FSH by the pituitary. And we shall see increase of progesterone level in the blood. As we can see in the lecture, almost nothing is reflecting the, what is really happening in human physiology. Let us first look to the source of this well-known scheme. You can trace it from the publication of Gerhard Leyendecker. Who conducted a rather complicated but a very good study where he showed that administration of estradiol injection to a woman, this is a castrated woman without ovaries. She is postmenopausal. She has no own source of estradiol or progesterone, but she has LH and FSH. So he delivers injection of estradiol, and couple of days with some delay we can see what could be named estradiol surge. That is how he draws conclusion we also would draw in 1972, because we don't have what we know today. We didn't have what we know today. We also would assume estradiol produced the surge of LH. In the same work, Leyendecker used progesterone to provoke FSH and LH peak. After progesterone, we see not a slow surge, but end of tip surge of LH and FSH. But as we all know, progesterone starts to grow after LH search, we cannot say that this is a physiological phenomenon, although we see it in experimental way. That is why Lane Decker wrote in his paper that as progesterone is not after LH peak, although it produces LH peak, it cannot be a physiological stimulus for LH. So estradiol should be the trigger. Although we all use the scheme telling that estradiol produces LH peak, we always knew there are some problems. Something was missed in this scheme. And there are well-known abnormalities existing which contradict to this assumption, hypothesis, or theory of that estradiol produces LH search. For example, if you give letrozole and suppress estradiol through the whole follicular phase, it in no way impacts the time of normally menstruating woman's menstruation. We also know that during ovarial stimulation, the supraphysiological levels of estradiol are achieved very early in the follicular phase, but they don't trigger ovulation. We also know from experimental works that injection of a very high amount of estradiol, 100 times higher, what we see before LH search, doesn't change compared to the control one, the time nor the level of LH when it comes. If we look at the real search of estradiol during the follicular phase, we shall see that unfortunately we shall see that the LH peak appears not when we have high estradiol level, but when it's very low. And as a matter of fact, if you look at 100 profiles of individual patients, the estradiol during the follicular phase, you shall see there is no correlation between estradiol peak and the beginning of LH peak is there. Also, estradiol never is rising in a linear way. It is an artifact when we gather in one schedule the profile of multiple patients. In real life, estradiol is oscillating every 2 days during the follicular phase. It is a separate, very interesting story. It will be published at the end of this year in Fertility and Sterility. Progesterone. It's interesting. Although progesterone is used practically since 40s as something blocking the search of gonadotropins, but already there at that time, John Everett started to doubt about that progesterone really has the role to suppress ovulation, meaning physiological role. It suppresses ovulation during pregnancy, we know about it, but in one of his articles he wrote that it seems that under certain conditions progesterone doesn't suppress, but vice versa, induces LH release. This was an animal study, but we know In humans, the situation is very similar. There are several very well done experimental works, including by Lindecker, I showed in the very beginning, which says that it's no doubt if you inject a progesterone for a woman, you will induce LH surge in her. Experimentally. Obviously, the women who get progesterone, they are castrated, and so this is a simplified system to be analyzed. But anyway, these data are there. That's why, if you have doubts about that estradiol produces ovulation and peak of LH and FSH, we have experimental proof that progesterone also produces the release of gonadotropins. But the question remains, is it progesterone which is a physiological trigger of ovulation, or is it just an experimental artifact? The barriers allowing to recognize progesterone as a natural ovulation trigger are big ones. Firstly, progesterone it starts to grow before LH peak starts. High progesterone during pregnancy blocks ovulation. We know about it, no doubt. Millions of women use the drugs helping them to prevent pregnancy. It's main component of all contraceptives, birth control. Also, sometimes we use progesterone during stimulation to block ovulation. And for me, the greatest barrier was the experiment of Lindecker, where it shows that a woman with no progesterone, absolutely, because she has no ovaries, in her, estradiol produces a surge of luteinizing hormone. Let's look, can we overcome these obstacles in our way to recognize progesterone as a natural ovulation trigger? The first barrier is practically the easiest one. In 1983, an article was published by Hoff, Coverley and Yen, where they conducted very interesting work. At the time when before them their reproductive hormones, experimental ones, were measured once a day, they decided to look more in detail what happens, and for this they took 5 or 6 volunteers, put them in a hospital 1 or 2 days before the intended day of ovulation, and they tested their blood for reproductive hormone every 2 hours. Every point here means measured value of hormones, and this showed that it turns out to be that progesterone starts to rise approximately 12 hours before LH surge. But what's interesting and why it was not obvious, it's not obvious now for 95% of people, a level of this progesterone before LH surge started was quite approximately just 0.5 nanograms per milliliter. Clinically, it's very low level, which we don't recognize as significant. But we look at basal level of progesterone in those women before they speak, then we shall see that they speak also it's very little, but it's two times increase in a short time compared to basal level. It's very interesting. I want to pay your attention to that. As soon as LH search starts in this experiments, at least, such a bifurcation happens between progesterone and estradiol. Progesterone rises and estradiol drops. We'll see why it's so important further on in the presentation. And next important experiment, very important one, which will help us to interpret Landecker experiments. This work was conducted by a very interesting, very prolific physiologist, McNeil, who did a lot of jobs in the area of reproductive physiology of mammalians. And what he proved, he showed that when estradiol is increasing and the level of LH and FSH is reduced in the sun, it's not because estradiol is blocking the synthesis of FSH and LH. Yes, it blocks a partial FSH synthesis, but doesn't block LH synthesis. It's very important. LH continues to be accumulated in the granules, the gonadotrophs, the granules where in LH is contained. What's interesting? The effect of estradiol producing the accumulation of LH granules in anterior pituitary is not connected with the GnRH pathway. It is the action of estradiol directly on the receptors and its hypophysis. The estrogens produce direct negative effect on the release of LH and FSH from hypophysis. It's very important. Let us now look at the work of Landecker once more, and let's analyze it from the point of view of what we knew from the time since year 32 when this work was firstly published. Although the injection was made here, but we know, the author tells us about it, that for several days before injection the patient received oral estradiol. She is menopausal, so we can assume the her initial LH and FSH level was about 100. In few days of her getting the oral estradiol, as it was expectable, it would go down to 30 international units per milliliter, approximately. But we do know, differently from Landecker, who should assume he suppressed LH synthesis, we know that he didn't inhibited LH synthesis with estradiol. He blocked the release of LH from pituitary. Just to imagine it. Imagine you have a barrel which is slowly being filled with liquid. And this barrel is open, the liquid is over leaking as soon as the barrel is filled. Now you close the crane, the tap, and you measure the liquid. You see there is less liquid. And you may assume it happened because a barrel has less water, but as a matter of fact, the water continues to be supplied to this barrel, meaning it's continuing to accumulate in the hypothesis. When you inject estradiol, you close this grain even more strongly, and when estradiol level is maximum, as you would expect, LH level would be minimum. Although it continues to accumulate, and we have a lot of it in these granules. Further on, at the extent of metabolization of estradiol, we see that with each step, estradiol drop happens. There's some systemic increase of LH. When estradiol drops to the level which eventually is critical one, then it happens what can be described as LH peak, but this peak, as a matter of fact, is not quite physiological. Why? We don't know it, because and this peak is not connected with the general H pathway we know well participates in search and release of gonadotropins. That's why exactly progesterone, which as we shall see further on is acting through GnRH pathway, is able to produce LH peak after estradiol, but estradiol cannot produce a new LH peak after progesterone because it's empty, nothing remains there. If we study the graphs of the women who measure daily FH and FSH and LH during follicular phase, we can see sometimes that level of LH which was observed by Landecker. Practically it's artifact. Look, here estradiol drops under the level which was maintained previous 4 or 5 days, and here it coincides with that LH peak, which as we assume, was seen by Landecker in his experiments. Coming back to the graph where we saw that bifurcation estradiol progesterone, what do we see? We see that estradiol under certain conditions produces search release of LH and FSH, LH mainly directly from pituitary when it goes down, and progesterone produces this release through GnRH pathway, as we assume, when it goes up. And this, as we assume, creates redundancy. It guarantees that gonadotropin search will happen in one or other way. And we believe that the well-known fact is because many women has not one but 2 LH peaks, it's connected exactly with this, and it's explained by this. If due to certain reasons she first has LH release due to the drop of estradiol, then she will have a peak. First, this one. It will produce obviously the increase in progesterone level, which will produce a second peak. If she will first have increased progesterone, then only one peak will be there, produced by GnRH pathway, meaning hypothalamus, hypophysis. Another option, which is observed in animals, in sheep, namely. their level of progesterone remains continuous, but the number of progesterone receptor increases, because as soon as progesterone increases, the number of receptor increases, and when this, I'm sorry, I'm a little bit cold, when this level is above certain trigger threshold, the same happens here. The launch of GnRH signaling pathway without obvious increase of progesterone level. What next? How should we reconcile and unify this observation on that the progesterone is blocking ovulation at the same time as we assume it is a physiological trigger of gonadotropins? And here, this table will help us. As you know, when you open a new birth control pills, you will find there always a number in milligrams for progestins, because progesterone shouldn't be used for natural progesterone is not used as birth, because it's peripheral drug which is absorbed, which is uptaken very poorly. So a pure type of progesterone is very quickly metabolized. In a couple of hours, it is already metabolizable. So the action of natural progesterone is used on all the drugs for controlling the pregnancy. The progestin, the artificial progesterone, all progestins in activity are completely different from progesterone, but we as a rule do not know about it, because the stakes and the information, the label of the drug and the information will take a lot of things, but it will not show correlation between the potency of this progestin used in the drug and the natural progesterone. This information is very difficult to find. There are very little publications. But I found one. If you look at this table, you will see that some progestins, even the old progestin, are 1,000 times more active than natural progesterone. So to understand what happens when the patient receives progestins, you have to know its activity compared to progesterone. To give an example, in the drug where one of the drug where birth control pills are used, there are 10 milligrams of dydrogesterone. It corresponds to approximately 200 milligrams of injected progesterone. This is the level found in pregnant women's blood, even higher, and it's much higher of that quantity which is necessary to induce ovulation by progesterone. Speaking in other words, when you give birth control pills to a woman, means you launch GnRH pathway, and that's why some of drugs shouldn't be started in the middle of the cycle, because the woman can become pregnant because it produces ovulation. If you start this drug in the very beginning of the cycle, then you drain a hypophysis every day. There is nothing remaining in it. So you produce kind of an ovulation in the woman. You produce a peak or LH release every day. That is how it cannot be accumulated. That is how, accordingly, she cannot have an LH peak during the middle of her menstrual cycle, and she will not have it. At the same time, if progesterone is very low and starts to rise, even not to up to very high level, when the hypothalamus PRs are desynthesized, it produces the launch. In this way, progesterone would block ovulation at any time of point, with exception of very narrow period before ovulation happens. Only during this window it's able to produce physiologic launch of GnRH pathway and the release of this. Now to reconcile it, the progestin with primed stimulation, as a matter of fact, it is very easy when we do understand what happens. We see when we give progestins, we desensitize progesterones. But at that time, if we give to agonist, it works at the level of hypophysis. Accordingly, FSH also will work because it works at low level, at the level of follicles. It's interesting that for the primed progestin primed stimulation to be successful, it should be started early during the follicular phase, otherwise it will not be able to give us the result we want. If progesterone launches GnRH pathway, how it happens? What can produce increase of the progesterone in the follicle? We understand that follicle should be somehow synchronized with hypothalamus, should somehow notify hypothalamus and that it's ready to ovulate. And we know that the spontaneous luteinization emerged 100 million years ago at the level of very low, at the low level of organisms. We know it happens in the women spontaneously when follicles are disappearing during the stimulation, especially in the women of older reproductive age. Without LH peak, the follicle is breaking and spontaneous luteinization happens with natural progesterone. We assume that the mechanism of progesterone rise in blood is connected to the inflammation of follicle, which happens, and we know it well, during ovulation. We know that there is relative hypoxia in the follicle during the most of the follicular cycle times, and the synthesis of progesterone is suppressed. The inflammation, which always starts before the follicle will be ovulating. That's why we can see the ovulation by measuring the basal temperature in the women. We know that inflammation is normally accompanied by increased blood flow, blood circulation, and we assume that it partially is reducing. That is why Andetoli cannot block progesterone synthesis, and it increases in the follicle independently from what happens with luteinizing hormone. And further on, this follicle oxygenation and progesterone increase produces launch of GnRH pathway, and release of gonadotropins, which will produce ovulation. This is the scheme we propose, the updated scheme of ovulation. The follicle is inflamming, and if first estradiol drop happens, it can happen if the follicle starts to break spontaneously. We can make fantasies why estradiol will drop first. In this case, we shall have decrease of its negative pressure on release of gonadotropins from the hypophysis. And the LH and FSH release from hypophysis will be the first peak of LH. At the same time, when progesterone is rising, first it accumulates, it activates the GnRH pathway, and we shall see a surge of LH and just one peak of LH. Now I want to show you a case report which we prepared. In this case, the concentration, the peak of progesterone concentration was 1 nanogram per milliliter. Basically, it's very close to what we physiologically assume or have seen in experimental works of normally menstruating women. We do see that her baseline progesterone was 0.4. At the 12th day of stimulation, she's got progesterone injection, 5 milligrams of progesterone, just 5 milligrams. Very low amount of progesterone, 10 times lower than daily injection during luteal phase support. In 17 hours after injection, we see that her progesterone and LH grew to the level expected with normal physiological surge of these hormones. We see the signs of ovulation in ultrasound. And what's very important and interesting, 7 days after trigger, with no supplementation, we see a beautiful level of progesterone which doesn't require any additional support. And this is the way towards use of progesterone for creation of more full-fledged and more convenient for the patient luteal phase support than what is used now. To conclude, I'm summarizing what I told you. We currently practically are sure that gonadotropinal surge ovulatory is launched by progesterone through GnRH pathway. We believe that the level of even the low level of progesterone, we should look at its correlation with basal progesterone. But even so low progesterone levels as 0.5 nanograms per millimeter should be regarded as clinically significant. And finally, the loss of follicular integrity produces increase of spontaneous increase of progesterone and drop of estradiol, which which makes unavoidable LH and FSH search. There are many ramifications from this work. Those who listened to my lecture last time on stimulation already would understood that unification of neural stimulation and the use of progesterone as a trigger for gonadotropins to create artificial, natural luteal phase is a very prospective potential, absolutely new approach to the practice of improvement of X quality and improvement of support of luteal phase. If you have a patient which due to some unexplainable reasons has good embryon, tested embryon, and there was a transfer of frozen embryons, and the woman became pregnant and she lost the pregnancy, or she is not becoming pregnant under your current luteal support scheme, please send me, if you want to understand about it, how to try to use this new scheme, please write to my mail. I don't know whether you see, because there is some rectangle which closes it. My name is 1@505747.com, and at the end I want to thank you. I want to thank many doctors and scientists who participated in the discussion of this topic with me and who helped in make these conclusions more strict, more clear. And I want to thank Pavel Eksin and Nabil Arakcha for their contribution, which make this article based upon which this presentation was made free of charge for everybody. Thank you very much. Here my presentation ends. Dmitry, I thank you for your presentation. Let me give a small analogy. When during times of genomics and metabolomics we deciphered genome expecting to get answer to all the responses, but instead of that the old paradigm was broken and new paradigm is not yet present. And we have now much more questions than we were expecting to solve, to answer. Whilst listening to you, there is impression of that the paradigm should also be changed, and eventually the ovulation induction we are now achieving happens not thanks to physiological processes, but in spite of them. Absolutely right. What's your opinion? Are there sufficient grounds currently to assume that stimulation schemes should be cardinally changed? If so, should we go towards certain standards or towards individual approach, which doesn't assume to have separate standards? I believe the answer should be yes and no. I believe that the standard should be there. It is possible to create it, but these standards should be ranged for different patients group. There are unique cases to be considered individually, but what regards the duration of follicular phase, germ duration, I believe the epidemiologic data are reliable. We can be oriented on 14 days as a standard. As regards progesterone and stimulation changes, I believe that these changes should be not big ones, but they will result in very significant changes in the results of the stimulation and in the experience of the patient. What we are doing now, to say so, that regards frozen transport, it's very popular now. We have such an opportunity. We see that these transfers improve significantly the results in the sense of pregnancy. But we also see that unfortunately it disappoints a lot when the women are losing pregnancy with tested embryons by PGS, good embryons, everything is good, but if you think about it, we impose on women quite artificial chemical luteal phase. We deprive her of any chance to develop her own corpus luteum. I believe that at least part of this loss of pregnancy happens because the transition from artificial luteal phase to the control of placenta, to the control of pregnancy by the placenta is not always full-fledged. There is a certain transition between the corpus luteum and placenta. There should be something like that. And I believe that small changes are required in the protocols. Little changes. They require a better understanding of what happens. I believe we are very close to creating a full-fledged luteal phase which will not require any support at all for most patients. And coming back to your question, it will be standard as this luteal phase. If there are no defects of luteal phase, it's a separate case. This scheme will be absolutely standard. I would like to understand how the new paradigm will allow to have less side effects from stimulation. Accordingly, talking about progesterone, it's impossible to use it during stimulation because you use drugs, we do many things which will not allow us to use progesterone as a trigger during the artificial cycle, and we don't need it because everything is good in this sense. We use any trigger, it works well, and it has more to do with the term stimulation, meaning the creation of stimulation cycle lasting for a certain fixed time, which corresponds to the time of physiologic prenuclear phase. Here it is one situation, but what regards progesterone as a trigger, it can be used only if you don't have inhibited hypothalamus, if you don't use something to change the sensitivity of GnRH pathway, it is possible to use with time intercourse or with Clomid. It also can be done, but specifically for IVF, for stimulation, the progesterone is not possible to use as a trigger. Thank you, Dmitry. I would like to summarize a little bit this section. You know, the modern medicine and not only reproductology, the genetics are so highly commercialized that sometimes it's very difficult to separate the grains from the envelope. Even the specialists themselves cannot do it. We had 4 presentations today, but we managed to cover a very broad range, starting from cycle preparation, stimulation, and the whole cycle of embryologic laboratory, and to see the controversies, to see the pro and contra in all the approaches. I'm very thankful for it to each speaker. And eventually, we missing delayed remote effects, remote outcomes. Should we put stake on this in the next time? I thank once more to all the speakers, and we can pass to the final part. Thank you. I thank Dmitry for an interesting section. It was a gift from embryologists to all of us reproductologists, and at the same time it was a gift from the Association of Embryologists, because such a communication and the results of reproductologists we have to assess together. And we thank Dmitry Dozortsov from US. We thank all the speakers who joined this very interesting section, which very successfully concluded our symposium. Dear colleagues, unfortunately, 2 days have passed very quickly in such a very intensive work. I draw my conclusion, and I also advise to you, let us think over quietly all the pro and contras. Let's review certain presentations. Let us note certain points in the presentations to use them further on. I want to thank all our sponsors, all pharmaceutical companies who joined the possibility to conduct this symposium. A great I thank very much to our embryologists, the clinicians, everybody who participated and who watched our symposium. Write us. Write us. We are very interested to know your advices, recommendations, remarks. We are accepting everything. We want you to become better. Last year, there was a remark on that we paid little attention to embryology. We increased the number of embryologic reports, and yesterday and today they have been interesting and necessary. Please address to us. All together we shall do our work better, and our children will smile to us more and more. All the best, health, and meet you in the next symposium in offline mode. See you again.